So it's 3, 2, 1. We are live now, ma'am. Over to you.
Just a second, ma'am.
Bhuvneshwari, ma'am, we are live now. You can start the session.
Okay, good evening, everyone. Welcome to the PG update of our 6th annual state conference of FPA Kerala chapter, AFPICON Kerala 2022. So we are starting our PG update now. Our first session is starting now. And for our first session, we have Dr. Celine Kurivilla, who has over 25 years of experience as a healthcare professional that includes many years of working experience in various renowned hospitals in Singapore and India. She has completed her graduation from University of Mumbai. Dr. Celine went on to do her specialization in family medicine and fellowship in diabetes from CMC Vellore. She also completed her post-graduation program in diabetology from St. John Hopkins. She is certified in evidence-based diabetes mellitus course conducted by FPFHI. She is a life member of AFPA, Bombay Medical Congress, GP Association, IMA, and Medical Legal Society. Currently, she practices at St. Thomas Mission Hospital as senior consultant physician and diabetologist, and also visiting lecturer at St. Thomas Nursing School and Pharmacy College. She also runs her own private practice at Chris Dare's Family Medicine and Diabetic Healthcare Center, Pudupalli. Our chairperson, sir, Dr. S. Bhuvaneshwari. She is a family medicine consultant currently working in family medicine in PD Hinduja Sindhi Hospital, Bangalore. She has also specialized in diabetology and holds a distinct fellowship in diabetes management from CMC Vellore with a distinction in project and academic performance. This helped to start a diabetic clinic and translate her passion to provide a holistic care with a large number of poor diabetic patients without compromising on the quality of care. She has delivered multiple lecture sessions on various academic topics under the auspice of NBE and St. John's Medical College, Bangalore. She has been a faculty and coordinator for the DNP Family Medicine and guide for DNP residents. Our second chairperson is Dr. Anand Kay. Dr. Anand has completed his undergraduation from Government Medical College, Corticosteroids, and his postgraduate course in family medicine from Malabar Institute of Medical Sciences, Corticosteroids. He is presently posted as a casualty medical officer at General Hospital, Talasheri in Kerala Government Health Services. He is an executive member and faculty of Trauma Care, Kannur, and advisory board member of Kannur Dementia Care Society. He was the organizing secretary of the first state conference of Kerala chapter of AFPI held in 2015 and organizing chairperson for AFPICON 2022. He has chaired the sessions and has been faculty at various conferences of family medicine, besides playing organizing role in both national and state conferences. I welcome all of you to the conference. Over to you, Dr. Bhuvanesh.
Yeah, good evening, everyone. Thank you for giving me this opportunity. I request Dr. Celine to go ahead with her presentation.
Good afternoon, everybody. Jisha, can you hear me?
Yes, ma'am.
Yes.
Good afternoon. I consider it a privilege and honor to be the first speaker for our AFPI conference 2022. When I was given a choice, I chose to speak on headache because this is the commonest neurological symptom or the commonest symptom that we encounter in our day-to-day practice. Patients comes with the complaint of headache and they think that it can be treated by itself. It is a self-limiting disease, but it can be the only manifestation for a very serious life-threatening disease. So I choose this topic because I had to emphasize on the importance of taking a proper clinical history, as well as going into a comprehensive and holistic approach for treating the patient, because that is the essence for a family physician. Well, I would like to talk on introduction, the causes and red flags of headache, then the history and evaluation with the history and examination, the investigations, and just in brief touching about the common types of headache. To start with, as I said, that 90% of the patients, 90% of the people once in their lifetime has experienced an episode of headache. So it is any disease, the first presentation, if you keep a survey in your OPD, there will be hardly any patient that will say that he doesn't have headache. Any complaint, even now we see that the commonest complaint for Omicron is also fatigue and headache. So what is the mechanism for having an headache? It is because of the traction to the major intracranial vessels. There is distension, dilatation of the intracranial arteries. There's inflammation of the pain sensitive structures. There is pressure, direct pressure over the cranial or the cervical nerves. And there is sustained contraction of the scalp or the neck muscles, or it may be a referred pain. So what is the commonest cause of headache? It can be classified as primary headache or a secondary headache. If it is primary headache, the most commonest is the tension type headache, followed by migraine, cluster headache, some idiopathic or exertional headache. The secondary headaches can be because of any type of systemic infection. It can be bacterial, viral, fungal, anything. It can be because of head injuries, vascular disorders, subarachnoid hemorrhage, brain tumors, or it can be any causes ranging from substance abuse, psychiatric disorder, homeostatic disorders, hypertensions, because of various drugs that we give in our day-to-day practice, because of anemia, sleep apnea, glaucoma, carbon monoxide poisoning. There is 150 more than like any name it, and there are more than 150 causes for headache. Anything under the sun can be a cause for an headache. So when we go around, it is mostly due to the clinical assessment. We would like to focus on the clinical assessment, because I feel that headache is a disease which is very benign. And if you take a proper history and go around in a proper order, there is no need of investigations actually. So first and foremost, what you should know is the chief complaints of the patient. So the history taking is very important. Even if you have 5 minutes in your OPD, the most important is to know the duration of the headache, the mode of onset, the frequency of attack, the age at which it started, the location, the intensity, quality, the aggravating and the relieving factors, the diurnal variation, associated symptoms, whether the patient has a history of trauma. Whether we have time or not, it is very important that we document these things in our notes. And from this, the diagnosis is very clear. We have to go around asking their family history, their drug and medical history, their personal, social, psychiatric history, and their occupational history. Because a patient who has headache, the fear of having a second attack of headache, it is very disturbing for the patient. So it not only affects them, the repeated headache attacks not only affects him physically, but socially, financially, and also his occupation. So overall consideration is very important. Now, when we start the age of onset, if suppose there is a young patient, 20 to 30 years of age, usually migraine, tension type headache, cluster headaches are common. If it is a late onset, it is secondary headaches. Depending upon the intensity, if it is a moderate intensity or a headache, it is migraine. Or it is very mild, then you can think it to be a tension type headache. But if it is a very severe headache, think about cluster headaches or subarachnoid hemorrhage, or you go for a cerebral venous thrombosis, eclampsia, malformation. All these things you have to see. And then the location of the headache. You ask the patient, where is the pain? Suppose the patient is pointing towards the sinus area, it is because of sinusitis, or around the eyes, it is a cluster headache. If it is a band-like pain, squeezing band-like pain, it is a tension headache. Or if the patient, it is associated with pain, nausea, vomiting, then it is a classical form of migraine. Also the secondary headaches. If the patient is telling the pain is around the sinus area, frontal or maxillary sinus, it is a kind of sinusitis pain. Or if it is around the eyes, it might be a trochlear neuralgia or a pain from the orbits. Or if it is around the occipital nerve, there is pressure over the occipital nerve, it might be occipital neuralgia. Pain around the neck, it might be because of it may be a cervicogenic headache, or it may be a TM joint. just a TM joint dislocation, it can come as a referred pain. Or there may be pain over the temporal arteries, then you have to think of giant cell arthritis. Same way, if the patient is complaining of pain in the oral cavities, you have to think of referred pain from the tooth or from the tonsillar fossa. Now, then comes the duration. It is very important to ask for how long does the pain last, whether it is, if it is migraine, it is from 4 to 72 hours. If it is a tension headache, it can last anything up to 7 days. Cluster headaches, it usually comes from few seconds to minutes. Then what is the frequency with which they get the attack? If it is 1 to 4 attacks per month, it is usually a migraine. If it is it comes once a month, or around, it lasts for 15 days a month, all this type of headaches are tension headaches. But if it is coming at small intervals and lasts for seconds and 1 to 8 attacks per day, then you have to think of a cluster type of headache. Now, then you have to ask the question, what are the aggravating and the relieving factors? Usually, the patients with migraine, they have aggravating factors. They will say it is because of some kind of food, light, stress. Females usually have during menstrual cycle, and the relief is by sitting in a very dark room. And cluster headache is usually because of some by taking alcohol or nitroglycerin, all these things. Now, tension type of headaches. Tension type of headaches, aggravating factor can be anything. Like my husband always says that there is always a tension besides me constantly for last many years. So the aggravating factor can be anything. But the relieving factors are rest and medications. The associated symptoms are important. You have to ask whether they have nausea, vomiting, which will point towards migraine, or it might be increased intracranial tensions or infection. There can be autonomic symptoms in cluster headaches. If there is a visual field defect, you have to think about increased intracranial tensions, pituitary tumors, whether there is any aura or there is any prodromal symptoms. Then after taking a proper history, along with that, it is very important to know about the social history, the financial history, the family history, occupational history. All this we have to keep in mind. Then we have to go for a physical examination of the patient. The proper physical examination has to be done. All the vitals have to be monitored, his eyes, everything has to be checked properly, including his apart from the toe, tree, oral cavity, everything has to be checked, though the patient is presenting with an headache, because it could be a referred examination. Then a proper general examination has to be done so that we don't miss out anything, many other infections, because headache might be just a manifestation of any other disease. Then going on to the neurological examination, it is very important to know the mental status of the patient. You have to do a proper examination of the cranial nerves. All the motor examination has to be done, the sensory and the reflexes has to be seen. Now, when the patient presents, the most important thing is that when the patient presents with secondary headache, you have to know the SNOOP, that there is, whether there is any systemic signs and disorders, whether there are neurological symptoms, whether there is the onset is new or change in a patient over 50 years of age, whether there is onset of a thunderclap presentation, and patient's presence with papilledema, pulsatile tinnitus, positional provocation is there, or it is precipitated by exercise. We should all be careful about the red flags in headache. This is the thing when we will refer the patient. So if the patient says that this is the worst headache of my life, or there is a new onset of headache, or the character of the headache has changed, or he is waking up from the sleep, or it is associated with other symptoms of fever, then we have or any neck rigidity or thing, we have to think about meningitis, or it is changing with position or coughing, if the patient is immunocompromised, or they are having history of cancers. These are the things that it's a red flag and you have to refer the patients. Also, while examining the patient, if the patient has high BP or papilledema, or there are signs, meningeal signs are there, or there is a temporal artery tenderness, there is neurological defect, if there is signs of glaucoma, these are the things that should alert you to refer the patients. Now, when you want to evaluate, as I said, first you have to take a proper history and examination. If there are you don't find any red flags, it will be, you have to classify it as a primary headache and then do a preliminary diagnosis for that. If there are red flags or you find that, then it goes on to a secondary, or you have to see whether it is a secondary headache or atypical features are there. Then you either refer the patient or you send it to the patient to the concerned department, or you do a diagnostic testing. Now, when And most of the, as I said, when you take a proper history, the headaches can be diagnosed even without much of investigations. But it is important that you first do all the routine tests, that you do a CBC. I don't go into the test that, because that everybody knows, that you do the routine test, and as per your history and as per the need and examination of the patients, whatever special test, if suppose if you think of a malaria, you'll do a PS4MP or accordingly, or if you feel that the patient needs a lumbar puncture, a CSF examination accordingly, or you go in for a imaging. So if suppose you can actually take for certain cases, all the cases doesn't require CT and MRI. But nowadays, any patient coming with headache, we send them to a neurological department and to the specialty, and every patient undergoes a CT or a MRI. Even a plain X-ray, if it is just subluxation or due to rheumatoid arthritis or cervical spondylosis, all these things, or there is a TM joint dislocation, all these things can be identified by a simple plain X-ray. Usually, I'll prefer CT scans if there is a fracture or you want to diagnose some paranasal sinus. MRI will be preferred if there is a vascular injuries, or there is a tumor, or there is pituitary tumors, carcinomas, if there is a vascular malformation, if there is cervical spine lesions, all these things. Of course, we have to do a MRI. There is a American College of Radiology recommendation in which cases that MRI is preferred with or without contrast. For example, in immunocompromised patients or patients older than 60 years of age and you are suspecting a temporal arteritis, or patients with meningitis. In that cases, you do either a MRI or a CT. And if there is a severe headache in pregnancy, or patients with dissection of the carotid or the carotid arteries, or there is the patient says that this is a worst headache, so you have to suspect a aneurysm rupture. In such cases, you have CT and MRI is of course preferred. And then sometimes you have to send the patient, if in your initial evaluation you cannot have a proper diagnosis, you have to send the patient to an ophthalmology, dental, or ENT department, because they might need further testing like their visual testing, tonometry, or they might need examination of the sinuses. Now, to talk in brief, since the time is running out, I will just touch in brief about the primary headaches. The most important is the migraine headache, which we see it very commonly. Usually, patient will be before the age of 40 years. So they will present with some visual or neurological symptoms. So they will be having an aura. Such is the classical migraine. Sometimes there will be no aura. That is the commonest type of migraine that we are seeing. So the diagnostic criteria is that at least there should be 5 attacks. And they should be fulfilling all the criteria, that it should be lasting from 4 to 72 hours. And at least they should be having this characteristic. It should be unilateral in location. It should be pulsating quality. There should be moderate or severe pain intensity. And it is aggravated, or it may there should be 5 attacks. And there should be routine physical activities. And at least they should be having this characteristic. And during the headache, the patient will be having nausea, vomiting, phonophobia, photophobia, and it is not attributed to another disease. Well, I will not go into detail about the management. Usually, prophylactically, we treat the patient, or we give something like analgesics, ergometrin, or somatropin for abating the pain. If it is a tension type headache, usually at least there will be 10 episodes in a month, or sometimes they will be having only 1 to 10. It can range from any number, and it may last from 30 minutes to 7 days. And it is usually a band type of headache with bilateral location. It is mild to moderate severity. There may be pressing and tightening quality. It will not be aggravated by routine activities. Just hold on. Hello? Clinic okay. I'm so sorry. There'll be no, in tension type headache, there will be no nausea or vomiting. There will be no photophobia or phonophobia. And then we go on to the cluster headaches. Cluster headaches, usually it is very severe and it is unilateral orbital, supraorbital. It may be lasting from few seconds to minutes, and it is accompanied by either one eye, there will be conjunctival injection or lacrimation, there may be rhinorrhea, there may be eyelid edema, there may be forehead and facial sweating, there may be meiosis or ptosis, and the patient will be very restless. So they have these attacks have a frequency every other day. Talking about trigeminal neuralgia, it is usually affecting the nerves, and the trigger zones are around the cheek, nose, mouth, and there is tenderness when you touch, by the wind, talking, chewing. And usually it is young patients with bilateral symptoms or abnormal examinations. So I will just try to summarize that. First thing, it is very important that you have a proper diagnosis. Again, I will emphasize that it is very, very important that you go and take a proper history, even if your OPD time is limited. But instead of wasting the patient's money on doing much investigations, if you invest that time in taking a proper history, asking all the questions, we can come to a diagnosis. Headache, it can be a very benign disorder, but we have to always keep in our mind what are the red flags. And if the red flags are there, we have to refer the patient. Then what are the dangers? That is, the red flag should be there. Then what are the ditches? What are the pitfalls? What can we miss? Herpes zoster, such kind of things we can miss. And what are the deceptions? And then when you go into a deceptions, usually if patients has hypoglycemia, or patient is having some thyroid disorder, sleep apnea, or urinary complaints, all these things can be missed, and these are the deceptions. Then when you go into a deeper diagnosis, it's not only the clinical assessment of the patient, but it is the individual assessment of the patient. It is very important to know the patient as a whole. And you should know where the patient is working. What is the condition? What is the background condition of the patient? What is the drugs that the patient is taking? So this 3-stage assessment. Then the contextual assessment of the patient is also very important, so that we can do a comprehensive and holistic approach to the patient and treat the patient accordingly. So I think I'll just finish up here, and well within time. So yeah, thank you so much.
Thank you, Dr. Selin. That was a wonderful class. Thank you for enlightening us about how to approach a case of headache, and also reminding us about the importance of a detailed history taking and clinical examination for the same. Thank you so much once again. Over to Dr. Bhuvaneshwari.
Thank you, Dr. Selin. It was an excellent, comprehensive, very crisp presentation from a family physician point of view. I have a question for you. So we are in a busy OPD. What are the 3 or 4 basic simple tests to assess quickly whether the headache is primary or secondary?
Yeah, first of all, I told you, the main thing is that you have to ask the history. In history, we will come to know that whether it is a tension headache or migraine headache or a cluster headache. It is very easy that we come to know. Other than that, also the general examination of the patient is very important, because if it is a benign thing, you can also always assess the patient in the next OPD. But if the blood pressure, if suppose the patient is hypertensive, or if the patient is having glaucoma, all these things are very important that we cannot miss. Or nowadays, we don't look into there is a referred pain. So many times the patients will be having referred pain. So the examination of the patient as a whole is very important. So I think again and again, I will emphasize that history taking is important, at least for headache. That was the reason I choose this topic, because more or less we are forgetting on that, and it's not a mistake of anybody. It is in our busy OPD, every other patient will come and say, I have a headache. In fact, long ago, I had a patient who came and said to me, Dr. Saab, mere pet mein sar dard ho raha hai. I mean, I have a headache in my stomach. So all the pains they will attribute to headache. Any pain, they are saying headache. So when you are specifically asking them, then only they will come out. So you have to, because there is no point in doing all the expensive tests or the CT scan or the MRI. So it is very important that you do a proper history taking for this patient. And then you will have a preliminary diagnosis. And according to that, we can move on.
Actually, we should not forget to check their blood pressure.
Yes.
And also do a simple fundus examination to
Yes.
look for any papilledema, for
Yes.
extraocular movements. Okay. And also quickly examine to look for any next step.
Neurological deficit
This
also.
will basically, help us to differentiate quickly between a primary and a secondary headache.
Exactly. Yeah.
And also, of course, you have covered asking a full detailed history, especially regarding the drugs. So many people are on, so it is like a polypharmacy. So we have to take a quick history, including the drugs. So
exactly. Yeah.
we don't miss anything on that.
Because nowadays patients themselves take steroid, they take aminophylline. There are so many drugs that they don't say. Over-the-counter medicines, including both allopathic, Ayurvedic, any other medicines they take, which we are not sure what is the content of that medicine. So there might be some triggering factor in those medicines. So it is very important to know what all medicines the patient is taking and make a note of that. And documentation is very, very important. I have to emphasize this, that you have to document, even if you are busy, whatever it is, please document and keep what all medicines the patients are taking. So that tomorrow, if something comes up, at least you have a documentation on your side that this might be the cause.
Yeah, thank you. In fact, I had a patient similar, like you have covered that also. She had come with a headache, very bad headache since 2 months. Was morbidly obese and no other comorbidities actually. So I admitted her, but one day after the admission, her saturation was around, it was sort of desaturating. It was 86, 90. So quickly did a ABG. It was like a severe respiratory acidosis. So she had a sleep apnea. And because of that, her, headache, that was the main complaint for her. We could put her on a BiPAP, the headache got resolved, and quickly did a sleep study, all that. Finally, she, she felt she was like a new person from that day onwards.
Yeah.
As you said, we have to have a correct, history and also a quick examination, basically to differentiate whether it is primary or secondary headache.
And the relief that they get from the headache, they will never stop thanking you, only the patient who suffers from that headache will know that what is the relief they get when they get cured of that headache, because the fear of getting that second headache is like constantly in their mind. So though it sounds to us that it is a simple headache, for the patient is really very terrible.
And also about the prophylaxis for migraine, what is the duration? Because that is it is a gray area. So people say it is 3, 6 months, 9 months. What do you feel?
Usually what I will keep the patient on a beta blocker. So most of the times they are hypertensive. So I will try to give them a beta blocker, propranolol or anything I'll start. And I have seen that the patient is relieved. And also if they are put on amitriptyline, so they can take it for some time. This migraine patients in the night, they will get proper sleep also. So I keep them for 3 to 6 months. So by 3 to 6 months, they get relieved. So there is no harm. Our small dose of beta blocker is okay. You can go on for 3 to 6 months. They themselves taper it off when they are better.
Yeah. How do you manage migraine in pregnancy?
Usually when they come, I will try to give only NSAIDs that time. I'll just try and give them some drugs by simple paracetamol and all, and I'll make sure that it is migraine only. But if they are coming in the later trimester, you have to be careful. You cannot tell everything is migraine and leave them. That is so. Pregnancy, as I said, it is a red flag. See, the patients with pregnancy cannot be just taken, okay, pregnancy, headache in pregnancy cannot be taken. So if the patient has a previous history of headache and or migraine, then, and usually I will just try to treat them with a simple analgesics. That is what I try and do.
Only paracetamol.
Yeah, mostly that only.
Mostly paracetamol.
Paracetamol, yes.
Because we can't give the triptans. So
yes, we cannot give the triptans. So, and pregnancy is like another thing, you have to be careful.
Yes. I don't think we have any questions in the chat box. Do we?
Yeah, I'm happy that I covered it in time. I was a bit worried, being the first speaker, I didn't want to exceed the time.
It was very much in time, and you covered most of it actually. The approach to headache from history and investigations, all that you covered very nicely. It was a very crisp, wonderful presentation.
Thank you, ma'am. Thank you so much. Okay.
I think there is a question. There is a question in the chat box from Dr. Swapna, I think. Are you seeing headaches associated with increased screen use, especially among adults, adolescent adults? If yes, how are you managing them?
Yeah, there is a lot of headaches in COVID time. Every other patient that I see, they are saying that headaches are there, mainly in children. Lot of, not only children, in fact, I have to say that I am seeing this in elderly, and this headache, they are not only coming with the refractory error. I have seen patients with cervical spondylosis. Lot of aged people now, they are very used to see mobiles, and they are looking at the Netflix and all other serials and everything. So they are looking down and bending in the mobile. So after some time, I realized that it is a cervical spondylosis more than headache, and it is a referred pain, and their timings of eating, everything is upset. So yes, it's very true that now, because of the increased screen time, there is lot of, that is because refractory error is there. So in children, I am seeing a lot. In adolescents, because the people who are working also, it is increased. But to my very surprise, I'm seeing it in older people. I have seen patients, relatives coming and telling that the older parents, they are finding, like children, they are coming and telling, please doctor, tell these people to use the mobile less. But they are using the mobile more. And
correct, yeah.
One. It is cervical. They are bending down and seeing. So one day, 3-4 movies they will see. Like that, they are now.
Okay. Ma'am, I'm really sorry to interrupt, but we're running out of time.
Yeah, sure. Okay. Okay. Have a good day.
Thank you.
Thank you very much. Thanks.
Thank you.
Bye.
Okay. So next we can go to our next second session. Yeah. Our next session is about how to formulate an asthma action plan. And the speaker is Dr. Asha Thomas. Dr. Asha graduated from Guwahati Medical College, Assam, and completed DNB Family Medicine from Medical Trust Hospital, Cochin. She's currently working in Medical Trust Hospital, Kochi. Over to the chairpersons.
A very warm good evening to all of you. Today I will be talking on the latest guidelines which the Gina has advised, the 2021 guidelines for asthma management. So what we have is, what is the goals of asthma treatment? The goals are broadly divided into two: the symptom control, where the patient should have fewer asthma symptoms. There should not be any exercise or activity limitation, and there should not be any sleep disturbance. Patient should not, an asthma attack should not wake the patient from his sleep, firstly. Risk reduction. Risk reduction is, we try to maintain normal lung function in the patient, prevent exacerbation, prevent asthma deaths, and avoid medication side effects. These are broadly the goals of asthma treatment. And what are the treatment options? In our, the drugs which we have for asthma are broadly classified into 3 categories. We have the controller medication or the maintenance medications. We have the add-on controller medications and the reliever or the rescue medications or the emergency medications. So now coming to each one of them. In our controller medications, what we have is inhaled corticosteroids, the most common ones used: beclomethasone dipropionate, budesonide, fluticasone. We have the inhaled corticosteroids, long-acting beta-agonist combination, of which beclomethasone formoterol has the maximum evidence for effectiveness. The other combinations used: budesonide, formoterol, fluticasone with formoterol, salmeterol, or with vilanterol. We do have leukotriene modifiers also. The commonly used ones, montelukast and zafirlukast, and chromonomes, sodium chromoglycate, and nidochromin sodium. Coming to the add-on controller medications, we have the long-acting muscarinic agents, tiotropium, which are only used in the later stages of our asthma management. They don't come in the initial stages. Then we have the biological therapy. In biological therapy, one of the first drugs which was approved by FDA in 2003 was omalizumab, which is an anti-IgE, and it is used in severe allergic asthma, which is not controlled on even high-dose steroids. Then we have the mepolizumab and the reslizumab, which are anti-IL-5 and anti-IL-5R receptors. These are used in severe eosinophilic asthma, again, which are not controlled on high-dose inhalational steroids. Then we have the dupilumab, which is an anti-IL-4 receptor. This is again used in severe eosinophilic asthma, and this is one agent which can be taken by patients at their home. The major side effect of all this is that it is very expensive treatment. Then we have the most commonly used systemic steroids, which we use in asthma, prednisolone, methylprednisolone, and hydrocortisone. As rescue medications, we have short-acting inhaled beta-2 agonists, the commonly used ones, salbutamol and levosalbutamol. Then we have the low-dose ICS formoterol combination and short-acting anticholinergics, ipratropium. So these are the drugs which we have for management of asthma. For inhalational steroids, this is just a rough idea about the dosage. Beclomethasone on a low dose means it's we're using somewhere between 100 to 200 microgram, and if it goes to high dose, we're using more than 400 micrograms. Budesonide, we're using 200 to 400 for a low dose medication, and high dose it goes up to 800. Fluticasone between 100 to 250 micrograms and a high dose of more than 500 micrograms. These are the commonly used ones. Now, coming to the Gina Guidelines of 2021 for the management of asthma. This Gina Guidelines, which I'm going to discuss here, is only for the adolescents and adults. Childhood asthma is a completely different guideline, which I'm not covering here today. So for the Gina Guidelines, there are two approaches to management. There is a track 1 management and a track 2 management. As per Gina Guidelines, track 1 is preferred approach and must be followed in all patients, and track 2 has been set aside for exception cases, which I'll come with later. So in the track 1 of management, we are using here, again, it's the cornerstones of therapy here are the reliever therapy and the controller therapy. Now for track 1, the reliever therapy for all the steps is low-dose ICS formoterol combination. This is what is the reliever therapy or the rescue therapy for all the steps of track 1. So in track 1, the steps 1 and 2 are combined, which are symptoms which are there for less than 4 to 5 days a week. Gina does not suggest any regular medication. As and when needed, low-dose ICS formoterol can be used. Coming to step 3, where the patient has got symptoms on most days or wakes up with asthma once a week or more. In this case, we have to use a low-dose daily ICS formoterol treatment. That is for step 3. Step 4 is the same as step 3, except that in step 4, the patient also has a low lung function. In this case, the patient will need a medium dose, daily dose of ICS formoterol, a medium dosage. Step 5 is severely uncontrolled asthma. It's at this stage, at this step, we can actually, as family physicians, we can actually refer the patient to a specialist or a specialist center where the patient can be given the option of a biological therapy. Or we have the option of adding on a LAMA, adding on an ICS formoterol, high-dose ICS formoterol combination. So these are broadly the 5 steps of track 1, where we are doing we start with a low-dose maintenance therapy, and gradually as the disease severity is rising, we are increasing from medium dose to high-dose therapy. So this is how the track 1 stages are. Now we go on to track 2. So track 2, again, there is a difference in the reliever or rescue therapy. This is the main difference which we have from track 1, because here the rescue therapy is a short-acting beta-2 agonist. So this is the reliever therapy of track 2. Here all the steps are individually kept. There are no combination of steps. In step 1, the symptoms are present in happen less than twice a month. In this case, the patient has to take an inhalational steroid whenever SABA is also taken. SABA is never advised to be taken alone, even in step 1. In step 2, symptoms are occurring twice a month or more, but it is less than 4 to 5 days a week. In this case, we have to go for low dose ICS. In step 3, again, here the patient also, along with the symptoms are happening on most days, along with that, patient is also waking with asthma once a week or more. In this case, we put the patient on a low dose maintenance ICS LABA combination. For step 4, the difference is again that the patient has a low lung function, otherwise it's same as step 3. In this case, we will either go for a medium or we can go for a high dose maintenance ICS LABA. For step 5, which is again severely uncontrolled asthma, here from track 1 and track 2 are almost the same way. You can add on a LAMA. We can consider giving a high dose ICS formoterol combination, or we can either refer the patient or consider biological therapy for this patient. So this is broadly track 1 and track 2 of asthma management as per the Gina guidelines. Now, what is the reason that we've come to this ICS formoterol combination? It's been known from various trials that it reduces the risk of severe exacerbation. ICS formoterol, there is one particular thing to be noted with this ICS formoterol combination is that if the patient has been taking a different ICS LABA for their controller therapy, then as reliever, you did not use an ICS formoterol. The patient is already on a different ICS LABA, so there is no need to add on an ICS formoterol as a rescue therapy. So this also means that ICS formoterol can be used both as reliever therapy and controller therapy from step 3 onwards in track 1. Then what is the risk? Why does Gina not suggest only SABA treatment? The risk is there. The risk is what it has seen is that even SABA, when it is used for as smaller duration as 1 to 2 weeks, has been associated with various adverse effects: beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response, increased allergic response, increased eosinophilic airway inflammation. So what happens when ICS is added? When inhalation steroids are added, it has been seen that there is reduced number of asthma deaths, there is reduced frequency of hospitalization, and there is reduced frequency of exacerbations which require oral steroids. So now, when do we follow track 1 and track 2? So as I said earlier, track 1 is to be followed always. When do you think that the patient can be put on track 2? When track 1 is not possible, shortage of medicines during COVID, issues like that, we can think about putting the patient on track 2 management. Or the patient prefers management with track 2 medications, or the patient is already well controlled on these track 2 medications, so we did not change the patient. Patient 2 or track 1. Gina emphasizes on personalized management of patients. There's no one treatment which is going to suit everybody, so personalized treatment of asthma. That's one thing which has been mentioned in Gina 2021. So when the patient is, suppose you're putting the patient on track 2, before prescribing a regimen having a SABA reliever, we have to make sure that the patient is compliant and will take an ICS containing controller therapy. Because if they are going to be poorly compliant, there will be a higher risk of exacerbation. Now, one thing which has come up in the Gina 2021 guideline is the add-on azithromycin treatment in step 5. So what Gina suggests is azithromycin 3 days a week can be considered in patients on step 5. Okay. As it is known to significantly reduce the exacerbation in patients taking high-dose inhalational steroid-LABA combination. It is also known to significantly reduce exacerbation in patients with eosinophilic or non-eosinophilic asthma. There is no specific evidence published for azithromycin efficacy or effectiveness in patients taking medium dose inhalational steroid-LABA combination. So it's mainly for high dose ICS-LABA combination or patients with eosinophilic, non-eosinophilic asthma. So now how we've already put the patient on a track 1 and track 2. How do we monitor these patients? This chart which I'm showing you, this slide, is basically just come up in the Gina 2019 guideline about asthma control. Here we're supposed to assess the patients after a month, and we should ask the patient this particular set of questions, and the answer to this will be a yes or a no. So the questions are, is the patient having daytime symptoms more than twice a week? Is there a requirement to use a reliever more than twice a week? Is there any nighttime waking up due to asthma? Or is the patient having any exercise or activity limitation due to asthma? These answers, the answers to these questions should be a yes or a no. So if all the answers are no, the patient is well controlled. 1 to 2 of these, the answer is yes, partly controlled. And if 3 out of 4 or 4 out of 4 questions have yes as an answer, it is uncontrolled, and the medications have to be adjusted accordingly. So this is about the guidelines. Now a little about our favorite topic these days, COVID-19 and asthma. COVID-19 with anything is favorite these days. So what does Gina have? These are the guidelines which are published on 26th of April 2021. So then what, the questions which patients usually have. Are patients with asthma at an increased risk of COVID-19 or severe COVID? The answer is no. Are asthmatics at an increased risk of death due to COVID-19? This question has got 2 parts as an answer. If the patient is having a well-controlled asthma, no, there is no increased death rate due to COVID. But if the patient has recently required oral corticosteroids, has had a recent exacerbation, a recent admission with step 5, then the answer is a yes. Yes, there is an increased death due to COVID-19. What are the implications of asthma management in COVID-19? It's just that maintain a good control, reduce the risk of exacerbation, and minimize the need for usage of oral steroids. So, and are there more asthma exacerbations during the pandemic? No, in 2020, actually, many countries showed a reduction in asthma exacerbation and in influenza-related illnesses. Reasons are not precisely known, but it might be due to the COVID protocols of wearing masks and sanitization and social distancing travel. So about COVID-19 and asthma medications. So patients should be advised to continue taking all their prescribed asthma medication, particularly inhalation steroids. For patients who have been advised biological therapy and inhalation steroids, everything can go even in the COVID-19 times. And are inhalational steroids protective in COVID-19? Inhalational corticosteroid use in asthmatics has been associated with lower mortality than in patients without an underlying respiratory condition. This was something which came out in the Lancet of 2021. All the patients must have a written asthma action plan, and they should be advised, guided. They should be known when to increase the controller and reliever medications when the asthma worsens, to take short course of oral steroids for severe exacerbation. They should be advised, and there should be a clear asthma action plan. Avoid nebulizers wherever possible to reduce the risk of spreading the virus. Pressurized multi-dose inhalers via spacer is preferred except for life-threatening conditions. Adding a mask or a mouthpiece to the spacer if required. Now, COVID-19, broadly what we need to keep in mind is avoid spirometry in patients with suspected or confirmed COVID-19 or if the community transmission is occurring in our region. Consider asking patients to monitor their PEF at home and follow strict infection control procedures if aerosol generating procedures like nebulization, oxygen therapies, glutamate induction, etc. are needed. And above all, please follow local health guidelines which are available in our region. Coming to COVID-19 vaccines and asthma, vaccines are safe, allergic reactions are rare, and if the patient has a fever or any other infection, we can delay the vaccination until they are well. If there is a history of allergy, it is always safe to take vaccine in a tertiary care center or in a center where anaphylaxis reactions can be managed. About biological therapy, Gina only suggests that biologic therapy and COVID-19 vaccine should not be administered on the same day, just because we don't know which the patient is reacting to. And even after COVID-19 vaccines, all COVID protocols should be followed. Influenza vaccine is a must in asthmatics. Only thing, a gap of 14 days between the COVID-19 vaccine and the influenza vaccine is recommended. So coming to the summary of what I've said so far, there is no option of an only SABA treatment. Only SABA treatment is going to increase the risk of exacerbation. The mainstay of asthma management is inhalation steroid formoterol combination. If asthma is well controlled, COVID-19 does not increase mortality. COVID-19 does not differentially affect asthmatics, and all asthmatics should be vaccinated against COVID-19. Thank you all for your patient listening. Wishing you all a very happy and peaceful New Year. And thank you so much to the President and Secretary of AFPI Kerala and the organizing committee for giving me an opportunity to present at this session. Thank you so much.
Thank you, Dr. Asha, for the wonderful class on the management of bronchial asthma. Due to personal reasons, Dr. Asha is not available, and this was a pre-recorded session, so we wouldn't be having a question answer session. So all those who have doubts or questions, please do post them in your in the chat box below, and the answers, the doctor will get back to you on the website. The answer will be displayed on the website at a later date. Over to you, Dr. Anand.
Yeah, thank you. Dr. Asha's session was good. The one thing I'd like to, am I audible, by the way?
Yes, you're audible.
Yeah, one thing I would like to stress is the use of spacers. The use of inhalers needs some amount of training, some amount of IQ and understanding to use the right technique, because many a times failure of inhalers is because of wrong technique. So that training needs to be it should be ensured that the person is able to follow the instructions properly and use the inhaler in the right way. And advocating the use of spacers will go a long way in producing better results, especially when the patient is a child, in cases of children. And as regards Dr. Asha's presentation, she has very meticulously and thoroughly gone through the entire spectrum of use of inhaled corticosteroids and bronchodilators. And I think that was a very well presented session. Thank you.
Okay, next I'd like Dr. Bhuvaneshwari to comment on the class.
Yeah, it was a very brief and very nice comprehensive presentation on asthma management. As correctly she has mentioned about the stress on the use of inhaled corticosteroids. So we have to, and we have YouTube videos actually, like Dr. Anand was telling, we have to ensure that they use the rotahalers or the spacers properly. So there are educational videos available. In fact, we show the patients to view the video again and again. Now, because of COVID, we are not able to, literally demonstrate in person. So we do teleconsultation. We tell them to watch the video so that they understand and use it effectively. So It was an excellent presentation by Dr. Asha. Thank you. Thank you for the opportunity given. I don't think we have any questions in the chat box, right?
No questions so far. Our next session will be commencing only at 5 p.m.
Good evening, all. Good evening, all. Am I audible?
Yes, ma'am, you're audible.
Our next session is on Livilla Vidaloka. The speaker is.
Ma'am, can you please be louder?
Okay. Good evening, all. Our next session is on Livilla Vidaloka, decision making in lifestyle diseases. Our speaker is Dr. Nina Jacob. Dr. Nina Jacob did her MBBS from Government Medical College, Ernakulam, and has completed DNB Family Medicine from Luth Hospital, Kochi. She is a life member of AFPI. Dr. Nina has presented posters at various conferences. She is currently working at Medland Healthcare, Tiruvalla. Our next session will be chaired by Dr. Jaya Bajaj and Dr. Zarin. Let me introduce them. Dr. Bajaj is a US trained family physician with strong belief in blending old-fashioned patient care with new-age digital technologies that can empower patients and lead to better outcomes. She has over 20 years of experience and believes in a holistic approach to patient care with strong focus on wellness and prevention. She is a health technology enthusiast and is a strong advocate of the right use of technology for better patient care. Next, Dr. Zarin. She is graduated from Government Medical College, Trivandrum, and pursued her DNB in Family Medicine from Luth Hospital, Kochi. After completing DNB, she joined as the academic coordinator and family medicine specialist at KIMS, Trivandrum, after which she worked with the Ministry of Health in Kingdom of Saudi Arabia for 3 years. She has also done her MRCGP from Royal College of General Practitioners, UK. She is currently pursuing her master's in clinical research at Boston University School of Medicine at Massachusetts in US. Dr. Zarin was the founder secretary of AFPICON Kerala chapter and continues to serve as the advisory member of AFPI Kerala. She is also current chief editor of AFPI Kerala newsletter. She has various publications to her name and has been instrumental in all activities of AFPI Kerala. I welcome Dr. Nina Jacob and Dr. Jaya Bajaj and Dr. Zarin to the AFPICON 2022 platform. Now it's off to you, ma'am.
Am I audible?
Yes, ma'am, you're audible.
Okay. Good evening, all. My topic is decision making in lifestyle diseases. As you all know, it's a vast topic. So we will discuss some common scenarios that often come across in our OPDs, and we will discuss the what decision to make in each scenario. let's go to my slide. The first scenario is 35-year-old male, IT professional, married, non-smoker, consumes alcohol occasionally and having a sedentary lifestyle. He is having class 1 obese and on his blood parameters shows FBS 120 and HbA1c 6.4. This scenario is a we'll discuss about impaired glucose tolerance scenario. And to diagnose this, the fasting plasma glucose comes in the range of 110 to 125 in WHO and NICE guideline. When ADA guideline shows between 100 to 125. 2 hour oral glucose tolerance test comes in the range of 140 to 200 milligram per deciliter, and HbA1c comes in range between 6 to 6.4. It diagnosed as impaired glucose tolerance. The risk factors that for impaired glucose tolerance is obesity and first degree relative with type 2 diabetes mellitus. The management for impaired glucose tolerance is to aim for not progressing towards type 2 diabetes mellitus. So in management, the first and foremost step is the lifestyle modification, which includes the weight reduction in total fat intake, and to include low glycemic index source of carbohydrate, and to increase the intake of dietary fiber, and to increase the physical activity. If we are only maintaining in lifestyle modification, we have to reassess weight, BMI, FBS, and HbA1c at least once a year. Whereas if the patient still progressing towards type 2 diabetes despite having intensive lifestyle modification, we can prescribe metformin. Before starting metformin, we have to assess, renal assessment should be done, and we can prescribe metformin for 6 to 12 months and then monitor FBS and HbA1c every 3 to 6 months. If the patient BMI is more than 28, we can consider starting orlistat to improve impaired glucose tolerance level. The next scenario, a 42-year-old female with a first degree relative of having type 2 diabetes mellitus, now complains of having unexplained fatigue, frequent urination, recurrent vaginal infection, and her BMI is 35, and her blood parameter shows FBS high, 2-hour OGTT high, and HbA1c above 6.5 with normal lipid panel. So in this scenario, it's a newly detected type 2 diabetes with fasting glucose more than 126 and HbA1c over 6.5. So for management for a newly diagnosed type 2 diabetes, we have to make an individualized approach for diabetic care, taking into account the personal preference, comorbidities, risk from polypharmacy, and the benefit to get from a long-standing controlled blood sugar and any disabilities she may face, like visual impairment, and can offer a structured program or education to patient, not only to patient, but also to the caregivers at the time of diagnosis and throughout the period of having contact with her, which includes proper diet control, reducing the glycemic, high glycemic index intake, increase the fat, reducing the fat intake, high fiber content, then increase the physical activity and to reduce the weight. So for the drug control, for the drug management, if her HbA1c is not getting controlled despite intensive lifestyle modification, so we have to start the first initial therapy with metformin to control the HbA1c. Still, if after having metformin prescribed, if still the HbA1c rises above 7.5, we have to intensify the therapy with dual therapy, metformin with DPP-4 inhibitor or pioglitazone or sulfonylurea. Still, after continuing with dual therapy, if your HbA1c not targeting below 7, have to intensify the therapy to triple therapy or insulin-based therapy. And after starting the treatment, how we will monitor the HbA1c? Until HbA1c becomes stable with unchanged drug, have to monitor every 3 to 6 months. Once HbA1c is stable, we can monitor it every 6 months. The HbA1c can be relaxed for those having a reduced life expectancy. For them, our aim of management is to prevent the infection and those having high risk of hypoglycemia. And the third scenario is 66-year-old widow with having long-standing diabetes, class 2 obese, and osteoporosis after treatment for breast cancer. Her recent checkup showed HbA1c increased to 8% and having a slight kidney function decline with EGFR with a glomerular filtration rate of 65 ml. So in this scenario, we have to deal with a long-standing uncontrolled diabetes with CKD. For a long-standing uncontrolled diabetes, as we all mentioned, if her HbA1c is more than 7.5, we have to intensify the therapy and before that we have to check whether her lifestyle pattern is modified and she's adheres to the drug treatment. If she is strictly maintaining the drug adherence, we can intensify the drug to triple regimen or an insulin can be started. In this scenario, her eGFR is 65, so we should be more cautious with metformin administration. If her eGFR is metformin is contraindicated or not tolerated, we can use other ADAs like DPP-4, pioglitazone, and sulfonylurea. And to intensify, we can use combination with DPP-4 and pioglitazone, DPP-4 inhibitors, and sulfonylurea. And for second intensification, we can use insulin. And in CKD patients, we have to assess the proteinuria using urine albumin creatinine ratio. If urine albumin creatinine ratio is more than 3 milligram per millimoles, we have to start ACI inhibitors or ARB. ACI inhibitors and ARB are actually kidney protective and effective in preventing or slowing the process of renal disease in diabetic nephropathy. And where urine albumin creatinine ratio is more than 30 milligram per millimoles, we have to consider using SGLT2 inhibitors like capagliflozin, dapagliflozin, because they have the ability to reduce the risk of CKD progression and the cardiovascular risk in adults with diabetic nephropathy. In the fourth scenario, a 48-year-old government official who was diagnosed with type 2 diabetes or systemic hypertension since 5 years, and his BP is 130/80 at the adherence of to ACE inhibitor, and his HbA1c is above 6.5 on a metformin and lipid profile normal. In this scenario, we have to discuss about how to control his blood sugar, what to start for hypertension with diabetes, and is there need to start any statins with lipid profile normal. In the first question about the diabetes management, we have already discussed even HbA1c is more than 6.5, we have to reinforce the lifestyle modification, diet and adherence to drug. If he's maintaining that, we have to intensify the drug from metformin to dual therapy and to aim to maintain HbA1c below 7. And to all patients with diabetes have to check their blood pressure at least annually or during each visit if they are not previously diagnosed with hypertension. If they are already diagnosed with hypertension, those patients with diabetic, they have to start with ACE inhibitors and or ARB because they are kidney protective. And the next question with lipid profile, with a lipid profile normal, whether to start with statin or not. For that, all diabetic patients should have been assessed for their cardiovascular risk, either by a QRIS-3 assessment tool or ASCVD score. QRIS-3 tool always calculate the patient's or person's risk of developing an MI or a stroke over a period of next 10 years. If it is more than 10, the ASVD or QRIS-3 score is more than 10, we have to start with atorvastatin 20 for a lifelong. So before initiating a lipid modification therapy, one lipid sample, including total cholesterol, HDL, non-HDL, and triglyceride should be taken. And our fifth scenario is a 32-year-old male, IT professional, smoker, consumes alcohol occasionally, having a sedentary life. On his routine checkup, his BP was recorded as 148/1998 millimeter mercury. In this scenario, we had to discuss when to diagnose to have a high BP or when to start with the medicine and what medicine have to be started. And this first scenario, diagnosis. Clinical BP recording of more than 140/90 in two recordings have re-recorded, it's considered as a high BP. And in scenario where home-based pressure monitoring of twice daily for next 7 days continues to give more than 135 to 85 BP is considered high BP. Once high BP is confirmed, we have to investigate for target organ damage. For renal part, we have to look for proteinuria using urine albumin creatinine ratio or hematuria, and renal function tests including urea, creatinine, and glomerular filtration rate. And the blood, you have to check for blood glucose, liver function test, lipid profile, and creatinine, then total cholesterol. Then we have to examine the fundus for hypertensive nephropathy, and we have to take a 12-lead ECG. And the management, the most important component in the management of hypertension is the lifestyle modification, which include a healthy diet, regular exercise, decreased alcohol intake, discourage excessive consumption of caffeine-rich products, low sodium intake, and stop smoking. And next part is when to start a medication. For those below 80 years, if they have a high BP of more than 160/100, straight away we can start with antihypertensive. Or those with those are below 80, with BP in the range of 140/90 or 160 between and 160/100, with any of the complication like target organ damage present or CVD, renal disease, cardiovascular risk present, we can start with the medication. So to start medication, all patients below 55, the first treatment to start is ACI inhibitors or ARB. And above 55, we have to start with calcium channel blockers. If the BP goal is not achieved, then we have to intensify the treatment with two-drug regimen. So that below 55, ACI inhibitors or ARB plus calcium channel blockers or thiazide-like diuretic. For above 55, we have to add with calcium channel blocker, ACI or inhibitor or ARB or thiazide-like diuretic. Still not BP goal achieved, we have to intensify the treatment with ACI or ARB plus calcium channel blockers plus thiazide-like diuretic. Still the BP is high, it's considered as a resistant hypertension, and after checking serum potassium, if it is less than 4.5, we can start with spironolactone, and if serum potassium is more than 4.5, we can start with alpha blocker or beta blocker. In this scenario, ACI inhibitor and ARB already conveyed that it's a kidney protective in diabetic nephropathy. All other nephropathies, it is deteriorates the renal function. So before starting ACI inhibitors or ARB, and after starting within 2 weeks or during any change in the dose, or every 3 to 6 months, we have to check the creatine and electrolytes. Once the serum creatine from baseline rise above 30% or serum creatine above 5.6 millimoles per liter, we have to stop the ACI inhibitors or ARBs. The next scenario is 80-year-old male active who is diagnosed with hypertension since 20 years. His BP is 160/100 despite adherence to calcium channel blocker, and his kidney showed slight decline in the function. This is a scenario with above 80-year-old age with hypertension and his kidney having slight decline functioning. So the scenario we have to manage, how to manage his pressure and how to deal with his kidney function. So for all CKD patients, the BP should be assessed after looking at proteinuria status. If urine albumin creatinine ratio is below 70, their BP to be charged below 140/90. And if urine albumin creatinine ratio is above 70, then your target BP is below 130/80. In this scenario, if urine albumin creatinine ratio is below 30 milligram per millimoles per liter, we can follow the guideline, NICE guideline, that along with calcium channel blocker, ACI inhibitors or ARB can be added. If the albumin creatinine ratio is more than 30, straight away we have to start with ACI inhibitors or ARB. The next scenario, a 28-year-old businessman, unmarried, having a sedentary lifestyle, came for medical clearance, and his blood, his class 2 obese, and his blood parameters shows LDL over 192 and triglyceride 135. In this scenario, my question is whether to start a statin or not. Statin beneficiary groups are adults of age 20 to 75 with severe hypercholesterolemia. That means LDL more than 190 and LDL level of 70 to 189 with cardiovascular risk. Before starting statin, we have to assess the patient having any generalized weakness or myalgias. If yes, he has to check with serum creatine kinase. If it is more than 5 times the upper limit, then we have to reassess in 7 days, and it's again high. We shouldn't start statin. If it is below, we can start. And after starting statin, we have to check the liver function test to rule out transaminase. If SGPT is more than 3 times, we have to stop statin. If statin intolerant occurs, esnitimab, ivolizumab, and aliruzumab is the option. Then after starting statin, we have to review lipid panel after 3 months and then every year. Scenario 8 is a businessman married, had done his blood test. his blood looked more milky, and his triglyceride level is 347. In this question, we have to think about whether to start fenofibrate for a triglyceride of 347. Hypertriglyceremia is a condition where triglyceride level is more than 150, and moderate level is 150 to below 500. Moderate to severe is 500 below 1000, and severe is more than 1000. So the first and foremost thing in the management of hypertriglyceridemia is the weight reduction, and the next one is the reduction of simple carbohydrate intake. And dietary fat is not a primary source for the liver triglycerides, so the reduction of the carbohydrate intake should be reduced. The abstain or limit from alcohol consumption. In moderate triglycerides that below 500, along with the lifestyle modification, we have to add only statins for the LDL cholesterol lowering. Statin have a ability for triglyceride lowering effect. So with moderate to severe, that 500 to below 1000 triglycerides, we can add fenofibrate, and we have to check triglyceride level every 6 to 8 weeks. Then for severe, that is above 1000 triglyceride, we have this dietary fat restriction to be maintained along with LDL cholesterol lowering drug and alcohol abstinence. In this triglyceride lowering drug is not preferred as this drug has no effect with the blood level triglycerides. So check triglycerides every 3 days. Then adding fenofibrate. Before adding fenofibrate, we have to check LFT, creatine phosphokinase, and serum creatine. If LFT levels, SGPT level above 3 times the normal, we have to stop the fenofibrate. And if there is an increase in total bilirubin level. Scenario 9, it show 28-year-old merchant navy on his routine ultrasound showed a grade 1 fatty liver. How to manage? The high-risk group belongs to obese and type 2 diabetes, metabolic syndrome groups all are high-risk group. Diagnosis is a liver ultrasound. Management is by lifestyle modification alone, weight reduction, nutrient-rich diet, and increase of physical activity, and abstain from alcohol. And have to screen for advanced fibrosis. If advanced fibrosis is present, you have to start with pioglitazone and vitamin E. Then last scenario is with an hyperuricemia, whether to start with medicine for a serum uric acid value 8 milligram. There's no need to start hyperuricemia or serum urate more than 7 without any symptoms or complication. We have to start only drug therapy for a serum urate more than 9 if symptoms are not present. And the lifestyle guidance for hyperuricemia is to avoid alcohol intake, restrict animal protein intake, avoid soft drinks, to reduce weight, and drink plenty of water. Thank you.
Thank you,
Thank you, ma'am, for the
Dr. Neena.
Hi, ma'am.
Welcome, ma'am, for your valuable comments on the session.
Dr. Zareen, would you like to go first?
Okay, yeah. So thank you, Neena. It was a very wonderful presentation with all the 10 case scenarios presenting, giving the detailed cases and the management. I don't think I need to add more. You have stressed on the polypharmacy and doing the urine albumin creatinine ratio, and where you have to be careful, and in the elderly where there is a kidney derangement, you need to be careful regarding the kidney function. And yeah, I think you've covered everything, including the hyperuricemia, fatty liver, and even the CRISC assessment, the assessment of CVD risk and when to start statins. So let me check the chat box. We don't have any questions. So Jaya ma'am, do you want to add anything?
Right. So Dr. Neena, I think a bit of a housekeeping issue. I think maybe for the audience references on where you have gotten especially those algorithmic charts, if you can share.
I already shared the reference, ma'am.
Oh, okay, I'm sorry, I missed it. And secondly, I think as a family physician, one of the things that we pay least attention, but in my practice, I spent more time is on lifestyle changes and the specifics of it. It's one of those things which is easier said than done. So when I signed up for this session, I was looking forward to hear more of that. So for busy practitioners, we just say, okay, lose weight, come back. Cut down simple carbohydrates and come back. But I think as family physicians, I would probably like to hear a little bit more on
Okay.
the lifestyle changes, or giving specifics on how much weight to reduce,
Okay.
or even about what's going to get you to reverse your diabetes. Do we even talk?
Okay.
We are the first point of contact, and first 5 years of diabetes are golden. And this is where, in my practice, I've achieved most diabetes reversals. So those were the two things, I think, from 2 cents from me. By the way, it was wonderful, wonderful session.
Thank you.
Ma'am, you're muted.
Are there any queries?
Yes, now you're audible.
Okay. Thank you, ma'am, for your valuable comments. Are there any new queries? Audience, please. If you have any queries, please put in your comments.
We don't have any chat questions so far. So I think.
Shall we move to the next session? Yeah. Now, our second session is on the somatizing patient primary care perspective. Our speaker is Dr. Anup. Dr. Anup is graduated from AFPICON Medical College and completed Diploma in Family Medicine from CMC Vellore. He has done fellowship in Diabetes Management from CMC Vellore and successfully completed MRCCP International. He is an alumni member of CMC Vellore, FPP. Dr. Anup is currently working as Medical Officer Kerala Health Services and has over 20 years general practice experience. Sir, I welcome you to the session. Sir, please put your hand up.
Good evening, everyone. Today I will be talking on the primary care perspectives of managing a somatizing patient. I will be dividing it into 3 parts. Part 1 will be dealing with the problem statement, where I am going to present 3 case scenarios. First one is a simple but irritating problem where Mrs. Anu, 35-year-old, feels that there is something sticking inside her throat for the last 1 year and desperately tries to clear it. She has visited multiple doctors. Evaluation was normal, but her problem remains unsolved. Now comes a severe haunting problem where a housewife, 50-year-old, has a long-standing problem with pain in multiple areas of body. Now she is on aspirin started by a cardiologist after doing an angiogram, which was normal because she was having persistent chest pain. But even then, she got admitted in ICU a few times, but all the investigations were normal. She's fed up is taking aspirin without any benefit, but no one seems to stop it for her. She continues to have pain and is wondering what to do with the illness. Now come to the third and disaster. It's a disastrous problem. Say a story of a child, 14-year-old, having recurrent periumbilical pain and vomiting with no signs. She cannot attend the school, although she denies any abuse or emotional distress. There was a death in her family. Father died about 5 years back, but she has already coped with it. All the examination, lab investigations, scopies, all the consultations, everything was normal. Even surgery for appendicectomy surgery was done early in the course of illness. And all the alternative medicines were also tried, but nothing could relieve her from her illness. It affected their bad family and their finances. Now, after a lot of investigations, she was referred to Psychiatrist for detailed evaluation and management, which she was, the parents were not willing, but had to accept it reluctantly because there was no other choices. So issues here are the 3 cases. These are mostly chronic problems, and the symptoms are clustered with real symptoms with no signs of disease. Some can be mild, some can be seriously debilitating. There is labeling issue of psychiatric illness. Then there is also issues of rampant investigations with normal results. Polypharmacy is there without desired outcome, because most of the patients have taken a lot of drugs without any results. Then they use a lot of healthcare resources, including emergency care. And doctors find it frustrating and challenging to treat these patients. But the patient finds that they are rejected by the physicians as having no disease. And it's a costly affair for the patients. So now you may be wondering, where have we reached? Yes, you have reached the crossroads between the mental and physical dimensions of a well-known problem, and that is the junction of somatization. So when coming to what's the position of primary care physician in managing somatization? It is ubiquitous, so you can't escape, because see the chart, you can see the somatoform disorders very common in general practice, even more common than depression and anxiety. So you can't escape, you have to manage the patient. Then, but you are unprepared, and that's not your fault, because you are not taught in the medical school how to manage this common condition. And so this condition is unrecognized in primary care, and because of that, a lot of unnecessary things like prescribing a lot of unwanted drugs, referring for diagnostic studies, and too much referral to other specialities, which is a costly affair. But the problem is that the patients are unwilling to go for a psychiatric evaluation, because they don't feel like they are having a psychiatric illness, and they are ready to get care from the family physician. And as a family physician, you are uniquely positioned to care these people, because you know the patient and the family very well. Now coming to what somatization means and how to assess. Somatization, as Lipowski defined, is a patient with one or more somatic symptoms that lacks adequate medical explanation, which causes patient distress and prompts the patient to seek help. It's a common human experience. Is there anyone here sitting in and listening to my lecture who haven't somatized even once in their life? If so, please raise your hand. But if this becomes a primary mode of behaving, then it becomes a somatoform disorder. Somatization can happen unconsciously and consciously. And unconsciously, it happens, and the most common form is somatic symptom disorder. And in this lecture, I will be talking more on somatic symptom disorders and somatization in general. And what exactly is somatic symptom disorder? It is one or more somatic symptom that distress the life of the person with excessive thoughts and feelings or behaviors related to these symptoms, and which persist more than 6 months. DSM-5 had added some specifiers whether the SSD is associated with pain, whether it is persistent, and what is the severity. In DSM-5, the emphasis is given on the burden of symptoms and not on the etiology. So it is not a diagnosis of exclusion. So suspect early and diagnose it early. So when should you suspect a somatization? Multiple symptoms occurring in different parts of the body. Vague symptoms that often exceed signs. Way in which they represent an interpreter, mostly that will be a dramatic and graphic representation. Disease run in a chronic course. If there is a presence of psychiatric disorder, then the chance of having somatization is high. Then if there is a history of extensive diagnostic testing and with normal results, you can suspect somatization. If the patient feels that they are rejected by the previous physicians having no disease, or having the problem is there in their head, then that is a sign of somatization. So when the patient comes to you and you feel irritated or overwhelmed by the history that they gave you, then that itself is a clue that the patient in front of you is having somatization. And most of the time, the patient will be a frequent attender to your clinic. History taking is like opening the Pandora's box. All sort of devils come out, and symptoms will be varied and mostly dramatic and graphic and vague. And in Kerala, we have a special symptom called neerkat. So whenever you hear all these symptoms, don't try to deter the patient, explore their belief systems and illness behavior. Ask them what are your biggest concern or worries about the symptoms. And as the history text moves along, attitude, beliefs should become clearer and patterns of interaction and illness behavior identifiable. Distorted beliefs, ideas, and fears can be addressed at several points during the process of gathering data. This is an easier method for assessing the severity and diagnosing somatic symptom disorder. That is somatic symptom scale 8. It is very quick. This is another mnemonic to diagnose severe somatic symptom disorder or screen out the same. So what is the mechanism in this disorder? Actually, we don't have a clear-cut idea what causes somatic symptom disorder. It may be due to the amplification of the somatic sensation, or it may be due to the psychological concept called identified patient, or it may be the patient's need to be sick phenomena, or if you can remember the phantom limb from the medical school, that also can be a cause for the somatic symptom disorder. And there is a strong association with childhood abuse. The differentials include undiagnosed medical conditions like the ones cited here and psychiatric illness. Remember, these can coexist with SSD also, but they can also mimic SSD. But you should rule out malingering and factitious disorder before diagnosing SSD, because these two are conscious somatizations, whereas SSD is an unconscious somatization. And how to evaluate in primary care? Review the old records, evaluate for organic medical conditions, evaluate for psychiatric conditions, assess a psychosocial assessment, then inquire about the family history. And please note, all these should be done in a smooth flow, in a patient-centric manner, and not in the old-fashioned medical call style questionnaire. Okay. Now we move to the last part, how to manage a somatizing patient. How to take care of a somatism. I will be dealing in this order, discussing the diagnosis, reassuring the patient, how to schedule visit, what are the drugs and psychotherapy strategies available, when and how to refer to a psychiatrist, what are the targets targets in care for a somatizing patient. Now coming to the first part, how to discuss the diagnosis and reassure the patient. Now we'll take the case of a 50-year-old patient called Mike, who is having pain in multiple areas of body for long duration. Now he is having chest pain, which has been evaluated in detail, but he's constantly worried about chest pain. How to discuss your findings? If this is the way in which you are going to discuss, whether what happens is that the doctor is trying to normalize the symptoms with his clinical knowledge, and patient is trying to legitimize their own suffering. And if the discussion is going like this, it ends in a battleground, because they are in different grounds, and consultation becomes a battleground. And this is called as contested illness, where there is illness, but you cannot name a disease. And in the end, what happens is that both the doctor and the patient feels that they have wasted their time, and the consultation goes bad. So how to discuss the diagnosis in an ideal way? First, you need some empathy, because the patient is coming in a frustrated state with no diagnosis, rejected by the previous physicians, suffering for a long time with no relief. So he requests empathy. So you should validate the experience, the patient's experience. Tell them that the symptoms and the pain are real and distressing for him. Never ever use these words. And how to discuss the diagnosis. The results of my examination test we conducted show that you do not have a life-threatening illness. However, you do have a serious and impairing medical condition which I see often, but which is not completely understood. Although no treatment is available that can cure it completely, there are a number of interventions that can help you deal with the symptoms better than you have so far. This statement conveys the message that it is not a serious life-threatening illness, but it is a serious impairing condition, which is not very rare because you see it very common, and there is limitations in treatment, but you can help him to become functional by a lot of strategies which you are ready to offer. Then you should name the illness appropriately, like stress headache, pain disorder, chronic fatigue syndrome, IBS, fibromyalgia, etc. Because without diagnosis, there is no prognosis. And diagnosis is expected in every consultation, and it is needed so that the doctors can also manage appropriately. Finally, now here the patient and the doctor has reached the common ground because you are not said the word that it's all in your head. So, but there's a problem that even if you have not labeled him as psychiatric case, a positive organic diagnosis or simple, straightforward symptom relief will not satisfy or cure this patient. That is the real problem with SSD. That is the dualistic view won't work. You have to incorporate holistic method, incorporating physical, mental, and psychosocial approaches into patient care. Now, after you have discussed the diagnosis, how to reassure the patient. Reassurance is simply letting the patient know how to do. We'll see, take the case of the Mike who was having somatization session with chest pain. You start by telling that I have listened to your heart and done an ECG, and while I cannot give you a definite reason for your chest pain, there doesn't seem to be a serious problem with your heart. But I'll be closely monitoring your condition and any new symptoms if that arise. This type of reassurance should be done only after you have gathered enough data and trust from the patient. Otherwise, it will be seen as a premature reassurance where the patient will be thinking that the physician is having disinterest or dismissiveness towards him. Now, after you have reassured him, you should put him on regular visits. Why? Brief but regular and scheduled visit. The rationale of this approach is to stop the emergency visits to casualty altogether, and regular OP and to schedule OP visits so that patient need not wait for another symptom to check in, so that he is regularly taken care in an OP manner. The frequency can be dictated based upon the severity of the illness. It can be twice a month or once in a month, and you can taper or increase it as you like. Then allow them to speak for a few minutes uninterruptedly. Ask open questions. You can ask, tell me more about your pain, rather than asking, does the pain woke you from night? Then patients will be having multiple physical complaints which can be split into subsequent visits. And keep an eye on for other disease, because SSD patients can develop other disease. So make it a practice to screen out common diseases and manage them, manage comorbid illness correctly. And perform brief physical examination at each visit. Keep a logbook for tracking illness and pain and review it regularly, giving feedbacks on improvements. This is very important. And when the patient presents with the physical symptoms, try to shift the focus away from physical symptom to psychosocial aspect by judging the process of improvement in level of function. So you should shift the focus away from the physical symptoms as such to the level of function. You can ask, how have your symptoms like low backache or chest pain interfered with your everyday life? So if the patient says that pain is there, but I can manage. So you should reciprocate by acknowledging the patient that the patient is doing the best she can to manage their illness. Do not try to cure or take away the symptoms. That is because SSD patient will be having a lot of symptoms. So if you take away one symptom, she will replace it with another very quickly. Set boundaries politely and try not to engage in conflict. Now coming to the drugs available to treat SSD and how to protect from iatrogenic harm. Actually, there are no drugs. SSRI or SNRIs can be used if there is a coexisting depression. Fluoxetine can be used along with fluoxetine can be used as also low dose amitriptyline because they improve the pain, morning stiffness, global improvement in well-being, then sleep, fatigue, and functional DGA symptoms even without depression. But it won't cure or take away the need to be sick. So drugs are not substitute to the regular scheduled visits. So regular scheduled visit is the key thing in this management. Now, how to protect the patient from iatrogenic harm? There is an inherent risk for polypharmacy because most of the patient will be taking aspirin for chest pain prescribed by some specialist or DMRD drugs for arthritis or arthralgia. So that is a risk for these patients. Then try to avoid narcotics for pain because they numb the angry feelings and patient develop dependence or tolerance. Then avoid tranquilizers for sleep because they distort the sleep structure and worsen the depression. Then if you're open and have a good alliance with the patient will ask you what is your opinion about alternative medicine, where you can share your opinion and concerns regarding alternative medicine. Thereby, we can protect the patient from iatrogenic harm from some of the alternative medicine. Now comes the iatrogenic harm from diagnostic studies. See, these patients are subject to excessive testing. So only order the test if there is really indicated. Because excessive testing introduce the risk for false positive results. So that increases the anxiety of already anxious patient and increases the confusion of already confused doctor. So never order a test without real indication. And studies have indicated that it doesn't provide real benefit if it is done for reassurance to the patient. Then the patient may request for diagnostic check. They may ask, how can you be so sure that I don't have a brain tumor? You haven't done a CT scan. You said you have put on a regular monitoring schedule, and if need arises, we will arrange for that. Then third type of iatrogenic harm comes from referral to specialist. Most of the time, these referrals are done to give a respite to the GP or get rid of the patient rather than any diagnostic benefit, or they may fear they are missing something. So if you refer to a specialist who is a generalist also, like an internal medicine specialist, and who you have good rapport with that, so that you can inform that specialist beforehand that the patient you are referring is having a problem with somatization, and that you need him to take care of that thing also. Then how to talk about stress? This is how you should talk about the stress. And remember that only talk about stress after giving a good therapeutic relation. Otherwise, the patient will have an impression that you don't believe him to have an illness or disease, and you think that the patient is making it up. That will harm the relationship. So talk about the stress only after having a good relationship. So how to manage stress? Relaxation training can be taught, like diaphragmatic breathing, progressive muscle relaxation. The other thing is behavioral management. By incorporating these three activities, one is meaningful activities, second one is pleasurable activities, third is exercise, into a daily timetable, and ask them to incorporate this timetable into the everyday life. Then teach patient to challenge their cognitions, like the pain is not damaging my body. I can continue activities even in some mild pain, so I don't have to stop. Then manage the sleep with sleep hygiene and not with sleeping pills. Sometimes during consultation, psychosocial issues pops up. So you can use this technique known as BATE technique, which is a 5-minute counseling technique used by GPs all over the world to manage psychosocial issues coming out during a consultation process. Then how to refer to a psychotherapist for CBT. It is effective for treatment of SSD and health anxious patient. It reduces the physical symptom, distress, disability, and to avoid the stigma often associated with these referrals, this program should be referred as stress management for patient with chronic illness, and not don't use the word psychotherapy or behavioral therapy. You should tell them that you are referring it for the stress management for the patient with chronic illness. And how to refer to a psychiatrist. See, take the case of Sumi. She's feeling frustrated and angry because her rheumatologist referred her to psychiatrist because her joint pains are not going away, but she is not willing to see the psychiatrist. So how did the things go wrong in this patient-physician relationship? See, collaboration of a GP with psychiatrist is needed and has good outcome in SSD, and sometimes it may be needed when the primary care physician's treatment is ineffective. But a referral to a psychiatrist is often interpreted by the patient as, he doesn't believe me, he thinks it's all in my head. The referral of a psychiatrist should not block the patient's trust if a strong empathic relation has been established beforehand. The first priority with any patient having somatization disorder is to listen and truly understand not only the symptoms, but what the patient is thinking and feeling. Then they will adhere to the treatment plan like referral. What are the targets in care? So if you go by these steps, which I have dictated now, I think the patient will develop tolerance to their symptoms. They will wait until the symptom check out, become less hypervigilant, and become more functional. They will stop emergency visit and decrease the OP visits too. Remember, cure is unlikely for this condition. Allow for relapse, but continue to care. This is the take-home message, CareMD approach to somatic symptom disorder given by American Association of Family Physicians. You can go through it. Now coming to another case, Mrs. Sija is a housewife, frequently calls her family doctor with complaints of mild numbness of fingertips. She had a stroke 5 years back and was detected late, but luckily escaped without paralysis. Examination was normal, but she gets anxious about it each time, which settles quickly, but only after consulting her doctor and getting her BP checked and ruling out stroke. Is it somatic symptom disorder? It is not a somatic symptom disorder. It is a subset of somatic somatization and is known as illness anxiety disorder. Why? Here the symptoms are only minimal or mild, and the behavior or the worry are limited, but the patient is preoccupied by the thought of a serious illness and he is anxious about that. So it is not a somatic symptom disorder, but an illness anxiety disorder. So what are the other forms of somatization? So that can be easily said with the help of a seizure. If you fake a seizure for insurance policy, that is malingering. If you fake a seizure for caring in hospital, that is factitious. And if you had a seizure-like symptom due to stress without any organic pathology, that is conversion disorder. And these are the other forms of somatization. And the final statement is, GPs are in a unique position to provide tenacious care for illness in absence of disease, as they are easily accessible and affordable to the patient. And we are masters in dealing with undifferentiated illness like somatic symptom disorder, with one of the sweetest pill ever invented at our disposal, the patient-centered care. But sadly, we continue to be the luxury item for our population. So no matter how broken you are, you will always find a way to rebuild yourself. So cure sometimes, treat often, and comfort always. And this is very true with regard to somatization. Thank you.
Thank you, sir, for this very informative session on the somatizing patient. Now, I welcome. Thank you, sir, for very informative session on the somatizing patient. I invite Jaya ma'am to comment on the session. Welcome.
Dr. Zareen?
Ma'am, you can start.
Okay, all right. Wonderful session, Dr. Anup. It's one of my favorite topics. That's why I had requested to let me be part of this session. Thinking back, it kind of made me reflect on my journey so far. So, as a first-year resident in US, I had, I think when I started my journey, I was the typical arrogant, defensive young physician who would commonly use things like, it must be all in her head. But had an opportunity to be mentored by wonderful family physicians, who made me fall in love with family medicine. Reed Blackwelder. So some of the things that you said, really echoed. I don't know what more I have to add to this. Some of the things he would always tell us, nurse the patient, which is if they're coming, and GPs in family medicine, I think sometimes, we could see significant amount of patients will be coming with, somatization disorder. So he always used to make us speak out, nurse the patient, name the emotion, understand it, respect it, and support it. And I think I have tried to live by that as much as possible. But honestly, wonderful session. Not much for me to add on your session.
Zareen ma'am, please have your valuable comments on the session.
Yeah, Dr. Anup, it was a very wonderful session. I think you've covered everything. And yeah, this is the most it's the most distressing one for family, for us also, dealing with a patient like this in the OP. And establishing the rapport is the most important thing. So once we establish that rapport, I think then whatever we say, the patient will take it into their side. Otherwise, when we say it's all in your head or giving them a diagnosis, nothing is going to work out. But once we get their trust, then they'll accept what we say. I don't think that I also don't have anything to add. Yeah, there's nothing in the chat box also. Yeah, there are no questions in the chat box. So,
Okay, ma'am, I thank all of you for being there for our session. Thank you, ma'am. Thank you, Jaya ma'am. Thank you, Zareen ma'am, for chairing our session.
Thank you. Thank you for the opportunity.
thank you. Thank you, everyone.
Okay, thank you everyone for patient listening.
Hello? Hello, am I audible?
Yes, ma'am.
Okay. Good evening to all. I'm Dr. Anaga, DNB resident from Luth Hospital, Kochi. Now, the next session is Knocking Out the Stone, Management of Urinary Calculi. The session will be chaired by Dr. Lizzie Vincent and Dr. Shobha. I would like to introduce the chairpersons first. Dr. Lizzie Vincent. Dr. Lizzie Vincent is a DNB family medicine with special interest in accident and emergency care.
She is currently working as consultant and academic coordinator, family medicine at KIMS Trivandrum. She has worked as the lead consultant faculty at Apex Trauma and Emergency Learning Center, Trivandrum. She completed her graduation from Vinayaka Missions Medical College and her post-graduation from Sundaram Medical Foundation. Later, she pursued her interest in accident and emergency and did a fellowship in emergency medicine from Dr. Mehta's Hospital. She is also an AHA, American Heart Association certified BLS, ACLS, and PALS instructor, and Advanced Disaster Life Support instructor, Advanced Trauma Life Support, and NRP provider. Dr. Lizzie is the current president of Academy of Family Physicians of India, Tamil Nadu State Chapter. She believes that family medicine is the cornerstone for improvement of healthcare in the society, and training the aspiring family medicine doctors as a major role in promoting the specialty of family medicine. Welcome you, ma'am. Dr. Shobha P. graduated from Tirunelveli Medical College and completed DNB in Family Medicine from Luth Hospital, Kochi. She also gained a postgraduate diploma in Geriatric Medicine from IGNOU, and she has also completed courses in Palliative Medicine and Diabetology and is currently pursuing a course in Bioethics from UNESCO. Dr. Shobha holds MRC GP and MNAMS degrees. Her special interests are in prevention of lifestyle diseases, primary care medicine, geriatric medicine, adolescent health, and community health activities, which includes organizing health camps and health awareness classes in schools, colleges, and in the community. She is an active advocate against substance abuse and was involved in the formation of anti-tobacco initiative of her hospital at TAC and the hospital's no tobacco policy. Dr. Shobha is the life member of AFPI and IMA, now holds the position of Joint Secretary of AFPI Kerala Chapter. Welcome you, ma'am. Our speaker is Dr. Vishnu. Dr. Vishnu graduated from Government TD Medical College, Alappuzha in 2013. He did DNB Family Medicine from KIMS Health Trivandrum in 2021. Dr. Vishnu is currently working as Registrar, Department of Family Medicine, KIMS Health Trivandrum. Welcome you, sir. Now, over to you, Shobha ma'am and Lizzie ma'am.
Yes, good evening, my dear friends. So now we are going to listen to a talk by our Dr. Vishnu, and welcome Dr. Lizzie ma'am. Nice to see you here. So shall we proceed with the talk now? Without much wasting of time. It's 6 o'clock. Over to you, Dr. Vishnu.
Good evening, everyone. Am I audible?
Yes,
Yes,
you're audible.
yes.
Am my screen visible?
Yes.
Yes.
Good evening, everyone. And I should thank AFPICON Kerala Scientific Committee for having given me an opportunity to present a topic before this August audience. And the topic for me today is knocking out the stone, how you manage a patient with urinary calculi. Urinary calculi is said to be the third most common urological disease in a practice with which a patient presents to us with renal colic, which is the most common presentation of urinary calculus. And a person who have experienced renal colic would know that it is one of the very painful conditions one can experience in one's life. And many of these patients first come to a primary care physician and not to a neurologist. So that makes this topic very important. And we should be able to know when we can manage a patient conservatively, what are the medications we have in our armamentarium, and when we should be referring a patient to a urologist. So that makes the difference between a successful consultation and an unhappy patient. Now, coming to the epidemiology, when it comes to age, the incidence of renal calculi increases with age. And when we look into the comparison between male and female, less than 40 years, it's almost similar in males and females, but above the age of 40 years, it is slightly more in males. And it's more commonly seen in white population than in black. And what is the pathophysiology of renal calculi? And renal calculi are crystalline mineral deposits that forms in various parts of the kidney. And the process of stone formation depends on the urinary volume, the concentration of the various ions like calcium, phosphate, oxalate, sodium, and uric acid, as well as the concentration of the natural calculus inhibitors, as well as the urinary pH. Now, coming to the composition of stones, 70 to 80% of the stones are formed by calcium oxalate, 15% by calcium phosphate. Uric acid constitutes to about 8% of the urinary stones. Cysteine constitute about 1 to 2%, struvite about 1%, and others around less than 1%. Now, coming on to the risk factors. The risk factors we can broadly classify into modifiable as well as non-modifiable risk factors. The modifiable risk factors mainly include the urinary factors, dietary factors, as well as medications, and non-modifiable factors are family history, genetic factors, as well as various medical conditions. Now, what are the main urinary factors? Now, high urinary calcium, more than 250 milligram per day in females and more than 300 milligram per day in males. High urine uric acid, low urine citrate, high urine oxalate, low urine volume less than 1 liter per day, and the urinary pH. All this contributes to the formation of renal calculi. Now, what are the dietary factors? It mainly the factors that increase or varies the BMI, the fluid intake, the DASH diet, dietary calcium intake, as well as the intake of sugar-sweetened beverages. Now, coming to the non-modifiable risk factors, it includes the family history, genetic factors, and various medical conditions. Now, how does a patient with renal calculi present to us? We should be knowing that 15 to 20% of the patients with renal calculi remain asymptomatic. But what is the most common symptom with which patient comes is pain. It can be either an abdominal pain or a flank pain or a loin to groin pain, which is typically giving a clue towards a renal calculi. And the other most important symptom is gross hematuria, dysuria and urgency, as well as nausea and vomiting. Now, coming to the topic proper, how you manage a patient who is having a renal calculi. When a patient is presenting to us, we first take the detailed history, in which we should specially focus on whether there is a history of previous renal stones, if there is any family history of nephrolithiasis, if there is any underlying renal and urinary structural abnormalities, is there any metabolic conditions that can predispose to the formation of nephrolithiasis, is there any history of medications like sulfonamides and indinavir which can result in stone formation, and also the history of recurrent UTI. And after taking a history, we should do a general physical examination where we focus on the abdominal examination to look for any tenderness, any mass, any evidence of urinary obstruction, or any other cause of abdominal pain such as appendicitis. This growth measurements more pertains to the pediatric population, where there is patients with poor weight gain and failure to thrive, points towards some kind of chronic conditions or congenital conditions that can lead to renal stone formation. We should also look for the BP measurement as well as the assessment of edema, because that can occur along with hematuria in a patient with a glomerular disease. And we should also measure the body temperature to look for any evidence of infections or sepsis. Now we have a patient with whom who is a suspect of renal calculi but doesn't need an immediate referral. What are the tests? What I am supposed to do? The first and the easiest available test is urinalysis, followed by urine culture, blood investigation, as well as imaging studies. Why do we do imaging studies? It is to confirm the diagnosis of kidney stones, assess for hydronephrosis, and look for the stone size as well as position. Now, coming to urinalysis, you do a urine dipstick examination where we can detect hematuria as well as reveal nitrate present or not. And urine microscopy gives a clue to the morphology of the crystals, where there is a hexagonal crystals as I shown in the image with points towards cysteine stones. If it is a dumbbell-shaped crystals, it points towards calcium oxalate monohydrate, and if it is an envelope-shaped stones, it points towards calcium oxalate dihydrate. These are the spindle-shaped ones are the sulfonamides, and all this can be evident with the help of a urine microscopy examination. Now, we have to do a urine culture examination to rule out any UTI in a suspected patient, because the treatment is entirely different when there is an concomitant UTI infection. And we should also be doing the blood investigations that is creatinine and uric acid, to look for the proper, whether the renal function is proper or not. We have to look for any hyperuricemia, look for any high calcium level. And if the calcium level is high, we have to look for PTH. And blood counts as well as inflammatory markers should be checked to look for any evidence of infections or sepsis or pyelonephritis. Now, if we ask what is the most important diagnostic tool in a patient with renal calculi, we can say it is imaging. And what are the three most common imaging modalities available with us are, one is the plain abdominal radiography, second is ultrasonography, and third is non-contrast CT. Now, abdominal plain radiography can detect large stones, radio-opaque stones, but it can miss any radiolucent stones, small stones, any stones that overlay a bony structure, and all these things can be missed in an abdominal radiography. But when is abdominal radiography important? In a primary low profile setting where there is no access to USG or CT, we can resort to abdominal plain radiography study. The most common investigation that we depend on when a patient with renal calculi comes to us is ultrasonography. It can detect radiolucent stones such as uric acid stones, and any evidence of urinary obstruction can be detected, but it is difficult to detect a small stone less than 5 millimeters, any papillary or calyceal stones or uretral stones. And the important thing in USG is the experience and the expertise of the radiologist is an important factor. Now, the most important and reliable test for a patient coming to us with renal calculi is non-contrast CT, where we can detect even small stones of 1 millimeter size, any uretral stones, any radiolucent stones, and it also gives a detailed anatomic information about the kidney. And it's a very rapid procedure. And the advantage is that if at all we need to use a contrast for detailed evaluation, we can do CT contrast when we are resorting to this mode of investigation. But the disadvantage is that we are exposing the patient to radiation. Now, these are the summary of the workups. You go with urinalysis, urine culture, stone analysis if it can be retrieved, blood investigations, plain radiography, ultrasonography, and non-contrast CT. So, a patient have come to us, we have to resort to management. The acute management mainly includes the pain relief, and the most common medicine that we have in our armamentarium is NSAID. We use ketorolac 30 to 60 milligram IM, and it is having less side effects. And studies have shown that alpha-1 antagonists like tamsulosin can shorten the duration and increases the likelihood of spontaneous stone passage, especially in the distal uretral stones. And we have to know which stones should pass. Most stones, even the symptomatic ones, we can manage conservatively. And the majority of stones will pass within a period of 3 to 6 weeks. And we should note that we should be doing an imaging studies in the first visit to stratify whether the stones can be conservatively managed safely or should be referred to a urologist. And in 60% of the cases, stones of the size 5 to 7 millimeters can pass with conservative management, but it is unlikely that stones more than 7 millimeter will pass by conservative management. And stones more than 10 millimeter is very less likely to pass spontaneously. So the likelihood of spontaneous passage decreases with increasing size and with the proximity of the stones. And what we should ensure is that the patients should be made aware of the likelihood of passage, as some patients will opt for expedited surgical management to avoid the possibility of any further episodes of renal colic, even though the stone may be of a small size that can pass spontaneously. So what should I be doing for a patient who is conservatively managed? So we know that renal colic is an extremely painful condition. So analgesia is the most important treatment. We can resort to NSAIDs, and all patients should be told to present to the emergency department if the patient has symptoms of UTI, if the pain is persisting, unbearable despite analgesia. And the most important thing, we should be knowing when we have to refer the patient to a urologist. For that, we need to know the red flags to initiate urgent surgical management. The first thing is the severe ongoing pain despite adequate analgesia. The second thing is stones more than 7 millimeter are less likely to pass and should be referred to a urologist. We should look for any concurrent obstruction or UTI which can lead to pyelonephritis or sepsis. And patients having complete urinary obstruction, that is, and those with single kidney or bilateral obstructive stones or anuria. And the next indication is the patients having a minimal renal reserve. That is, the patient is having a pre-existing kidney disease. And the next indication is failed conservative management more than 3 weeks. We should not wait until 6 weeks because it can cause renal damage. And the next indication is the pregnant female or having a delayed menstruation, and the patients with potential comorbidities and elderly age group more than 60 years. And lastly, the patient who has passed stones but is having ongoing blood in the urine. All these are indications for referral to a urologist. To summarize the approach to how we manage a patient with renal calculi, we take a detailed history and physical examination. We do a point of care urinalysis or dipstick to look for hematuria and urine microscopy. Look for urine culture if there is any evidence of sepsis. You look for any renal failure, whether the pain is resolved with analgesia, if there is any single functioning kidneys or any other comorbidities. All these conditions we have to refer to a urologist. Then we have to resort to an imaging. And if the stone size is less than 5 millimeter, we can manage the patient conservatively. And if the stone size is more than 5 millimeter or hydronephrosis is present, we have to refer to urologist. Once we are managing conservatively, we can start the rescue medications and do subsequent repeat imaging to look for the presence of stone or whether the stone has passed. And if we are able to retrieve the stone should be sent for analysis and do the repeat imaging if we are not able to retrieve the stones. And in patients having recurrent episodes of stones, we have to take a detailed medical history and do a metabolic test. Now, what are the preventive measures to reduce the recurrence of kidney stones? The main modalities include lifestyle modification, citrate supplementation, as well as medications. The lifestyle modifications mainly include increased fluid intake to 2.5 to 3 liters per day. A balanced diet is ideal for preventing stone recurrence, and patients who are obese or overweight should pursue a normal body weight through dietary modification and increased physical activity. And citrate supplementation is used for calcium stones, uric acid stones, and cystine stones. And medications, we can resort to thiazide diuretics, allopurinol, hydrochlorothiazide 50 milligram per day, chlorothalidone 25 to 50 milligram per day, or indapamide 2.5 milligram per day. Or allopurinol should be started at 100 milligram once daily and gradually increase to 100 milligram. There is benefit with alpha-1 antagonists like damselosine, and patients on conservative management should be advised to strain urine to avoid any unnecessary imaging if the stone has passed, and that stone can be sent for analysis. And we can also resort to follow-up scans where X-ray KUB is, if the stone is definitely seen on initial X-ray, we can go with X-ray KUB, and if not, we can resort to a CT KUB. It can be done after 3 to 4 weeks of initial visit. And when we are putting a patient on the citrate supplementation, we should be monitoring the potassium levels as well as liver enzymes if we are giving allopurinol. Now, let me just give a brief description about the surgical options which we can suggest to our patients. The most common surgical options available with this are laser lithotripsy, extracorporeal shockwave lithotripsy, percutaneous nephrolithotomy. Usually, we are not doing any open surgeries nowadays. It used to be done in the past, but recently we are not preferring open surgery. And the availability varies, particularly in remote areas. Now, what is laser lithotripsy? It's the most common procedure for management of urolithiasis and used to treat calculi anywhere in the urinary tract, where we pass a scope periurethral into the ureter, and then a flexible laser fiber is used to fragment the stones, and the stone fragments may be removed with a basket or allowed to pass spontaneously. A ureteric stent is usually left in situ and is kept for 1 to 14 days following the procedure. The next procedure is extracorporeal shockwave lithotripsy, which is used for stones in the renal calyces or renal pelvis that are 5 to 10 millimeter in size, where a lithotripter is used with ultrasound or X-ray guidance under GA to deliver a series of shocks to one or more stones to fracture them and allowing them to pass spontaneously. Now, the third one is percutaneous nephrolithotomy. It's a surgical procedure where the renal calyces are accessed via a 2 cm incision over the kidney, and a nephroscope is passed directly into the kidney, and the stone is fragmented with a combination of mechanical force and direct application of USCR laser. Now, what is the possibility of recurrence? The rate of stone recurrence is 10 to 30% at 3 to 5 years among patients with idiopathic calcium oxalate stones, and the recurrent rate is higher in males than females. And the overall stone recurrence rates depends on factors such as previous stone history and the type of treatment. And who are the group at risk of high risk of recurrence? That include early onset of urolithiasis in younger than 20 years of age, a family history of stones, disease-associated stones like in hyperparathyroidism, genetic conditions, any anatomical abnormalities like PG obstruction or single kidneys, and any previous or concurrent renal calculi. And what are the advices I can give to a patient with recurrent stones? Renal calculi precipitates with concentrated urine, so we should be asking them for a good hydration. We can ask them to take adequate fluid until the urine is clear. And you can advise low sodium diet, which can reduce the incidence of calcium stones. We can advise low oxalate diet, low protein diet, and metabolic screening for patients who are at high risk of having recurrent stones. And for patients who pass stones with conservative management, those who are at high risk of recurrence should be followed up with metabolic workup. Now, what about asymptomatic stones? Asymptomatic renal calculi are most frequently incidentally found in the calyces of kidney, but they occasionally present in chronically obstructed, atrophic, and maybe a focus of recurrent UTI. Now, what are the indications for referral for asymptomatic renal stones? If the stone is more than 5 millimeter, if it is seen in a patient with single kidney, the occupational need to be stone-free, like in the case of airline pilot or in military, if there is chronic obstruction or recurrent urinary tract infection, in all these conditions, the asymptomatic stones should be treated. To summarize, the take-home message, the urinary calculi typically present with renal colic and hematuria, frequently accompanied by nausea and vomiting, and the gross or microscopic hematuria frequently accompanies renal colic, but it may be absent in around 15% of the cases. The unenhanced CT is the single best initial diagnostic imaging test, and if positive, an immediate KUB is very helpful for determining the stone shape and the density, as well as follow and tracking. And clinicians should initially assess the need for urgent intervention, as well as the likelihood of stone passage before planning for a conservative management. And the need for urological intervention must be individualized. And the metabolic risk of stone recurrence should be addressed in repeat stone formers as well as in children. So these are the stones not collected from any park or beach. This was shared to me by one of the senior professors of urology, which he operated before this recent procedures, I mean, like our lithotripsy have come. This was operated, the stones operated by him through open surgery in 90s. And he's currently a professor in Manipur. He has shared this image with me. That's why I put it up. So these are my references. Thank you.
Thank you, Vishnu sir, for your informative session. Now it's time for question and answers. Audience, please put questions in your chat box. We didn't get any questions so far, so I welcome Dr. Shobha ma'am to comment on the session. Welcome, ma'am.
Thank you. Dr. Vishnu has elaborated upon this very interesting topic and a very common topic, because we see a lot of patients coming with actually asymptomatic is quite common. I think there are several patients whom I see who just have this renal stones as an incidental part of their checkups. When they get their sonograms done, we see the patient having small calculi. They're not aware of that particular issue at all beforehand. And he has elaborated upon why we should know about, as GPs, why we should know about renal calculi, and this being such a common condition. And of course, we know about, we learned about a few of the risk factors, modifiable as well as non-modifiable, and as well as the pathophysiology also we saw. The investigation wise, that workup was very nice. The diagram was very nice. I like the diagram, small diagram which you had given. And red flags. We had elaborated upon the red flags as well as the approach to renal calculi. It was a very comprehensive diagram. That one also was very good. Actually, lifestyle modification is quite important, I feel, because as you said, recurrence is quite common. So it's very important that as a GP, when patient is coming, even though they are not having symptoms, and but they are instantly being found to have renal calculi, we should keep on emphasizing upon lifestyle modifications. And I think even for passing the stones, drinking water is something which we don't usually, many of us don't drink lots of water, no? The required amount of water. So maybe that is also one reason for the formation of this crystals of stones in the initial stages, which later turns out to be, turns into a bigger one. So that lifestyle modification regarding diet, as well as drinking of oral fluids and maintaining of the body weight, etc., is very important aspect, which we have to explain again and again whenever we see the patient in our practice. So it was a very comprehensive and very nice presentation, Dr. Vishnu. Over to Dr. Lissy ma'am for her comments. Thank you.
First of all, I thank AFP Kerala for giving me the opportunity to be here in this platform. And I'm very proud and happy to see Vishnu also coming here. Thank you, Shabama. Actually, Vishnu has made a very wonderful presentation and a crisp one for the upcoming people. From my point of view, I'll tell all the youngsters that lifestyle modification is the one, as Vishnu and Dr. Shobha said, has to be emphasized as family physician. So dehydration is one of the commonest things, especially when we see elderly population like palliative people and all, their immobilization can be a cause, and recurrent UTI even in the catheter patients we have to keep in mind. And for younger, very young, small children, if you see, you have to think about the hereditary causes and screen for those also. So thank you, Shabama. Thank you, Kerala team and Vishnu for this opportunity.
Thank you.
Thank you. Thank you so much. Thank you, Dr. Vishnu.
Shobha ma'am, thank you, Lissy ma'am, for your valuable comments. The next session will be start by 6:30.
Ma'am, you are not audible. Ma'am, please unmute yourself. Okay.
Muted.
Moving on to next session. The next session, the art and science of healing nail disorder, a guide for GP.
Ma'am, you are not properly audible. Please make yourself audible.
Okay. Moving on to next session, The next session, The Art and Science of Healing Nail Disorder, a Guide for GP. Our speaker is Dr. Ebin. Dr. Ebin did his MBBS from Government Medical College, Alappuzha, and MD Dermatology from Government Medical College, Pariyaram, DNB from National Board of Examinations. He is a life member of Indian Association of Dermatologists, Venerologists, Nephrologists, member of the World Allergy Association, Junior Members Group, life member of the Association of Cutaneous Surgeons of India, active member of the International Trichoscopy Society, and member of Emergency Medicine Association. He has many international, national, and state level paper presentations to his credit. Dr. Ebin has worked as Assistant Surgeon, Government Health Services, as Assistant Professor, Department of Dermatology, Kannur Medical College, and is presently Consultant and HOD, Department of Dermatology, VPS Lakeshore Hospital, Kochi, and Consultant Dermatologist at Dr. Ebin Abraham's Dermatology Clinics at Kolancheri and Kottayam. Welcome, sir.
Good evening. I'm Dr. Ebin Abrahamati, Consultant Dermatologist at Lakeshore Hospital. Today, I'm honored to speak on the art and science of healing nail disorders. And at the outset, I'd like to thank the organizing team of the Association of Family Physicians, Kerala chapter, especially Dr. Shopa and Dr. Ali, for inviting me for this auspicious meeting. As we all know, nail has a lot of functions like protection, manual dexterity, and scratching is one of the common functions in our patients because they are having pruritic skin conditions. Now, with the advent of nail cosmetology, the cosmetic function is considered as one of the major role that the nail has to play. A pink and lustrous nail is equated with a good health and is often considered to be a measure of woman's personality and appeal. Coming to the nail unit, a bit of anatomy. It consists of the nail plate, which is around 0.5 to 0.75 millimeter in thickness, which rests on the nail bed. Nail is formed from the nail matrix, which lies below the eponychium. 80% of the nail is produced from the proximal part of the nail matrix, and the ventral layer is formed from the nail bed. So our talk would be revolving around these 6 major topics: nail shape abnormalities, attachment changes, nail surface changes, nail and color abnormalities, nail and systemic diseases, and of course the nail changes in specific skin diseases. So we'll just see one by one very briefly. Koilonychia is a spooning of nails, as we all know, that just becomes everted upward, the nail appears concave. It's seen physiologically in infants, and there are certain congenital causes for koilonychia. The main causes include, metabolic syndrome parameters like malnutrition, acromegaly, iron deficiency anemia, infections like onychomycosis, certain dermatological diseases like lichen planus, alopecia, and psoriasis. It's also seen in Renal's disease, certain occupational contact with oils, and upper GI malignancy. Clubbing, as we all know, is an increased nail plate curvature with soft tissue hypertrophy of the digital pulp. As physicians, you'll be aware about the causes of clubbing and how to address these factors. So I won't be going into the details of clubbing. We'll be moving on to pincer nails, which is transverse overcurvature of the nail plate, which can be hereditary or due to certain triggering factors like ill-fitting shoes, certain disease conditions like onychomycosis, fungal infections, tumors of the nail apparatus, or it's seen in psoriasis. There are different clinical types like trumpet-shaped nails, plicated nails, tile-shaped or omega-shaped nails. And often the best treatment would be complete nail avulsion with lateral digital matrixectomy using chemicals like phenol. Anonychia is a congenital absence of nail. As we can see on the photograph on the right side, the patient is having only the right big toe nail, all the other nails are absent. Macronychia and micronychia are normal nails except for their sizes. These are seen in certain ectodermal dysplasias, congenital onychodysplasias. And this is a picture of micronekia. You can see a small nail on towards the lateral aspect. Racket nails, the digital phalanx of the affected nails is shorter and wider than normal, giving the appearance of a racket. This happens because there's a premature closure of the epiphysis of the terminal phalanx at the ages around 7 to 10. It can be inherited in an autosomal dominant way. It's most commonly seen on the thumbnails. Polyonychia is the presence of 2 or more separate nails on one digit. Dolichonychia is a condition where the length of the nails greatly exceeds the width. It is seen in conditions like Marfan syndrome and hypopituitarism. Brachionechia is just opposite of dolichonychia, wherein the width exceeds the length. It is seen in hyperparathyroidism and cases of bone resorption like psoriatic arthropathy. Now, if we finish the first topic, moving on to the abnormalities in nail attachments. The first one is onycholysis, which is nothing but the separation of the nail plate from the nail bud distally. So there is a yellow or a white discoloration, which happens due to the air or debris accumulating between the separated nail and the nail bed. The most common causes is psoriasis, trauma, infections, and can also be seen in contact or irritant reactions due to excessive use of nail cosmetics. Certain drugs like tetracycline will produce onycholysis, and psoralens are also known to produce onycholysis. Plummer's nail is a type of onycholysis which is seen in thyrotoxicosis, mainly affecting the 4th and 5th fingernails. Onychomesis is what happens proximally. It is a separation from the proximal part at the nail matrix. So the nail loses its attachment and shreds. It's seen in conditions like pemphigus vulgaris. Is one of the typical features or the typical nail manifestations in hand-foot-mouth disease that is seen in children. Certain chemotherapy drugs and anti-epileptic drugs can produce this sudden shedding of nails. Coming to tertium, there are 2 types, the dorsal and the ventral type. The proximal nail fold fuses into the matrix and later on to the nail bed. As in dorsal tertium, it is typically described in lichen planus. It's also seen in pemphigoid. Ventral tertium, there's a distal extension of the hyponychium attaching to the undersurface of the nail plate, thereby obliterating the distal nail groove. So there is no separation of the nail from the underlying structures. This ventral tertium is seen in leprosy, neurofibromatosis, some cases of lupus, and systemic sclerosis. Coming to the abnormalities of the nail surface. Onycholysis is an increased longitudinal ridging on the nail, and the most common cause attributed is trauma. There can be central ridging in iron folic acid deficiencies, systemic amyloidosis, collagen vascular disease, and graft-versus-host reactions. Herringbone nail is a physiological change manifested as oblique lines which point centrally and meets in the center, seen in certain children, and it usually disappears as the child grows. I don't know whether you can appreciate that lines on this nail. And small lines are there which are oblique, directed towards the center of the nail. Fused lines are band-like depressions extending from the one lateral edge to the other. This represents a temporary cessation of nail growth, which is happening in the nail matrix. So when there are certain acute illnesses like fever, severe disease like heart diseases, extreme psychological stresses, the nail formation is stopped in the matrix, and this can produce some indentation, which will be seen once the nail grows again. Sometimes there will be severe separation, there's complete separation, which lead to onychomatosis or separation of the nail. Poor nutritional status and trauma is also implicated in the etiology. Onychoschisia is a lamellar splitting of the nails, which can be horizontal or it can be vertical. It is seen in trauma and retinoids. oral retinoids. Pitting. Pits result from defective keratinization of the proximal matrix with persistence of parakeratotic cells in the nail plate surface. This is a common nail abnormality seen in psoriasis, wherein we describe around 20 pits or more than 5 pits per nail as a diagnosis of which is characteristic of psoriasis. Usually the pits are coarse and irregular in psoriasis. Pitting is also seen in some other dermatologic conditions like lichen planus, alopecia areata, some cases of chronic eczematous dermatitis, vitiligo, etc. In alopecia areata, the pits are small, they are fine and regular, and it's also known as Scotch-Brite pitting or dimple pitting. Coming to the abnormalities of the nail color. Leukonychia is a white discoloration of the nail, which can be either true leukonychia, where the pathology originates in the matrix, and it is seen once the nail emerges out. It can be apparent where the pathology is in the nail bed, or it can be a pseudo-leukonychia. It can be due to an exogenous pathology like any fungal infection. And there can be punctate leukonychia, which can be due to trauma. They're characterized by white spots around 1 to 3 millimeter in diameter, which can occur singly or in group, which is very common in population. Mees line is a type of true leukonychia, which is associated with arsenic intoxication. A single or multiple transverse narrow whitish line seen along the width of the nail that can involve multiple nails. It's also seen in Hodgkin's disease, leprosy, tuberculosis, malaria, and herpes. Wilkes lines, they are apparent leukonychia. They are double white transverse lines. They occur due to an enigmatic state in the nail bed, which is exerting pressure on the vascular bed. It is seen in hypoalbuminemic states like nephrotic syndrome, glomerulonephritis, liver disease, etc. Half and half nail is typically described in chronic kidney disease with uremic failure. These are apparent leukonychia with a proximal half, normal half, and brownish discolored distal half. So distal half is the abnormal brownish discolored, and the proximal part is the normal part. You can see that brownish part distally. You can observe closely. Terry nail is just opposite of the Lindstedt nail, wherein the proximal part is white and the distal part is normal. It is seen in congestive heart failure, diabetes, peripheral vascular disease, HIV, hemodialysis, etc. Melanoma is one of the common conditions of the nail, which is creating a lot of anxiety in the patient. We get a lot of patients, when staff members coming to OP with this problem. After they search the net, a lot of diagnosis comes up and they're afraid and they rush to the OP. So this is a longitudinal transverse brownish black pigmentation of the nail. This is typically described in lichen planus. This can be constitutional. This is also seen in melanocytic nevus, which is the nevus arising in the nail matrix, which is one of the most common causes, other than lichen planus. Malignant melanoma is also an etiology. Certain drugs like antimalarials, minocycline, psoralen, chemotherapy drugs, methotrexate, etc. can produce melanoma. Other conditions include hemochromatosis, malnutrition, smoking, and Addison's disease. So when should we suspect melanoma? When you see a case of melanoma. So this is known as Hutchinson's sign. This is one of the indicators. There's a periankle extension of the pigment. You see the pigment extending onto the proximal nail fold and the lateral nail fold. This is one of the indicators, one of Hutchinson's sign. There's a pseudo-Hutchinson sign where it is not associated with melanoma, but it's seen in certain other conditions like non-melanoma skin cancers, Bowen's disease of the nail, and hyperpigmentation of nail, but as in nevi. So when you suspect a subungual melanoma, if you have this following dermoscopy features, when the longitudinal band of melanoma is broader, it's more than 3 millimeter in size, one indication. It's very dark brown or black in color. It is irregular colors along its length. It's fuzzy or blurred lateral borders. It's having irregular bands that are not parallel and often wider at the proximal end. The presence of pigmentation on the adjacent skin, that is Hutchinson signs, it we just described, when there is an associated nail dystrophy or ulceration. So this, if this is present in dermoscopy or microscopy, is an indication to do a nail matrix biopsy to rule melanoma. Coming to yellow nail syndrome, it's a triad of yellow nail discoloration with pulmonary manifestation of bronchiectasia, pulmonary effusion chronica, and lower limb edema. Yet the lunula is obscured with loss of cuticle. So we completed almost the nail color changes, and we're moving on to nail and systemic diseases. So there are a lot of indications, or there are a lot of nail changes mentioned in different systemic conditions. For example, in diabetes, all the nail infections are very common, like onychomycosis, paronychia, are much common. So it's not specifically related to that particular disease. So we'll just discuss about these few factors or few changes specifically associated with a systemic disease, most of which we have discussed in the previous slides. Case of true leukonychia, which is seen in arsenic poisoning. Apparent leukonychia is Milky's line seen in hypoalbuminemia. Lindstay's nail or half and half nail seen in renal disease. The Terry nail seen in hepatic cirrhosis. Your clubbing seen in cardiopulmonary diseases. These are the nail abnormalities specifically related with specific systemic diseases. So since the other part is very broad, we'll just skip it and move on to the dermatological disorders. Coming to psoriasis, wherein we have a lot of nail changes described. So once you think of nail changes, you always think of psoriatic nail changes and pitting, red spots on luna, leukonychia, nail bed crumpling, onycholysis. These are all changes because of abnormalities in the nail keratinization happening in the nail matrix. Salmon patches, which is a reddish brown discoloration beneath the nail plate because of the thinning of the nail plate. Suburban hyperkeratosis, accumulation debris beneath the nail plate, as you can see in the picture. Splitter hemorrhages all occur due to changes in the nail bed. Sometimes Bu's lines are also seen in psoriasis. So nail changes as an indicator of severe disease with chances of developing psoriatic arthritis. There are studies to show that nail changes is associated with distal interphalangeal joint involvement because of that contiguity, and also chances of enthesitis more in patients with nail involvement. So how do you treat nail psoriasis? We can give potent topical steroids under occlusion, topical calcipotriol. Intralesional injection would be, depending upon nail change, you can give either an intramacrucial injection or an intra-nail bed injection. You can see what's the route of entry of the needle. In severe nail involvement, you can go for oral medications like methotrexate, cyclosporin, and apremilast, which is shown effective in treatment of nail psoriasis. Coming to lichen planus, dorsal nail pterygium is a hallmark of severe nail disease in lichen planus. Red lunula, longitudinal ridging, fissuring, and pitting, along with are the other features. This picture shows nail pterygium. A 20-nail dystrophy or trachonechia is a brittle, thin nails with a sandpaper appearance involving almost all the nails. It can be seen in certain idiopathic conditions. Alopecia areata, nail lichen planus is one of the common causes of trachonechia. Also, it's seen in psoriasis. It can be treated with intralesional steroid injections, nail matrix injections, topical steroid, topical retinoids, that is tesarotin, and oral retinoid acetate in the dose of 0.3 to 0.5 milligram per kilogram shown to be effective. So this is how we give intra-nail injections. It can be intramatricial injection for disorders arising from the matrix, wherein we inject with the insulin syringe. Usually we inject triamcinolone acetonide to 0.5 to 5 milligram per ml, just above the junction of the proximal and the lateral nail fold into the matrix until blood is raised. And nail bed injections are more painful. We need to go deeper into the nail bed in the direction as shown in the picture. Coming to onychomycosis, which is the most common infective nail disorder. It's prevalent in males and with increasing age. Diabetes, peripheral arterial disease, immunosuppression are other predisposing factors. Mostly it is dermatophytic, caused by trichophytic rubrum, mentacophytes, yeast infections or mold infections. There are various clinical types of onychomycosis depending upon the modality of nail infection. Diagnosis by nail microscopy in a 40% carriage. You can see hyphaeus spores and also by culture, nail culture. This is a picture showing white superficial onychomycosis caused by dermatophyte trichophyte interdigital. It's colonizing the supermost layer of the nail without penetrating it. So this particular clinical classification, there is no involvement of the deeper layers. So you need an oral medicine to treat onychomycosis. Drugs usually given are terbinafine, traconazole, and fluconazole, along with topical antifungal in the form of solutions, creams, or nail lacquers. Terbinafine can be given continuously in the dose of 250 milligram, and always the dictum is the fingernails require lesser duration compared to toenails. Toenails require longer duration of treatment. You can give pulse therapy in the form of, in case of itraconazole, we give in a dose of 200 milligram twice daily for 1 week per month for 2 to 3 months, and for fingernails for 3 to 4 months in case of toenails. Fluconazole can be given in a dose of 200 to 400 milligram weekly for a few months. Depending upon the response, we can taper it and stop. We can stop it. And long duration therapy requires monitoring of liver enzymes. Peronica, as we all know, is inflammation around the nail, which can be due to chronic multifactorial etiology, with chronic exposure to retinal allergens, with damage to the cuticle, with this attachment of the proximal nail fold skin onto the nail plate. And there are a lot of, it can be because of bacterial, fungal, or any viral infections, which can be treated accordingly. And avoidance of the triggers is also very important. Green nail is onycholysis with greenish black discoloration. The Pseudomonas is the most common organism identified from the cultures. Chronic exposure to moisture is one of the factors implicated. Ingrown toenail is another common painful condition of the nail in patients coming with nail disorders. It's also known as onychocryptosis. Poor trimming of the nail with ill-fitting footwears, hyperhidrosis, poor foot hygiene are all implicating factors. It can be treated with conservatively with certain techniques like band-aid technique, wherein you put a band-aid or a sellotape, one end attached to the lateral nail wound as shown in the picture, and other end on the dorsal aspect of the finger. It can be applied at night, so it will give a little bit of tension to the lateral nail structure so that the ingrown part comes out. You can put a nail or a gutter splint wherein you cut an IV tubing into 2 halves, and it can be inserted into that ingrown margin of nail as shown in the picture on the middle. And the best treatment would be lateral nail plate avulsion with lateral matrixectomy by phenol or Triogen or by radiofrequency ablation. So I hope the talk was not boring. There are a lot of conditions, a lot of features, a lot of entities in nail. So the basis would be to understand the anatomy of the nail apparatus. Because as we have just discussed in psoriasis, we have changes happening in the nail matrix and changes happening in the nail bed. So, and the injection depends upon where the pathology is. So understanding of anatomy is important, and knowledge of these nail changes and its associations may help in early detection of skin and systemic conditions, as we have discussed in the slides. Because healthy nail is a matter of great cosmetic concern, and hence the detection and effective treatment of nail diseases has now become very important. Thank you so much for your patient listening. I hope the talk was useful to all. And thank you very much once again.
Thank you, Abin sir, for your informative session. Next, I invite Dr. Lissy ma'am to comment on the session.
Thank you, Dr. Abin. It was a wonderful session which covered most of the topics that we actually see in our practice. Especially you have told about the finer details of the ingrowing nail, which I actually liked a lot, because ill-fitting shoes and all these things will cause a lot of problems, which we can try many people won't prefer the surgery at the first instance, where we can try the band-aid technique or something, and other modalities which you told, and then refer the patient to the specialist. Probably will solve half of the issue. Other things I love is the description of the common diseases which causes the nail problems and the onychomycosis. Thank you, Dr. Abin, for this wonderful session, and thanks all the residents and other participants who are participating in this.
Thank you, ma'am. I invite Dr. Shobha ma'am to comment on the session.
Yes, thank you, Anaga. Dr. Abin is my colleague and a very good friend. So it was an honor having you here as one of the speakers. And really enjoyed your presentation too, because the main highlight of your topic presentation was the diagrams, because each and every, I'll start my video. Yeah. The main highlight was the diagrams, because that made it all very clear.
Ma'am, you turn off your video. You need to start your video.
No, I'm not allowed by the host. Okay. Start my video. Just 1 second. Yeah.
Yeah, it has started.
Yeah. Thank you so much. So I like the fact that there were so many pictures. No, it was very clear, Dr. Abin. So thoroughly enjoyed, and didn't know that there were so many conditions in the nails, even though we are familiar with a few of them, many of them. But one thing is that previous topic, we had some lifestyle modifications which we could apply to the particular condition. I think in nail disorders, lifestyle modifications don't play much of a role, I thought, excepting in systemic diseases. Maybe it's just one of the observations. Anyway, thank you so much. Yes, Dr.
Sorry to interrupt you. Dr.
Yeah,
Shobha.
no problem. No problem.
Yeah, I would add one lifestyle change which I usually advise my patient,
yes,
especially in cutting of nails, because most of us has a habit of cutting the nail too close or too inwards into the lateral nail fold area. So ideally, what we recommend is you need to cut your nails in a straight line. So that is one thing that can predispose to, especially for the toes, ingrowing, because that end of the nail becomes sharp and can get sharpened, and that will grow inside into the nail fold. So proper cutting of nails and avoid too much curvature at the ends. Just cut straight.
Okay. Thank you, Dr. Abin. Thank you for that advice. We'll be informing our patients, telling our patients too in the future. Take care to tell, explain. And it was a very nice presentation. Thank you so much. And it was an honor to be a chairperson in the 2 sessions, and an honor to have you have both the speakers too. And Dr. Lizzie ma'am, thank you so much. Thank you, Anaga.
Thank you, dear chairpersons and the organizing team. Thank you once again.
Thank you.
Thank you, Shobha ma'am. Thank you, Lizzie ma'am, for your valuable presence. And thank you, Abin.
One comment. Actually, we had some queries in the chat box. Sorry to interrupt you, Peter, because they have asked, Dr. Nadim has asked, is there a role of tamsulosin in female patients with ureteric calculi? Yes, in the distal, actually, it helps. That is what the randomized trials tell. There are only few studies, but they say yes, it has. And other warnings for role of Dr. Prashant has asked about role of potassium in renal calculi. It's in renal tubular acidosis and such kind of conditions where you get a renal stone, this citrate will help. I hope I clarified both the doubts. Thank you.
Thank you. Thank you, Dr. Lucy.
Thank you, Shobha ma'am. Thank you, Lissy ma'am, for your valuable presence. And thank you, Vishnu sir and Ebin sir for informative sessions. And now we can wind up this session. The next session will be started at 7 p.m.
Hello, ma'am. Are you sharing your screen, ma'am?
Welcome to the next session. The next session is on surfing the COVID waves. What do we really know by now? Our speaker is Dr. Mridul Murali Krishna, and our chairpersons are Dr. Vandana Agarwal and Dr. Mohammed Jassim. Let me introduce the speaker. Dr. Mridul Murali Krishna did his MBBS from Government Medical College, Thiruvananthapuram, and DNB in Family Medicine from MGM Muthoot Medical Center. He has worked as NHM Medical Officer in Kayamkulam District. Currently, Dr. Mridul is working as Assistant Surgeon in Kerala Health Services at FHC Chandanapalli, Pathanamthitta. Welcome, Dr. Mridul. Our chairperson, Dr. Vandana Agarwal, she is based in Delhi and is currently working as a principal consultant in internal medicine and preventive health. She graduated from Mahatma Gandhi Medical College, Jamshedpur, and postgraduated in family medicine in 2006. She's a passionate family physician promoting health education, lifestyle modification, and early intervention. She chairs the post of National Secretary of Academy of Family Physicians of India. Now, Dr. Mohammed Jassim, he graduated from Trivandrum Medical College and did post-graduation in family medicine under National Board, New Delhi. He has special interest in clinical neurology and rheumatology. His focus of work mainly involves internal medicine, rheumatology, headache, diabetes, obesity, and primary care. Dr. Jassim holds many national and international publications to his credit. Currently, he is working as consultant in Department of Internal Medicine and Rheumatology, UPS Lakeshore, Kochi. Over to you, Dr. Mridul.
Thank you for the great introduction. So now the topic COVID, most of you must be really bored by now, listening to facts about COVID. So let me first of all make it clear to you, I'm not going to much details about how we manage it in a tertiary care center. So let's begin surfing the COVID waves. Sorry. Yeah. So why this mind-numbing topic again? Primarily because it's still ongoing.
Can you please share your screen? Your screen is not shared.
I just. Oh, okay. Now, is it clear now?
Yeah, visible.
Okay. So why? Because it's still ongoing. Next is because this talk is primarily involved with family physicians and GPs, and they are still in the forefront. Next, as I already mentioned, it's not about the different protocols followed all over India. I'm just bringing some information to your attention, and over the course, I'll be mentioning some of my experiences as a family physician in a COVID second line treatment center here in Kerala. And the simple question is, am I giving you facts? What's just something else? So it's up to you. It's up to you to decide if you want to follow up on that and how to accept the facts. Just tickling your inquisitive minds. So what we plan to cover? Primarily, we'll be dealing with some comorbidities, some complications. It's mainly diabetes, hypertriglyceremia. Then about some medications which I have not seen much discussed around. Then about a single post-common COVID problem, which is really common. And some add-ons if it's possible. Now, why? Because I'm not sure I'll be able to complete it in the time. So we'll see. So the first one is diabetes. Diabetes is a drug. So hyperglycemia in COVID-19 patients have many manifestations. If the patient is already hyperglycemic, and the patient can have severe clinical problems. It's common to have ICU admissions, machine-driven ventilation. They have increased inflammatory markers, as you already know. There is a 2 to 4 times increase in mortality. And as you already know, the COVID virus, nCoV, has an affinity for the ACE2 receptors. So it mediates the SARS-CoV effects. And these receptors are most common in the lungs, the type 1 and type 2 alveolar cells, hearts, kidney tubules, enterocytes, and then the pancreas. So along with this, the diabetic patients have a higher circulating furin levels. All these leads to whatever we have already mentioned, the ICU admission, machine-driven ventilation, etc. In addition to that, and why the furin levels? The furin is a cellular protease that cleaves S1 and S2 domains of the spike protein. As you already know about spike protein, it's the most notorious one for the virus and the one we concentrate more for the vaccines. Now, this helps in the access of the COVID virus into the patient. Now, why diabetes? The thing is, if a patient is already hyperglycemic, like I already mentioned, the patient can have a very bad prognosis at times. And other is, we treat the patient with steroids. So, as steroids can induce hyperglycemia in the patient. And the third is, after COVID, post-COVID, due to the problems that the virus creates within the pancreas, a patient who was pre-diabetic or even not even a diabetic can become a diabetic or even a pre-diabetic. So, because the virus affects the beta cells, it causes an acute insulin secretion impairment or beta cell loss, and which leads to diabetes. So, the drugs. So, as you already know, insulin, it reduces, from animal studies, it was seen it reduces ADAM17 expression, and but we don't have any human data to support the outcome. Then again, we use metformin, sulfonylureas, pioglitazone, but pioglitazone causes an upregulation of the ACE2 receptors within animal studies. And again, it downregulates ADAM17 in human skeletal muscles. So it has a theoretical risk of poor outcome. Similar is the case with liraglutide and SGLT2 inhibitors, which are like, as some people already say, is a drug that's there for the next 100 years. So it promotes promotion of renal ACE2 activity. Hence, it can have a poor outcome. Then there's DPP4 inhibitors, which cause severe disease in animals, and it can overall exert an anti-inflammatory role. So theoretically, DPP4 inhibitors can modulate and offset cytokine-mediated COVID complications. Now, steroid therapy. It's like one of the life-saving drugs. When initiated properly, we all have noticed that patients have a significant better outcome. So I'm not going into details how a steroid works, and because I know you already know, because it increases hepatic gluconeogenesis, blocks the action of insulin, reduce uptake of glucose by the peripheral tissues, and reduction of action of the beta cells. So all these leads to hyperglycemia. Again, the patient can have a very bad outcome. Now, how to approach a patient who has steroid-induced hyperglycemia? Now, we should actually find the reason why the patient has hyperglycemia. Hyperglycemia can be due to stress, like the patient's own cortisol levels can increase, and the patient is having a COVID infection, and we are giving steroids. So all these leads to the patient having hyperglycememia. And what can we do as a physician? So primarily, we do an HbA1c testing. When we do it at the onset of the disease, if the patient is saying I'm not a diabetic, and the patient is already having a very high HbA1c level, that says he's already a diabetic. Next is check for the pharmacokinetics of the steroid if prescribed, and advise the patient to perform SMBG. SMBG is self-monitoring of blood glucose. Ensure daily glucose monitoring with fasting blood sugars, post-breakfast, post-lunch, post-dinner. And in critically ill patients in ICUs, maintain the glucose within a target of 140 to 180. Check for blood ketones if the blood sugar is more than 250, because decay is common. And next is educate the patient on diet and lifestyle, which I prefer. It's the most important thing. The next is prefer rapid-acting analog insulins as pre-meal and correction bolus, and to avoid physician inertias. Now, how to treat the hyperglycemia? I'm not going into much details about that, because you've already dealt with this. And one of the notorious drugs that I've seen at that time is our next topic, hyponatremia. It was seen and mentioned by one of my colleagues that sulfonylureas have a very high risk of producing SIADH. So it's actually mentioned in their side effects. So at times, some patients can develop SIADH. It might not be because of the drug. COVID as such has a propensity for causing SIADH. So the management of hyperglycemia, it differs from patient to patient. It has to be based on your what you feel at that time. So anyway, even if you're giving insulin, I'll advise that you also give metformin, because insulin is a drug. The most common side effects you already know. It causes hyperglycemia, and insulin also causes insulin resistance. And insulin resistance is the cause of type 2 diabetes. So we don't want the patient to become a diabetic after our treatment. Next topic is hyponatremia in COVID-19. Hyponatremia is frequently associated with atypical pneumonia. And so it's also actually very common in COVID. And these are the symptoms of hyponatremia, which I don't think I have to elucidate on. So it's the most common electrolyte disorder in COVID-19. The mechanism was not entirely understood. So it might be because of systemic inflammation. The non-osmotic, it acts as a non-osmotic stimuli for vasopressin production. Again, the patient has the cytokine storm, interferon checks, which also causes SIADH and hyponatremia. Intravascular volume depletion, the baroreceptors and the RAS gets activated. The baroreceptor, this is a baroreceptor mediated non-osmotic ADH secretion occurs and leads to SIADH. And the next is decreased intravascular osmolarity. The osmoreceptors activate and increases ADH secretion. So, what's more important? We need to have an early clinical judgment of the patient's volume status. So why? Because if you have actually, we have PG students also. So if you have actually read about it, hyponatremia management is not always treating with just giving sodium and give rice water rich in salt, or just giving hypertonic saline. So we have to decide between fluid restriction and fluid replacement strategies. So because for that, we need an early clinical judgment of the volume status. So we have to go with a cautious and conservative fluid resuscitation, because that can also lead to the patient is already at a risk of developing ARDS. So we have to avoid pulmonary edema exacerbating the underlying respiratory distress and pulmonary inflammation. So the use of serum osmolality, urine osmolality, and urine sodium is crucial for a correct diagnosis of why the hyponatremia. Next is about the drugs. So I am quite sure all of you know about montelukast. It's commonly prescribed for asthmatic patients, seasonal allergy. The list goes on. Why here? It blocks the action of leukotriene D4 in the lungs. This leads to decreased inflammation and relaxation of the smooth muscle. The common side effects are diarrhea, nausea, vomiting, mild rashes, symptomatic elevations of liver enzymes, and sometimes fever. And uncommon side effects include fatigue, malaise, and behavioral changes. It can cause, some studies have shown that long-term montelukast can cause depression in some patients, paresthesias, seizures, muscle cramps, and nosebleeds. So why montelukast? It has shown some viral inhibitory role, mainly with Zika virus, Zika-like flavivirus, and also it can reduce dengue shock syndrome. So we don't have a definite study that says it is inhibitory to COVID. But again, the patient is already having severe rhinitis and all other symptoms. So adding in montelukast might even also give symptomatic relief and might give an extra add-on addition with the nCoV virus. It attenuates the frequency and the severity of episodic wheezing in children. And usually montelukast comes in a combination, like it comes alone and also comes in a combination with levocetirizine or fexofenadine. So it can, along with levocetirizine, it may stop the cytokine storm because it inhibits the production of intracellular adhesion molecules, ICAM1, and the secretion of interleukin-6 and interleukin-8, which theoretically should have a beneficial effect on the pathophysiologic changes associated with COVID-19. So it is pertinent to say, recently a hypothesis was reported by Sian Fidan et al., where the author has described a potential treatment of COVID-19, montelukast, with an anti-inflammatory role. Now, this is just showing how montelukast can have beneficial effects in relation to COVID. One is the effect on the virus as such. Then there is effects related to the host. Then preventing ARDS by decreasing the cytokine storm. And again, the tissue sequelae because of its antioxidant and antifibrous properties. The next drug is N-acetylcysteine, which is now I think it's a very common drug in the private practice session, more commonly known as Mucinex, or some people use it as Palmoplay, which is azathioprine with N-acetylcysteine. So these drugs are quite common now. So why in COVID? The cellular immunity to fight viral infection, it's primarily regulated by the oxidant and antioxidant balance. Now it's maintained by antioxidants including glutathione. In the immune cells of elderly or immune compromised, the reactive oxygen species is quite increased due to decreased levels of glutathione. And this causes a dysregulation of immune responses, particularly the T cell mediated functions. Now, N-acetylcysteine is a precursor of the antioxidant glutathione. And it has been used to treat clinically ill septic patients and more recently for COVID-19 patients. N-acetylcysteine has antioxidant, anti-inflammatory, and immune modulating characteristics. So they may prove beneficial in the treatment and prevention of SARS-CoV. It's also used for loosening mucus. And again, it is so more beneficial in COVID patients. It also can boost the immune system, suppress viral replication, and reduce inflammation. And studies have shown oral administration to improve cell-mediated immunity. Now, how to administer? It can be given for those who have not contracted COVID yet, 600 milligram twice daily. If there has already been an onset of symptoms, 1200 milligram twice daily. Relatively severe, but without airway obstruction, you can use it as inhaled. So allergy patients should use antihistamine before taking it. Then clinically confirmed pneumonia or dyspnea, you can use it as along with other medications, IV N-acetylcysteine, intermittently or continuously. Studies have shown that both are the same. And it can prevent ARDS. And in a patient with ARDS, using N-acetylcysteine can avoid irreversibly fatal multi-organ failure. Next is curcumin. It's a common thing, and most of us might have heard because our patients will be asking, does this work? Does taking turmeric work? So phytochemicals have been proven effective against previous episodes of virus outbreaks over the last 2 decades. So these are studies regarding that. And major bioactive component of turmeric is curcumin. Now, it can confer curative and preventive effects, studies have shown a stable interaction between curcumin and SARS-CoV enzymes. Now, this is just showing how it works when related to AC receptors and the virus entry. Again, the same. Just a concise way of showing that preventing the cytokine storm reacting oxygen species, preventing fibrosis, preventing the virus absorption, replication, and attachment. So, the best of the review literature to date, there is no laboratory or clinical investigation which confirms the potential of curcumin against SARS-CoV. However, inhibitory effects against other related coronavirus and respiratory viral infections promise the potential. So, however, curcumin has a low bioavailability because it does not dissolve well in water and it's unstable in aqueous media, and especially in a higher pH. Usually, how we take it, when orally administered, it undergoes rapid metabolism in the gut and the liver. So absorption is difficult, and for that we use nanosystems. Nanosystems are nanostructured carriers that can be used for this, like nanoemulsions, microemulsions, nanogels, micelles, nanoparticles, and these prevents the metabolic breakdown of curcumin. Next is genetics and immunity in COVID. Now, why this? Because it's related to both the COVID infections and how we take the vaccines. Because individuals' immune response to SARS-CoV may be limited by their MHC genes. These genes are the ones that present the antigen to our body. So the poor presentation of key RBD fragments by many MHCs has been seen. And because of that, along with that, the impact of newly discovered mutations. The mutations, the topology of the mutations in these new variants indicates that further potential breakdown of this immunological relay between the T and the B lymphocytes, and an additional negative impact on the ability of the individual in the global population to generate a high quality, long living, neutralizing antibody responses. That is, the vaccines might become less effective in some, and it can be really effective in others because of these facts. Next is the word coercion. Okay. So these are about historical references, deep understanding. This is about a genetic study. Then a chronic fatigue syndrome. Again, it's a complication of COVID. And just going through it, I'm just talking about L-carnitine. It's actually helpful and used in chronic fatigue syndrome. Now we have to flatten the infodemic curve. And Omicron, I'm just waiting on the answers. I know you might be really bored now, so I'm just showing you some mythbusters. Just go to the link and you'll see it. So that's it. I think I just rushed through some topics. The thing is, it's quite large. And I think I conveyed at least one or two things that you might take home. Thank you.
Thank you, Dr. Mridul, for that relevant talk in the present scenario. Over to the chairpersons for their comments.
We are muted.
Good evening. A very, I will say, innovative presentation rather. So, 5 things I could take out from your presentation. Type 2 DM, we all know it has been disbalanced throughout the COVID period. We concentrate more on the lung in the first and second waves rather than the diabetes. And later on, all the family physicians were dealing with the uncontrolled or newly found diabetics. Very true there. Hyponatremia, personally, I don't have much experience of this. Like yes, fluid management was a difficult part during the COVID scenario because we were not all the time there. And either patients were going into lung failures or they were having high-grade fevers. So fluid management was a difficult part there. As far as your Montelukast, N-acetylcysteine and curcumin part is there, from what I know of, there is no fixed guideline of these drugs. They are considered as a symptomatic treatment, not the guidelines to treat the inflammation of the COVID. For the past 5 days, I have been, searching and researching the Omicron management. Still there, the symptomatic part, and they just said you have to take care of the inflammation. For that, till now, I think steroid is the drug.
So we could not hear the later part of your presentation because of the time issues. Maybe we'll discuss later. But yes, I've been, listening to all your presentation, very innovative one. And yes, it gives a family physician post-COVID all the time thinking, rethinking, and managing. Thank you so much.
Thank you, madam. Like I already mentioned, I am not mentioning about anything about the protocols. These are just we are taking a
the thought process, very innovative one. Yes.
Good evening. Can you hear me?
Yes, you're audible.
Yeah. Okay. Mridul, I would like to comment on your presentation. It was an enthusiastic and entertaining presentation, rather. So thank you for the visuals and the slides. And commenting on COVID, as far as COVID is concerned, I would like to be seeing it more as a physician rather than the patient, because it is very creative when you see from the patient side. So we have been through some notorious terminologies with regard to COVID since it came into existence, like lockdown and quarantine. Then another thing was antibody cocktail. Then day by day, new antivirals are coming. Actually, we are confused, both as physicians wish to prescribe. And so as far as COVID is concerned, it's still an ongoing puzzle in the field of medicine. And as Madam has very well communicated that with regard to your presentation, what I have also felt that whether it be vitamins, multivitamins, minerals, antioxidants, all sort of gimmicks which we see, does it have a role? It is actually a thought-provoking statement. So in this scenario, and today, what I have seen something new in regard to COVID is that I have seen a new terminology which is known as protection dose. So till now we are hearing boosters, vaccine boosters and all, but what Indian government has put forward is something known as protection dose. So when you consider old age people more than 60 years and those with comorbidities, they have given I think from January 10 onwards, they are starting protection doses of vaccine. Actually, that is an interesting terminology, rather than commenting it as a booster, because as far as boosters are concerned, when you practice evidence-based medicine, actually apart from Pfizer and Moderna, the mRNA vaccines, the boosters when compared to Covishield or Covaxin, the boosters, we don't have much studies. But protection dose is an interesting terminology which we follow as far as influenza virus and all is considered. So again, I would like to thank you for the beautiful presentation. Actually, there was some time limitation, so thank you.
Yes.
Thank you, Dr. Mridul. Thank you, Vandana ma'am. Thank you, Jason sir. Let's move on to our next session. Next session is on newer advancements in insulin in the treatment of diabetes mellitus. Speaker is Dr. Surya. She did her MBBS and MD in pharmacology from Pondicherry Institute of Medical Sciences. She has also completed certificate course in evidence-based diabetes mellitus in Mohan's Diabetes Academy. Her fields of interest are diabetes and obesity. She has participated in various regional and national conferences. She has been a part of the organizing committee in various workshops like insulin workshops, pharmacovigilance, etc. Dr. Surya is currently the regional medical advisor in Novo Nordisk under insulin wing covering Tamil Nadu and Kerala. Over to you, Dr. Surya.
A very good evening all. I just wish you all a very happy new year, and so happy to be a part of this conference, and that too a very interesting topic, newer advancement in insulin and the treatment of diabetes, which is going to be my...
Sorry for interruption. Ma'am, you are not perfectly audible. Your voice is breaking.
Okay. Just 1 minute.
Can you try without headphone if possible? Hello. Hello, Dr. Surya. Ma'am, you are not audible. Ma'am, can you
Dr.
rejoin the
Surya?
meeting?
Sorry for the interruption. There is some technical issue. We shall restart soon.
Affection lies in small details. Comfort lies in small details. Confidence lies in small details. Beauty lies in small details. Welcome to Microlabs, where health lies in small details. It was with this core value that Microlabs was incepted in 1973 by the late Mr. G.C. Surana. Today, Mr. Dilip Surana and Mr. Anand Surana bear the torch of creating a healthier world by making Microlabs a growing transnational.
Should I click speaker? It is same as system only. A microphone array is there. Under the microphone, I have two options, same as system and microphone array. In that case, I will do one thing. I'll connect to my iPad and can you please project my slide? Sorry for the technical issue. We will be resuming the session soon. Let's move on to the next session. Over to Dr. Namita to start the next session.
Hi, a very warm good evening to one and all. I'm Dr. Namita Unnikrishnan and I work as a registrar in the Department of Family Medicine at KIMS Health Trivandrum. I welcome you all to a very special session, Keep Your Cool in Life School, Tips for Mental Health by Dr. Amina Okay. This is a very interesting and much needed to be discussed topic. A few words about Dr. Amina. Dr. Amina did her MBBS from Sri Gokulam Medical College, Trivandrum, and completed her DNB in Family Medicine from Luth Hospital, Ernakulam. She is a treasurer, AFPI Kerala, North Zone. Currently, Dr. Amina is working as a family physician at FHC Vattankulam, Malappuram, Kerala since 2017. I welcome Dr. Vandana Agarwal and Dr. Mohammed Jassim to share the session. Over to you, Amina.
Thank you. Thank you. So how?
Hello, Dr. Amina.
Yeah, I'm here.
Okay, now you're audible.
My screen is visible, right?
Yes, ma'am. Can you make it full screen?
Yeah. Okay. So today I'll be dealing how to keep your cool in life school. So we can't change the world around us. What we can change is how we perceive situations around us and how resilient we are. Stress, acute or short-term stress is good for us. It helps us stay focused and take appropriate action. But chronic stress, as in our today's society, is harmful to us. When an event occurs, you sense danger and brain's nervous system get activated. A cascade of hormones get released, and in response to that, flight, fight, and freeze response occurs. Heart rate and blood pressure increases, breathing quickens, muscles tense, immune system gets activated, liver releases glucose to give you energy, platelet becomes stickier to aid clotting and stop bleeding. Digestion, reproduction, and other non-essential functions shut down to preserve energy. So it is impossible to sidestep all sources of stress. Relaxation response must be elicited regularly to make beneficial changes in the genes, and consistency is the key. And chronic stress can lead on to panic or exhaustion, aches and pains, sleep problems, gastro and immune problems, anxiety and depression, low focus and motivation, irritability, unhealthy eating, addiction, sex drive, cell damage, and premature cellular aging. The brain areas affected by chronic stress include hippocampus, amygdala, prefrontal cortex, and it leads to memory problems, anxiety, phobia, panics, and executive function problems. A healthy brain has a low level of underlying arousal and it is calmer. It responds better when stressful event occurs and it recovers quicker after becoming stressed. And it has an enhanced cognitive reserve. So the different phases of stress that we see are work, health, related to work, health, finance, and relationship. And cell phones, telecommuting have breached the wall between work and leisure time. So first key to a healthy and relaxed brain is practicing mindfulness. So mindfulness is being in the moment without any judgment, and it is not difficult to practice. Only thing is we should remember to practice it. And studies have shown that brain's frontal cortex are thickened in experienced meditators who elicit relaxation response through mindfulness at least 20 minutes a day. Also, MRI images taken after 8 weeks of meditation program shows an apparent shrinkage of amygdala volume, which regulates your emotional response to stimuli. With smaller amygdala, you have lesser levels of stress and anxiety. So, how to meditate? Choose a calm and quiet place without distraction. It involves learning to focus an object of attention, and there are different types of meditation: breath focus, body scan, guided imagery, mindfulness, yoga, tai chi, which are meditation in motion, and repetitive prayers. So initially it will be difficult. Your attention drift to worries. Gently redirect your mind back to focus. Also, at some places like in kitchen, study room, we tend to overthink with negative thoughts, and at that places you can use signs or colors like red dot or blue dot to tell your mind to stop overthinking. Instead of choosing one type of meditation, sample many, and some work better for you than others, and embrace a routine. Brush your brain regularly, at least 10 to 20 minutes daily. And if you cannot, if you don't have time, you can do different 5 minutes segments spaced throughout the day. So resilience, what is resilience? It's the ability to bounce back from difficult or stressful experiences. So your wellness depends on both the total amount of stress in your life over which you have little or no control over, and your ability to deal with it. How to boost your resilience? The first step is to change your mindset. Key isn't to deny stress, but to recognize and acknowledge it. Ask yourself why you are experiencing it. Look for any positive aspects of it. Are you learning something from it? Are you gaining strength? And regular exercise boosts metabolism and mood, and it reduces stress and improves the resilience by triggering the release of endorphins, and it focuses the mind away from stresses. It also improves the blood flow to brain and creates an energized feeling. Eating well, fat and sugar laden foods seem to dampen stress related responses and emotions, but it is very temporary and leads to blood sugar crash and increased hunger again. Comfort for foods long term is harmful. Also, avoid screen during eating. Short-term stress leads to a release of epinephrine, adrenaline, and corticotropin releasing hormone, and it reduces the desire to eat. Whereas long-term stress, it releases cortisol and increases the desire to eat. Serotonin is a neurotransmitter which regulates mood, appetite, pain, and sleep. And 95% of serotonin is produced in GIT. So mental health is related to gut health. Healthy gut bacteria improve production of serotonin. Fruits and vegetables increases serotonin production. And a proper sleep and rest is inevitable for boosting resilience. Have a consistent routine. Get morning light. Limit naps during daytime to less than 30 minutes. Avoid all electronic at least 1 hour before bedtime. Minimize alcohol. Write down your worries. Create a comfortable sleep environment, and don't spend too much time on bed if you are awake for more than 20 minutes. Seek support and well-being. Ask help when needed, and when doubt, work as a team. Practicing positive psychology is a method to boost resilience, and include nurturing gratitude. You can either practice by writing at least 5 things you are grateful for in your life every day, or you can discuss what you're grateful for in your life during dinner time. Laugh often. Savor small pleasures in your life. Use your inner strengths. Perform random acts of kindness. Let go of past or bottled up emotions. Next is cognitive restructuring. Negative self-talk has shown to increase stress, and cognitive behavior therapy is built on the premise that thoughts and perceptions shape moods and emotions, and distorted thinking can be changed with practice. There are 10 common cognitive distortions. Check whether any of these resonate with you, and make a list of it and try to resubstitute with more realistic positive thought. So the cognitive distortions are all or nothing. Everything is black and white. If you don't perform flawlessly, you consider yourself a complete failure. Overgeneralization. One negative event from anyone is perceived to be a part of an endless pattern of dismaying circumstances and defeat. Mental filter. One negative comment made to you during an otherwise enjoyable evening shades everything else. Disqualifying the positive. That is, you are unwilling to or unable to accept a compliment or praise. Jumping to conclusion, especially negative ones, and you may be mind reading. Magnification or minimization. That is, you exaggerate problems and minimize the things that make you feel good. Emotional reasoning. You assume your negative emotion reflect the way things are. Should statement, adhering to a rigid set of beliefs and internal rules about what you should be doing, and feeling guilty when you don't stay on the course. Labeling. Rather than describe a mistake or challenge in your life, you label yourself negatively. Or when other person's behavior bothers you, you pin a global label on him or her. Personalization. You blame yourself for triggering negative event that occurred for complex reasons or for something that was largely out of your control. So when these thoughts, negative thoughts or distortions come, stop. Tell your mind to stop overthinking. Take a few deep breaths. and reflect. Ask yourself these questions. Is this thought or belief true? Did I jump to conclusions? What evidence do I actually have? Is there any other way I could view the situation? What's the worst that could happen? And does it help me to think this way? And choose an appropriate action to deal with your stress. And learn to communicate better, listen actively, and communicate assertively without judgment. Practice to nurture yourself, comfort your body, eat healthy, lie down and rest, take a walk, get a massage, give yourself encouragement as you encourage a good friend. Try loving kindness meditation, or always have creativity and leisure in your life. Practice these key points in your life. Focus what you focus on grows, discipline and consistency, practicing gratitude, live without expecting validation from anyone, and practicing to say a no if it's a no. Delegate the job and develop hobbies. Thank you.
Dr. Amina, good evening.
Good evening.
A very beautiful presentation.
Thank you.
So this conference is for doctors. You have mentioned many points for keeping your mind cool. Agreed, so many things are important for life. But as a busy practitioners and with passing 2 years of pandemic, this is the 3rd year we are facing this. What 2 things you think that is too important for the doctors to follow in regular life so that they can keep their minds cool? With so much around to do, no time to eat, no time to sleep, so many calls, so many people angry, so many messages, so many things, so many gadget messages, online consultations, and you hardly find time for all these things. What 2 or 3 things you think is the most important thing we can inculcate our life to keep our minds cool? These all things I keep telling to my patients. What do I do for myself?
But I think we should practice these things for our own well-being, because only when we take care of ourselves, only we can take care of others. So getting a proper sleep is very important. Also eliciting a relaxation response, I think it is very important. At least being mindful in what you are doing. Don't be stressed about what will happen in the future. Whatever you are doing, be mindful. That is, you shouldn't you don't have to do meditation and all. Just be in the present moment without any judgment.
Okay, what my experience is that if you have any hobby, maybe you can take out half an hour for your hobby.
Yes.
Or exercise surely breaks your stress. 2 things I personally always felt.
Yeah,
Dr. Shobha says, yes, practice self-love. That is excellent. We all should do that. Thank you so much. Over to you, Dr. Jasmine, if you have something to say.
Yeah. Hello, Dr. Amina. It was a wonderful presentation. And as far as we doctors are concerned, the question which was put forward by Vandana Madam is interesting. So what I would like to answer for the question is that you keep your mobile phone 30 minutes from your life every day. Nothing is going to happen with that. And another thing is that, yeah. And another thing is that you spend 30 minutes of your day with your family. If you are able to get 1 hour, that will reduce your stress to a lot extent. Then, coming to the practice wise, as a family physician, which most of us see in our OPD is that 90% of our patients has complaints of muscle pains, muscle aches. And when you draw a trajectory and when you approach these cases, you will end up all this cause is a result of stress, where you have stress, pain, and sleeplessness contributing to the most exotic diagnosis of what you call as fibromyalgia. So when you consider your practice, stress do have an important role to play, and managing stress is ultimately difficult. All these things we tell to our patients, but will they be able to do And the question which Madam has put forward, are we able to do, is a $1 million question in regard to the topic.
So we should have a group, I think, of something where people can be motivated for this. There should be societies and groups that are really important.
Personal experiences, meditation helps a lot, I think. Exercise and meditation, both of them.
Okay, Dr. Amina, thank you so
Yes.
much.
Yes, that was a very refreshing discussion. Thank you, Dr. Amina, Dr. Vandana Madam, and Dr. Jasim Sir. Over to you, Dr. Surya, for the next session.
Thank you. I'm very sorry for some technical issues. I think we can begin with the presentation without any further delay. Can you just please share the slides?
Yes, ma'am. Is it visible?
Yeah. Yeah. So the topic of my discussion would be the newer advancement in insulins in the treatment of diabetes mellitus. Next slide, please. Yeah, the agenda of my topic, initially we have a small introduction, and then I'm going to discuss about the advancement in the basal insulins, bolus insulin, and the premix, finally summary and conclusion. Next slide, please. Over the past 100 years, more than 10 different categories of anti-diabetic medications are being developed, for which insulin has been awarded the Nobel Prize. Next slide. So this slide tells us that importance of insulin discovery. How did humanity benefit with the discovery of insulin? By when, if you see in the 1945, a child was diagnosed with type 1 diabetes at the age of 10 years could expect to live more than 30 years longer than a 10-year-old child diagnosed with type 1 diabetes. Next slide. So this is the breakthrough innovations of post-discovery, where you can see starting with the Banting and the Best experiment, and then there is a production of the first insulin in the year 1923, and the Nordisk has launched the lenti insulins, and also when you look into the biphasic insulin has taken its role in the year 1959, and the H-Stone et al., where the protamine insulin took place. Next slide, please. So here in this slide, you can see the first successful semi-synthesis of human insulin has taken place in the year 1976. And also in terms of the pen devices, 2001, NovaRapid FlexPen is marketed, and 2004, Levemir is launched. And also you can see in the year 1999, NovaRapid is marketed, and Sanofi launched its insulin Glargine in the year 2000. Next slide, please. So the new generation insulins marking the milestones, we need to understand there are four important landmark years. In the 2013, Tresiba is launched. In the year 2014, Ryzodec, which is a co-formulation of Degludec and Aspart, that has been launched. In 2015, Toujeo, which is Glargine U300, that is launched. In 2017, Fias. So let us go in each insulin in detail in the future slides. Next slide, please. Yeah, these are the available basal insulins. Already we have the NPH insulin, insulin Glargine U100, Detimir, and insulin Degludec. So you can see the onset of action, peak duration of action of all these insulin, where the NPH being an intermediate acting insulin, the onset of action is quite slow, 2 to 4 hours, and the peak effect you can see is 4 to 10 hours. So the total duration of action will be 10 to 16 hours. But when you look into the other three insulins, which are the peakless insulin, with the insulin Glargine, you can see the onset of action at 2 to 4 hours. And with the Detimir, it is 1 to 4 hours. But all this depends on the individual patient. The physician can either go with once daily or twice daily dosing. The most important thing to be noted here is the insulin Degludec, being an ultra long-acting insulin, has got an onset of action at 1 to 2 hours without the peak, and the duration of action is going to be more than 42 hours. Another important difference here we need to understand is with the NPH insulin, the nocturnal hypoglycemic risk is more, following which you can see the evolution with the insulin Glargine and Detimir. These two in comparison to the Degludec has got an increased glycemic variability. By when the Degludec has got an outstanding profile of longer half-life, and also the variability is quite less, 4 times lower than the Glargine, and steady state is reached after 2 to 3 doses. Next slide. Yeah, so this is the concentrated glargine U300. So here you need to understand the main important mechanism of this glargine U300. So comparing to glargine U100, this particular glargine U300 is going to deliver the concentrated glargine at a higher concentration. And not only that, since it is having an acidic pH, once it enters into the subcutaneous depot, it is neutralized and it will form a microprecipitate by when there is slow release of the insulin. That is why there is a smaller surface area and the reduced rate of absorption. In terms of the half-life, when you look into, with a glargine U100, it is going to be 12 hours and U300, it is going to be 16.7 hours. Overall, the duration of action is going to be less than or equal to 36 hours. Next slide, please. Yes, the insulin deglutide being ultra long-acting insulin. So here, the main structural difference is the threonine is omitted. With the DES B30, the acylation happens. Mainly, the purpose of acylation is something going to increase the duration of action in terms of slow release of the drug. So where the glutamic acid spacer is being added along with the fatty acid side chain. So that is a specialty of this ultra long-acting deglutide. Next slide, please. So in this slide, they have mentioned about the mode of protraction. So when it comes to insulin, we need to understand a concept called protraction. As we know that there are three things which we need to understand the basics of insulin. Any insulin, it is going to be in three different forms. One in the solution, that is a formulation, and then when it is injected in the subcutaneous tissue, it will exist in one form. And when once it is released into the circulation, it will be in different form. So when you take deglutide, as such, in the formulation, it exists as a dihexamer. So along with the zinc and the phenol as a preservative. So what happens once it is injected in the subcutaneous tissue, the phenol slowly it gets diluted. So once it is diluted, what will happen? This dihexamer, they will undergo self-association and they will form a multi-hexamer. So this multi-hexamer further on with the removal of zinc. So the zinc slowly gets detached. And what happens? This dihexamer further, it will disassemble, resulting in the dimer and finally the monomer. So you all need to understand the most important active form of any insulin is going to be the monomeric form. Next slide, please. So the usage of basal insulin in special population, this is just to highlight and also get an understanding which insulin can be used in different special populations. So the most important thing to be noted here is that in terms of pediatrics, the NPH insulin can be used and the glargine and detimol can be used more than 2 years, whereas deglutide can be used more than or equal to 1 year. And in terms of the CKD and chronic liver disease, those three basal insulins are going to be safe, and among which the insulin deglutide is going to have a better impact in the patients with chronic kidney disease and also in elderly in terms of reduced risk of hypoglycemia. And in pregnancy, so far none of the insulin have been properly approved, whereas the insulin detimol has got approved in pregnancy. Next slide, please. So with this, we have done the basal insulin. To summarize, each insulin has got a different advantage and disadvantage. As we have discussed before, NPH has got the increased risk of hypoglycemia, especially the nocturnal hypoglycemia. Whereas when you look into the glargine U100 and U300, the only difference it is going to make is in terms of the duration of action, and also the risk of hypoglycemia is quite less comparing to glargine U100. And detimol is quite going to be similar as glargine. But when you look into the deglutide, the most important thing is once a day dosing, and the flexibility of dosing is quite good because here the flexibility is 8 to 40 hours. Whereas with the glargine U300, it is going to be plus or minus 3 hours. And not only that, with the deglutide, the cardiovascular safety is very good in terms of, there are various studies conducted. One is a DEVO trial, and also it is available in an excellent pen device. Most importantly, the glycemic variability is going to be less with the deglutide. So with this, we are completing the basal insulin. Now let us move on to the bolus insulin. Next slide, please. Yeah, these are the available bolus insulins. One is a regular insulin, insulin aspart, lispro, and glulysin. So the regular insulin, when you look into, the onset of action is going to be 30 to 60 hours with a peak effect at 2 to 3 hours, and the duration of action is going to be 3 to 6 hours. Whereas when you look into the other three fast-acting insulin, that onset of action is less than 15 minutes, and the peak effect is 1.5 hours, and the duration of action is going to be 2 to 4 hours. So what are the limitations of failure with the regular insulin? One is a delayed onset of action. You all know the bolus insulin is one, it is given at the timely prandial phase, that is soon after the meal. So if there is a insulin should have a property to produce a immediate effect. And number two, when you look into the lower and delayed peak insulin level, again the peak effect in terms of the regular insulin is going to be little delayed, which is of 2 to 3 hours. And also, if being a short-acting insulin, the duration of action is little longer, which can increase the risk of hypoglycemia. Even with the bolus insulin, you need to understand there is a mode of protraction. It exists as an hexamer, and then it disassembles to the dimer and finally to the monomer. Next slide, please. Yeah, so the newer prandial insulin, what is the advancement, which is called PRs, which is a faster acting insulin aspart. So what is the difference over the insulin aspart? There are two excipients which is being added. Number one is niacinamide, which is nothing but vitamin D3 and L-arginine. So the niacinamide, it is going to be the absorption modifier. Mainly, it will accelerate the absorption of aspart by impacting the self-association earlier to promote the monomeric formation. And number two is L-arginine is basically for the stability of the molecule. Next slide, please. So can you just click on this slide? Yes, so this is actually a 3D animated video showing that we have 3 different insulins where the monomeric form dissociation will be quite quicker with a faster aspart, which is really needed in terms of to say that it has to match the physiological release of insulin. Next slide, please. Yes, again, the bolus insulin used in special populations, both in the CKD and CLD, all this insulin aspart, lispro, even with the insulin glulysin, the insulin dose adjustment have to be done. With the faster aspart, no, exactly, there is no specific effect on the PK parameter. And in terms of the pregnancy, the insulin aspart is commonly used, but very recently, if you look into, many of the obstetricians are preferring faster aspart because of its immediate effect, and also it is closely matching with the physiological release of insulin. And all these insulins we can even use with the IT setting, and once the patient gets discharged, it can be converted to the subcutaneous route as well. Next slide, please. So that is with the evolution of bolus insulin, all these
Excuse me, Dr. Surya. I'm
Yes,
very
please.
sorry to intervene, but due to time constraints, I think we are forced to end the session.
Yeah, okay.
I'm very sorry,
Thank you.
but
It's okay. No
thank you.
problem.
Thank you
It's
so
okay.
much, Dr. Surya.
Thank you. Thank you very much.
Our next session, yes, it is Time is Precious, Essential Primary Care Before Arrival by Dr. Jisha V. And it is my privilege to invite my dear senior, Dr. Jisha, for the next session. Dr. Jisha, she graduated from Government Medical College, Kottayam, and completed DNB Family Medicine from Kerala Institute of Medical Sciences, Trivandrum. She has worked as a consultant family physician at Aster Medicity, Kochi, and Forays Polyclinic, Idapalli. Dr. Jisha has done oral presentations and poster presentations at various conferences. She is currently working as a consultant family physician at Keyhole Clinic, Idapalli, and as consultant physician, Airtel Kerala Circle. Dr. Jisha is currently the secretary, AFPI Kerala Midzone, and is the organizing secretary of this very conference, AFPICON Kerala 2022. This session will be chaired by Dr. Raghavendra and Dr. Indu Rajiv. Dr. Raghavendra, sir, he completed his graduation from Kempagowda Institute of Medical Sciences, Bangalore, and DNB Family Medicine from St. Philomena's Hospital, Bangalore. He has completed postgraduate diploma in diabetology, contemporary management of obesity, and the advanced course in thyroid disorder management. He is currently the editor, Journal of Family Medicine and Primary Care, and has worked as the Dean of Academics, College of General Practitioners, AFPI, and as DNB Family Medicine Coordinator at Sagar Hospital, Bangalore. Dr. Raghavendra is a life member of AFPI, Indian Telemedicine Society, and Indian Thyroid Society. Currently, he is the Chief of Super Specialty Services, Consultant Primary Care Physician, and Lifestyle Disease Specialist at PES Institute of Medical Sciences and Super Specialty Hospital. Welcome, sir. Dr. Indu Rajiv. Dr. Indu completed her MBBS from Coimbatore Medical College in the year 1994, and she worked as a resident in the Department of General Medicine, Lourdes Hospital, Ernakulam, and completed her DNB in Family Medicine from the same hospital in the year 2009. She was involved in establishing a curriculum for family medicine residents, peripheral health centers, and also a family medicine department at Lourdes Hospital. She did her fellowship in intensive care from Apollo Hospitals, Bangalore, and now works as a critical care consultant at Lourdes Hospital, Ernakulam. She is also a practicing family physician in Vijayalakshmi Medical Center, Ernakulam. She is also the training center coordinator, BLS, ACLS, and PALS instructor of Lourdes Academy for Clinical Training, the International Training Center of AHA. She has presented various presentations, conducted workshops, and has many publications to her credit. Dr. Indu is currently the president of AFPI Mid-Zone, Kerala chapter, conducting academic activities regularly, and was awarded the best zone for the year 2018. Welcome, madam. Over to you, Dr. Jisha.
Hello. Am I audible?
Yes, ma'am, you're audible.
Yes, yes.
Okay. I'm not able to share my screen. Okay. Okay, so good evening, everyone. I'm really happy to be here presenting this topic. This is a conference that we have put a lot of effort in, and I'm really thankful for Dr. Shobha and scientific committee for giving me this opportunity today to talk about this topic. So without further delay, I'll go straight into my topic. The topic I got for today is time is precious, essential primary care before referral. So we as family physicians, we are often the first point of care for multiple illnesses. And we will see regular things, we will see emergency things, we will see non-emergency things. We get the sea of undifferentiated cases. And we can face any type of emergencies, be it when we are in our clinics, or be it when we are doing a house visit, or even in the hospital. We see multiple types of cases every day. Some of it we will be able to manage, but some we may need to refer for the specialist care. But always, when we are referring a patient, we should give the essential care that we are capable of doing before referring the patient. And also, always explain to the patient why you are referring, because we may understand that this patient is in a critical condition and needs urgent referral, but the bystander or the patient may not understand the situation. So it is always essential that you explain to the patient or the bystanders why you are referring to the patient. And also, when you are referring a patient, you should consider the degree of severity and time criticality. If you are facing a life-threatening condition, you should not cause unnecessary delay, and you should initiate a fast referral. Also, consider your expertise in managing that particular case, because family medicine is a very broad topic. Some of us may be good at managing some things, some may not be good at some other things. So if you're good at managing, do what you can. If you are not confident in managing it, make sure that you get the patient to someone who can without wasting time. And also consider the distance to the nearest hospital. So if you're practicing in a rural area and the next hospital where the patient can get a management is far away, then you'll have to stabilize the patient and then refer the patient. Also, when you're referring a patient, document, because the next person who is seeing the patient has to know what you saw. You document the patient details, their presenting complaints, and the vitals and any relevant examination findings that the patient presented to you with. Also, what do you think is the patient having? What is your professional diagnosis? What treatment did you give, and why are you referring the patient? Document this, but documentation does not cause any unnecessary delays. So one thing that I'm mentioning before I'm going on to my session is the News 2 score. So this is had some recent relevance because of the COVID pandemic also, because this is considered for even referring and treating critically ill COVID patients also. The News 2 score takes into account several parameters that you routinely examine in a patient and tells you when the patient needs referral. First of all, the first one is respiratory rate. In a respiratory rate less than 8 or more than 25 is a red flag sign. It's something like that gets a 3 point. 9 to 11 gets 1 score, and a normal respiratory rate 12 to 20 gets 0 score. Just like that, the oxygen saturation, if it's less than or equal to 91, the patient patient gets a 3 score. 92 to 93 gets a 2 score, and 94 to 95 1 score. If it is more than or equal to 96, there is no scoring. The SpO2 scale 2 is for patients on type 2 respiratory failure, patients like who are on chronic COPD patients. For them, you know, this 91 is not a target that you should keep. So for patients in type 2 respiratory failure, you use the SpO2 scale 2. That is less than or equal to 83 is considered critical. 84 to 85 gets a 2 score, and 86 to 87, or even for these patients, if the patient is on oxygen level more than 97 could be toxic. So that is also given a 3 score. And any patient who is on oxygen automatically gets an additional 2 score. Then next thing is blood pressure. If the systolic blood pressure is less than or equal to 90 or more than 220, that is also a critical sign. And the heart rate, the less than or equal to 40 or more than 131 is a critical sign. And the patient's consciousness. If the patient is alert, you don't have to give the patient any score. But if the patient is having a new onset confusion or not responding to verbal or painful stimuli, that is CVPU, then again the patient gets a 3 score. And hypo or hyperthermia, that also is considered in the scoring. So if the patient has an overall score of 1 to 4, that means there is a threat and risk of deterioration, but not you can consider whether acute referral is needed or not, or sometimes the patient may be safely monitored at home. Or if the patient is having a score of 5 to 6 overall, or a score of 3 in any of the specific parameters, then the patient needs urgent medical review. You treat the patient for their presenting complaint and advise the patient for urgent medical review in an acute care setting. But if the patient is getting a score of more than or equal to 7, the patient is having a severe disease and patient is very unwell, the patient needs emergency referral to an acute care setting. You do the bare minimum and arrange for referral immediately. Okay, so now these are some of the common emergencies that are encountered in GP. I know this list is quite exhaustive. I won't be able to even list out everything that could be a potential emergency in this 20-minute interval, but some things I just listed out the common causes like acute breathlessness. It can have cardiac causes or respiratory causes. Even anaphylaxis can. Pediatrics, there will be new causes like other causes like bronchiolitis or croup. Acute chest pain, first of all, it's ACS that you have to rule out, but there could be aortic dissection or pericarditis. Pulmonary causes like pulmonary embolism, pleuritic chest pain. If there's trauma, it could be tension pneumothorax, but it could also be costochondritis or musculoskeletal pain. You never know. And acute abdominal pain is there. If the patient could be unresponsive, could be CVA, metabolic poisoning. You can see a patient with seizure or trauma. Like I said, the list is never ending. So I'll briefly cover some of the major emergencies that are commonly seen, but I know I have not covered everything in this list. So moving on, first one is the acute coronary syndrome. And the thing everyone is scared of, for the layman, at least, acute chest pain. So when a patient comes to you with acute chest pain, always rule out acute coronary syndrome before considering other disease. What all encompass acute coronary syndrome? Could be either STEMI, NSTEMI, or an unstable angina. The patient will be having chest pain, but along with that, if there is relevant ECG changes, that is STEMI, that STEMI would be more than 1 millimeters of more than 1 millimeters in more than 2 adjacent limb leads, or more than 2 millimeters in more than or equal to 2 adjacent anterior chest leads, or new onset LBPB, then the patient is having STEMI, and definitely the troponin levels will be raised. In NSTEMI, we may not see any changes, or there may be HT segment depression or T wave inversion, and again the troponin levels will be raised. In unstable angina, the patient will be having persistent chest pain and signs of myocardial blood limitation, but the troponin levels are normal. So how will the patient present? As everyone knows, the band-like chest pain around the chest or the central chest pressure. Could be a dull ache with or without radiation. Radiation could be to the shoulders, mostly left arm, but could be in the right arm, to the neck or jaw. And even in the case of diabetics, it may not be even the presenting complaint. Also, but patient will be unwell. Patient will be in distress. There will be nausea, sweating, or shortness of breath. So when you're suspecting acute coronary syndrome, check BP in both arms. Check the patient's general appearance. Is the patient in distress, sweating, is the pallor? See if JVP is elevated, oxygen levels are falling, respiratory rate is increased, heart sounds, if there's evidence of left ventricular failure, lungs filled, is there crackles. All these things, and definitely check for ECG and troponin levels if available. So what do you see if you get a patient with acute coronary syndrome? Stabilize the patient before referring. That means prompt analgesia. The patient will be having severe pain and anxiety, and morphine is the drug of choice for analgesia in ACS, and along with Phenagan. You can also give loading dose of aspirin and clopidogrel. Administer oxygen if the oxygen levels are less than 94. Sublingual GTN can be given 0.4 mg every 5 minutes. You can give atorvastatin, IV Lasix if there is evidence of left ventricular failure, and other supportive measures. And the thing to remember is the golden hour of 60 minutes. If the patient is having STEMI, the patient reaches with the cardiac center within 60 minutes, we will be able to do a angioplasty for the patient. And within 12 hours, you'll be able to do this streptokinase injection. So next thing is acute left ventricular failure. The symptoms is sudden acute breathlessness, fatigue, there might be pink frothy sputum. Usually the occurs at night. Patient will be severely breathless and patient will not be able to lie down. Check for all the vitals. There may be gallop rhythm, peripheral edema, basal crackles, and hypotension may or may not be there. Causes is usually an MI, but could be precipitated with blood loss or arrhythmia. And management is L, M, and OP. So if you get a patient, you suspect this, if the patient has BP, give the patient Lasix and glycerolide nitrate. Then keep the patient popped up, give oxygen by mask. And also, if you can see the cause as an AF or something, treat the cause. And if you are not able to refer the patient, do additional investigations like troponin, BNP, ABG if available. Another thing is arrhythmias. That's something that you routinely see, but not all arrhythmias need emergency management. Arrhythmias need emergency management only when there is evidence of poor cardiac output. That is, if there is impaired consciousness, that means the patient will be having impaired cerebral blood flow. If there is chest pain and breathlessness, there is evidence of cardiac ischemia. Also peripheral perfusion, there will be low blood pressure. If the patient is not having these signs, then just ensure ventilation and oxygenation, and you don't have to treat as an emergency. So these are a few of the ECGs showing your common arrhythmias. First one is atrial fibrillation. That will be very disordered waves. The P wave will not be able to see. Second one is the atrial flutter, where the sawtooth pattern is seen. Third one is the SVT, where you get narrow complex QRS complexes. The VT, you get a wide QRS complex. And in VF, it will be a totally irregular rhythm. So one thing, another thing is, so when you call it a bradyarrhythmia, heart rate less than 50. So first of all, what you do is make the patient get fast, adequate preload. Supinate the patient, raise the legs above heart. If a patient is not in CHF, you can give IV fluids. Then atropine is the drug of choice for bradycardia. You can give 1 milligram every 3 minutes up to 3 milligram. If not responding, you can give epinephrine. If this is tachycardia, heart rate more than 100. If it is a new onset IAF, you can treat with rate control and rhythm control. And SVT, try with vagal stimulation like Valsalva maneuver. Carotid massage is not recommended for elderly people. Then next thing, if it's not responding to vagal stimulation, you can give adenosine. Start with the 6 milligram and chase with 10 ml of normal saline. If it is not working, you can increase the dose to 12, 18 milligram. And if the patient is having ventricular tachycardia or ventricular VF or VT, is broad complex with no P wave, then there is the only treatment that is best thing to do is a cardioversion. But you have to notice that if it is prostaglandin pointers, that is a polymorphic ventricular tachycardia. And there will be gradual changes, the ECG is there. So there will be gradual change in the amplitude and twisting of the QRS. So for Torsades, you don't give the patient cardioversion immediately. You treat the patient because it may spontaneously can terminate by itself, but it can spontaneously degenerate to VF also. But management is magnesium 1 to 2 gram IV. Next is cardiac arrest. So What is cardiac arrest? Cardiac arrest just means that the cessation of adequate heart function and respiration and results in death without reversal. So you see a patient who does not have a pulse, that is cardiac arrest. What do? Make sure that patient has do the BLS, call for help, make sure patient is not in danger, check for response, check for circulation. You always check circulation, the carotid pulse first, also then airway and breathing. And if the patient does not have a pulse, start CPR immediately. If you are a single person, it is 30:2. And if you have a bag and mask, use the bag and mask inhalation. So this is when there is no defibrillator available. Maybe hopefully in all the places where a doctor practices, there is at least an AED. But if it is not there, and if ECG monitoring is possible without interrupting CPR, do an ECG monitoring, see if it is PEA or resistor. Also, if there are any reversible causes like hypoxia, hypovolemia, the 5X and hypothermia, hypokalemia, tamponade, tension pneumothorax, toxins, thrombosis. If there is any reversible causes, treat this and give the patient oxygen, continue CPR, and if the patient is in asystole, can give adrenaline, 1 milligram adrenaline immediately and every 3 to 5 minutes. Also, it's acceptable to give at least 1 milligram of atropine. The patient, if we don't have any other means. But if the defibrillator is available, follow the ACLS protocol, start CPR, give the oxygen, attach the monitor, check the rhythm. If it's a shockable rhythm, shock the patient, continue CPR for 2 minutes, recheck the patient, and if you can give epinephrine every 3 to 5 minutes. And also, if it is not responding to epinephrine, you can give amiodarone or lidocaine. And if the patient is having a non-shockable rhythm, you can again give epinephrine and continue CPR, reassess every 2 minutes. If the patient attains loss, then you can stabilize the patient and send the patient for referral, the cardiac center where further monitoring is available. If otherwise, continue CPR till help arrives. So this is the position. This picture shows where you keep the AED leads in case you have an AED. One is in the right infraclavicular and the other is in the left inframammary areas. So in infants, if a single person, you use 2 fingers, and for 2 persons, you use the thumb of the patient. Thumb to press the chest. If it's for bigger children, heel of one hand, and for larger children, just like adults, you use both hands. AEDs are not designated for use in infants less than 1 year. Children more than 8 years use the standard adult AED, but children less than 8 years, if the pediatric pads are available or pediatric mode is there, use that. Otherwise, just use the adult AEDs. And also the drugs adrenaline should be given 10 microgram per kilogram of adrenaline and 100% high flow oxygen. Next is foreign body aspiration. Foreign body aspiration, it can happen for anyone at any place and time. If there is an effective cough, encourage coughing. But if there's an ineffective cough, for adults, you give 5 back blows, stand by the side of the patient to support the chest and give strong blows to between the shoulder blades. And 5 abdominal thrusts. That's a Heimlich maneuver. Keep your hands under the CP sternum and pull your hands towards the back. That's a Heimlich maneuver. And if the patient is unconscious, just start CPR straight away. For children, young children, you give back blows and chest thrusts, and this picture here. For bigger children, you can give the abdominal thrust. And for children, if the child is unconscious or not coughing, you can just see inside their mouth if there's something there. And if you can remove, try to do a single finger sweep. And also open the airway and attempt the rescue breaths. See if the chest is rising. And if there is no response, you have to give chest compression. Anaphylaxis. Anaphylaxis is something that you can see at any time. Always see the ABCs. This airway can be blocked because there is angioedema. Patient may have stridor. Breathing can be compromised because there is bronchospasm and saturation fall will happen. Circulation may be, the patient may be in shock, and patient may be in the mental distress because of reduced cerebral perforation. And skin changes like urticaria and angioedema will be there. The management is IM epinephrine. That is, there is no other required alternatives and no absolute contraindications. You give 0.3 to 0.5 milligrams of IM epinephrine preferably in the mid-outer thigh, and you can repeat it every 5 to 15 minutes. That is the absolute management for anaphylaxis. Then keep the supportive measures. Everything else is supportive. Keep the patient in recumbent position with legs elevated. Give oxygen, sodium, saline, then bronchodilators, antihistamines. You can give either Avil and H2 blockers also. And steroids. Steroids are supportive. You can give steroids, but it is not an alternative to adrenaline. Then acute pulmonary edema. If the patient is having severe symptoms of acute pulmonary edema, it's better to refer the patient immediately. Give oxygen to maintain oxygen saturation of more than 94. And you should give anticoagulation only after confirmation. If the patient is stable, you can check the well score. And if it's likely, PE is likely, you can give refer for PTPA. If it's unlikely, check D-dimer. If that is again negative, check for other DDs. Pneumothorax. The tension pneumothorax is one emergency that you may see in a case of trauma. The patient will be agitated and distressed, and it could be fatal if not treated immediately. The management is sit the patient upright and insert a large bore cannula in the second intercostal space in the mid-clavicular line on the affected side. The emergency shift of the patient to the hospital. And for trauma, you check the ABCDs, resuscitate if needed. If there is hemorrhage, control by elevation and pressure. Do not move the patient in case of spine injury. Use log roll movement. That is one thing that you have to be mindful in trauma. This picture shows log roll movement, and use a spine board or vacuum mattress. Then don't give anything by mouth, and give analgesia if there is no head injury or peritoneal injury, and give IV fluids if the patient is in shock. And this is the recovery position for any patient that is unconscious but has circulation and breathing. This helps to maintain a good airway and does not cause, ensures that tongue does not cause obstruction. Next, another one that we can encounter is trauma or GI bleeding. Rapidly assess how much blood has lost, and if it's severe, arrange for immediate referral. Place the patient supine with legs elevated. Start IV fluids. If you can, take blood for grouping and cross-matching. Give oxygen. That is the immediate management. And if the patient is having epistaxis, the thing is pinch the tip of the nose for 10 minutes. You apply ice pack, and then make the patient sit and lean forward. If the patient status epilepticus, the medicines that you can give, check the ABC, place the position in recovery position. Give midazolam. You can give buccal 5 to 10 milligram or diazepam, and phenytoin after the seizures are controlled. Acute asthma is already discussed by Dr. Asha. Then COPD also same management. Only thing is you can give beta-2 agonists and systemic corticosteroids. Maintain SpO2 more than 90. And snake bite. Do not immobilize the limb. Do not tie a tourniquet. Keep the patient in recovery position if feasible. Keep NPO. Watch for progressive weakness, bleeding, myotoxicity. And if it is neuroparalytic snake venom, then there will be, you have to monitor, look for the 5 Ds and 2 Ps. That is dyspnea, dysphonia, dysarthria, diplopia, dysphagia, and 2 Ps, ptosis and paralysis. In vascular toxic, there will be local manifestations, swelling, bleeding, blistering, and necrosis, and compartment syndrome may be there. Management is maintain circulation, airway, breathing, and monitor whole blood clotting time. Every 3 hours, every hour for the first 3 hours, then every 6 hours for 24 hours. Also, you can check peak flow meter, single breath counting time, and indicate ASV is indicated if there is any sign or symptom of envenenation, or there is lab evidence. There is no absolute contraindication for ASV if the patient is envenomated. Have adrenaline, antihistamines, oxygen, steroid on standby. And for neuroparalytic snakebite, ASV 10 vials stat as infusion over 13 minutes, followed by second dose of 10 vials after 1 hour if no improvement. For vascular toxic, there can be 2 therapies, either low dose, both starts with 10 vials stat as infusion over 30 minutes, but a low dose gives 2 vials every 6 hours, and high dose you give 6 vials 6 hourly as bolus therapy. So I've tried to rush through some of the topics. Hopefully that was not too fast. Thank you, everyone.
Thank you, Dr. Jisha. It was a wonderful presentation. What I would like to say, even if you're given 2 hours, you cannot complete this topic. It's very vast. Okay. Yeah. Okay. So as family physicians, what I would like to advise is, the first thing is you need to recognize an emergency first. Then only you can, yeah, we encounter a lot of patients, but we always want to be in the comfort zone. So I think many of them avoid facing this, but I think in this nowadays, I think a lot of legal situations have come around. We also need to be very careful while attending cases. We need to stabilize the patient. And you told rightly, we need to stabilize before transferring the patient. Okay, so we'll have to give a documented letter also before referring. So a lot of responsibilities as a family physician. So for all that, I think the being primary care providers, we need to have a training for that, because theoretically emergencies are very easy to study, read, go everything. But when you are in the situation, we will panic because you will be alone. There will be nobody with us.
Yes.
So for that, we need training. So my advice is all of you should have trainings in BLS, ACLS, pediatric advanced life support, and also go for workshops for learning airway and many other things. So Jisha, I don't have much questions for you. Few things I missed was the acute stroke, because that's also equally important for as an MI.
Yes.
So we didn't have time, as you told, and also burns. That's also the first primary care.
Yeah. So I try to include whatever
As
I
a
could.
primary care physician, we need to do something. Yeah. Over to
Yes.
Dr. Raghavendra.
Dr. Jisha, I think your topic is a topic for one full day. I mean, in fact,
Yeah,
referral
not 2
management
hours
for
also.
each topic itself is a big thing, but it's a very good thing. But actually, what I would like to say is, you have tried to put in the presentation thinking that the primary care physician who is there in a hospital setting or in an emergency setting. Actually, I want to put in a word here where primary care physicians work in a different zone. Like I worked in a clinic, I worked in a hospital, I worked as a hospital director, now the chief. So the different scenarios, the referral system becomes different thing. The first thing what you need to take care is, first thing is legality. One is legality. Second thing is taking care of the life of the patient. These two things become very important. So whatever decision we have talked here, it is all, most of the things will be theoretical. But when you come to the practical scenario, the legality is when you're referring a patient somewhere, you need to know whether you know this patient properly. Because many of the time when I was practicing in my own clinic, suddenly midnight 10 o'clock, some patient walks into the hospital or some neighbor comes in and says some emergency and they want you to take up. So you need to decide whether you can take up this case or some. It is when in case of emergencies, you should think like a lawyer. Whether I can take up this case, whether I can win this case, whether it is going to backfire to me, that is one thing. Over a period of time, you will know which case to be sent where. Because when you're sending a case to some other thing, we think that all the other side, whoever is receiving, should receive the case. If you're referring a case and if the other side, if they don't receive, then you are in trouble. Because legally, in the hospital where now the presently when you're referring something, if you have documented, you are the primary responsibility until unless somebody takes over. So referring a case, somebody has, it's like a relay race. You hand over a baton, somebody else have to pick it up. So you have to make sure this patient is alive until the patient goes there. That is first main thing anything happens. Next thing is you need to always try to have some quaternary care or something like where you can just send the case and they will receive it. Or many of the time when you call, they should come and pick it up. Most of the time in bigger cities, we have 108 ambulances and other places where we can refer. But in the places where people are working in a villages or something, they will get their own vehicle or two-wheelers or car or try to make and they try to find. And if something happens in between, whatever effort we would have put in, that doesn't come into existence. So most of the time what we do in our setting is we video record whatever discussion we make with the patient and whatever documentation we are making, we make it a video record, especially the counseling part. When you are explaining the primary emergency, like this is what's happened or whatever action you're taking, whatever thing is there, in front of you patients will say yes, yes. If patient recovers, you are the God. But if something happens to the patient, they come back with a vengeance. So that becomes very important. Then in case of, there is something called cool referral, that is called hot referral. Whatever we have discussed now is a hot referral, where patients are sick and life is at threat and we are referring. But when it comes to a cool referral, most of the time what we have been taught is, whenever you are trying to refer a case, don't get confused. Whenever a case is there, try to evaluate till you make a diagnosis. If the patient is stable, Like example, today I had a patient who had with some rare kind of rash or something. So need not have to refer everything. So referral comes in both. All referral doesn't mean they are acute referral, emergency referral. It can be a cool referral. We can work up the case. We try to make a diagnosis, because making a diagnosis itself is a big happiness to any primary care physician. Treatment anybody will do. So making a diagnosis, that becomes important. So that is two things. Then whenever you're making a referral, the legality comes. Example, there are few hospitals which make an agreement with a primary care physician. Most of them, they don't refer, they take up a case. So today in Bangalore and in Karnataka and other, even in Andhra Pradesh, the hospital which is trying to take the case makes an agreement with us. So there is an agreement, proper agreement, where you can hand over the case and take over the case. And also sometime when the patient is referred back to you, and they even inform you, like the patient is received, what has happened. So sometimes we refer and we don't know what's happening. But many of the hospital today, they call us up and they tell us step by step, every step there is an information or a message system, or a digitally we get informed like what is happening to the patient. So we are also rest assured. And sometimes the patient comes back to us on the second day and third day and they ask us to put in a word. So if we don't know what has happened to the patient, to the hospital where it has sent, we become like a blank. We don't know what has happened. Because at the end of the day, the patient is always going to come back to us. Attenders are always going to come back to us. We are in the society and we are all alone. So this is what happens in primary care. In secondary care and quaternary care, there is always an agreement. So over a period of 1 year, 2 years or 5 years, we know what are the kind of cases we are getting. So that becomes very important. And most of the cases, I think whenever we are talking injections, I think we need to be very careful. You stress a lot about adenosine, epinephrine, all those things. But in a clinic, it becomes very tough. Suppose you give an injection and before 108 comes and if the patient collapses, we are finished. Patient doesn't understand that we tried all our best. We don't maintain a crash cart or something like that. So ideally, the saying, whatever it is, most of the 108 reaches you within a matter of 10 minutes or 15 minutes. So in between that time, always I try to give injections in the ambulance. Or most of the time there is a paramedics inside the ambulance. So when I used to give injections, I always give it in the ambulance because there is a defibrillator available or you are inside the government. But when you're inside your clinic, I generally used to avoid injections. I try to put the patient in ambulance. So we used to tell the ambulance, and when in the transit, I used to help the patient. So in the clinic, I always say, if you are practicing alone, avoid injections. If it is in a nursing home or in a secondary care, that is okay. I think these are the few words I like to put in, but it was a wonderful presentation. Good attempt. Thank you.
Thank you, Dr. Jisha, Dr. Raghavendra sir, and Dr. Indu ma'am.
Moving on to the next session. Next is Catch the Butterfly, Hypothyroidism and Ensuring Continuous Care. Speaker is Dr. Kailas P. Dr. Kailas, after completing MBBS and DNB Family Medicine, he has completed DFID Diabetology from CMC Vellore and has completed basic certificate course in palliative medicine. He is FM 360 coordinator of Spice Route India. Dr. Kailas has won Best Paper Award in 2nd FMPC held at New Delhi and has won Young Doctor Award in 4th FMPC held at Bangalore. He was organizing secretary of AFPICON Kerala 2019. Dr. Kailas is currently working as assistant surgeon in Kerala Government Health Services and is presently in charge of COVID lab surveillance of Palakkad district. Welcome, Dr. Kailas. Chairpersons are Dr. Raghavendra sir and Dr. Indu Raju. Over to the speaker.
Thank you, Sangeeta, for the introduction. Am I audible, right?
Yes, you're audible perfectly.
Thank you. I'm sharing the screen.
Sure, sir. Yeah, it's visible. Can you please make it into full screen? Yeah, visible perfectly.
Okay. Today, in this late evening, I am talking something about hypothyroidism, which is a very common topic and which is very common to all the family physicians who are working in primary care and also in any type of practice. So I'm trying to talk about hypothyroidism in a perspective from a family physician or a primary care physician. So what is hypothyroidism? Hypothyroidism is defined as a failure of the thyroid gland to produce sufficient thyroid hormones to meet the metabolic demands of the body. So, what are the causes of hypothyroidism? Let's see what are the causes. It may be either due to primary hypothyroidism, which is due to a defect in the thyroid gland itself, which may be either acquired causes like Hashimoto's thyroiditis, iodine deficiency, or certain drugs which are blocking synthesis or release of T4 like lithium, ethionamides, sulfonamides, or iodides, or goitrogens in foodstuffs, or as endemic substances or pollutants, or certain cytokines, or thyroid infiltrations like amyloidosis, hemochromatosis, sarcoidosis, etc. And also in certain post-ablative thyroiditis due to iodine 131 surgery or therapeutic irradiation for non-thyroidal malignancy. Or primary hypothyroidism may be also due to certain congenital causes like iodide transporter utilization defect, iodothyrosin dehydrogenase deficiency, organification disorders, defects in thyroglobulin synthesis, etc. And there is another entity called as transient hypothyroidism or post-thyroiditis, that is due to following painless or painful subacute thyroiditis. And another entity called as consumptive hypothyroidism, in which where there is a rapid destruction of thyroid hormone due to the increased expression of T3 iodinase in large hemangiomas or hemangioendotheliomas. Or sometimes hypothyroidism may be also due to defects of thyroxine to triiodotyrosine conversion, like selenocysteine insertion sequence binding to protein defect. And also certain drugs, drug-induced thyroid destruction like tyrosine kinase inhibitors, sunitinib, etc., causes drug-induced thyroid destruction. The other cause of hypothyroidism is central hypothyroidism, which may be also acquired or congenital. And those hypothyroidism which is of pituitary origin is called as secondary hypothyroidism. And those hypothyroidism due to hypothalamic disorders are called as tertiary hypothyroidism. And bexarotene or dopamine can also cause acquired central hypothyroidism. And congenital causes of central hypothyroidism include TSH deficiency or structural abnormality or TSH receptor deficit. And hypothyroidism may also be due to certain resistance to thyroid hormones. So keeping in this mind these causes of hypothyroidism, let's see how it is clinically presented to you. You all know that the symptoms of hypothyroidism may be very diverse. It may range in all types of systems. It might not be system specific. Presentation will be there. The most common symptoms which we see are cold intolerance, fatigue, certain things like arthralgias, dry skin, menorrhagia, myalgias, constipation, hair thinning or hair loss, weakness, weight gain, depression, difficulty in concentrating, or memory impairment. So it is very difficult to pick up these symptoms from the patients itself, because it's sometimes it may be very non-specific also. And also, while certain clinical signs of hypothyroidism which we commonly see are bradycardia, ghost facies, cognitive impairment, and delayed relaxation phase of deep tendon reflexes, diastolic hypertension, edema, sometimes goiter, hypothermia, etc. And also certain laboratory results like elevated C-reactive protein, hyperprolactinemia, hyponatremia, or increased creatine kinase, increased LDL, increased triglycerides, normocytic anemia, proteinuria, sometimes lateral eyebrow thinning or low voltage ECG, macroglossia, periorbital edema, or pleural pericardial effusion may be seen. So a correct clinical examination of the patient is needed to find out these clinical signs also. So when should family physicians evaluate for a thyroid dysfunction? First of all, when to screen the patient. There is each and every family physician should evaluate the patients for thyroid dysfunction with the above symptoms and signs if there is present during the clinical examination. In asymptomatic patients with risk factors for hypothyroidism, such as history of head or neck irradiation, previous radioactive iodine therapy, presence of a goiter, family history of thyroid diseases, or treatment with drugs known to influence thyroid function. And also in adults and children with type 1 diabetes or other autoimmune disease, or new onset or atrial fibrillation. And also in adults and children with depression or unexplainable anxiety, or children with abnormal growth, unexplained change in behavior or school performance. In menopausal women whose symptoms of thyroid dysfunction may be mistaken for menopause. And do not test for thyroid dysfunction during an acute illness unless you suspect the acute illness is due to thyroid dysfunction, because the acute illness may affect the test results. So with these symptoms and signs of hypothyroidism, so you plan to test for hypothyroidism. So you send for a you first measure a TSH, and if TSH is less than 0.35, then consider the hyperthyroid state, and TSH is in normal range, patient is considered as euthyroid. So now going to our topic, if the TSH is more than 5.5, also see the free T4. And if free T4 is above the normal range, it is not a primary hypothyroidism, we should refer for an endocrinology consultation. So if the free T4 is below the normal range, then we should consider it as a primary hypothyroidism. That is, free TSH is high and free T4 is below the normal range. And if free T4 is within the normal range, the diagnosis of subclinical hypothyroidism can be made, and consider treatment in subclinical hypothyroidism only if TSH is more than 10 or increased thyroid peroxidase antibody titer, or if the patient is desiring pregnancy or patient has symptoms of hypothyroidism. So how do we treat the primary hypothyroidism? We all are treating hypothyroidism for once we completed our basic MBBS. And if in patients with more than 50 or 60 years, and also a patient who is known or suspected ischemic heart disease, start levothyroxine only at a smaller dose, which is around 25 to 50 microgram daily, and increase the dosage by 25 microgram until TSH is within normal range. Or a patient who is pregnant and also on previously stable dose of levothyroxine, during pregnancy, the need for levothyroxine increased by 30 to about 30%. So increase the levothyroxine daily dosage, or increase the levothyroxine to 9 doses weekly. And we should give an endocrinology referral also. And if the patient is suspected to have any stupor or other mental status changes or hypothermia, consider the possibility of mixed edema coma, and an intensive care unit admission or an endocrinology referral is warranted. So in other normal cases, consider starting levothyroxine at a dose of 1.6 microgram per kg per day. And also, I'm just showing this slide to see the need for once TPO antibody is positive, consider Hashimoto's disease and lifelong treatment of T4 may be needed. Sometimes if TPO antibody is negative and transient hypothyroidism or post-viral thyroiditis is considered, you treat the patient with T4 levothyroxine for a period of 4 months, and after which you try to reduce the dose by 50% for 6 weeks and check TSH. And if it is normal, then you can slowly stop the drugs, or if it is TSH is increased, it may be due to a permanent hypothyroidism, and continue the T4 lifelong. So so we have come to a diagnosis, and we have started the medications, and we are going to monitor the treatment. So usually after the starting of treatment, repeat the TSH testing only after 6 to 8 weeks. And if repeat TSH is less than 0.35, that is, patient is over replaced, and decrease the daily dosage by increments of 25 microgram, and repeat TSH again after 6 to 8 weeks. And if repeat TSH shows TSH level is more than 5, that means the patient is under replaced. Always check for the adherence and check for interfering medications, which we will discuss later. And also, if the patient is adherent and medications are reconciled, increase the daily dosage by 12.5 to 25 microgram, and check again after 6 to 8 weeks. And if the repeat TSH is within the normal range, and then go for an annual or 6 monthly serum TSH level checking. So certain dosing guidelines for hypothyroidism in adults, that is in non-pregnant patients, the dosage is, as we already told, it is 1.6 microgram per kg per day initial dosage. And in older patients or patient with suspected cardiac disease, start with a dose of 25 to 50 microgram increase the dosage by 25 microgram until full replacement dosage is reached. And in pregnant patients, increase the doses to 9 doses weekly at the earliest knowledge of pregnancy and refer to an endocrinologist. And patient with subclinical hypothyroidism, if it is more than 10, treat it as per as normal non-pregnant patients. And if it is TSH is less than 10, start at a dose of 50 microgram daily and increase by 25 mcg every 6 weeks until TSH is between the normal range. So while giving instruction, giving a prescription, you have to give certain, as a family physician, we should give certain instructions to the patient. That is, thyroid hormone is generally taken in the morning, 30 minutes before eating, because these food factors maybe affect the absorption of levothyroxine, and it is better taken in the early morning, 30 minutes before having any food. So if a patient skips a dose a day, what should they do? What we can say is the half-life of levothyroxine is around 7 days. So he can either take the medication and the next day today's dose also along with the tomorrow's dose in the early morning. Or also there is another thing, if the patient is unable to take the dose in the early morning, guidelines also recommend that patient may take the dose in the evening 3 hours after the last meal of the day. And also calcium and iron supplements should not be taken within 4 hours of taking levothyroxine, because these supplements may decrease the thyroid hormone absorption. And also say that even when tell the patient that there may not be any symptoms, but treatment should be continued to avoid the risk of long-term complications. And also talk about the risk of over and under treatment, and how to take and when to take, and what are the which all drugs, what all things to do, things to be aware when you take another drug, any other drugs, need for and frequency of monitoring, and when to seek advice from a healthcare professional, and how hypothyroidism may affect pregnancy and fertility. So what are the reasons? So as family physicians, we may not be able to treat all the type of hypothyroidism. There are maybe certain reasons we also should know when to refer. And these are the reasons for an endocrinology consultation in patients with hypothyroidism. Age is less than 18 years, with those patients with cardiac disease, coexisting endocrine diseases, and if myxedema coma is suspected in pregnancy and presence of any structural thyroid gland abnormality, on somebody who is unresponsive to therapy. And also, what are the conditions that alter the levothyroxine requirements? There are certain conditions that may increase the levothyroxine requirements, as in pregnancy, as in certain gastrointestinal disorders as listed, and also the therapy with certain pharmacological agents, that is some drugs that interfere with absorption, that drugs which increase the cytochrome P450 enzyme, or drugs that block T4 to T3 conversion, as in amiodarone, and also certain conditions that may block deiodinase synthesis, like selenium deficiency, cirrhosis, etc. And those patients in aging and androgen therapy in women, a decreased levothyroxine requirements is seen. So as we started the treatment, after 6 months, the dose should be reassessed, because the restoration of euthyroidism increases the metabolic clearance of T4, and a dose that was adequate during the early phase of therapy may not be the same when patient is euthyroid, owing to an acceleration in the clearance of thyroid hormones. So once the dose is stabilized, then again after 6 months, just check for the whether any change in the TSH values is happening, because there may be a chance. So most patients, and also once the patient is stabilized on a dose, most patients receive the same dosage for a long time. But at the age of a 7th or 8th decade of their lifetime, there is a downward adjustment of 20 to 30% may be indicated, because thyroid hormone clearance decreases in the elderly, So with this keeping in my mind, we are moving on to some certain special situations which we may encounter in our practice, which are usually being treated by an endocrinologist. So the first thing is the congenital hypothyroidism. So when should we screen for congenital hypothyroidism? Screening should be done for every newborn using cord blood or postnatal blood ideally at the age of 42 to 48 to 72 hours of age. And how heel prick or cord blood TSH on the first screen, and if the TSH is less than 20, then it's normal. And if TSH is more than 20, what to do? If the TSH is very high and TSH is more than 80, take a confirmatory venous sample for TSH and FT4 or T4 after 72 hours of age, and start levothyroxine treatment immediately without waiting for the reports. And if TSH is more than 40, then send for the confirmatory venous sample, wait for the result. And if it is between 20 to 40, then recall the patient, recall the child at 7 to 10 days of life and do a second screen. Repeat TSH, and if the TSH is greater than 20 at the age less than 2 weeks, or TSH is greater than 10 at the age of greater than 2 weeks, this confirmatory venous sample is sent. And if the patient has normal T4 and TSH, the results may be either normal T4 and TSH, and then it's normal. And if it is low T4, irrespective of the TSH, start treatment. And And if it is normal T4 and high TSH, repeat TSH after 2 weeks. And if TSH is less than 10, then it is normal. But the TSH is persistently greater than 10 after the age of 3 weeks with normal T4 or FT4, start treatment, reassess at the age of 3 years. So levothyroxine replacement at a dose of 10 to 50 microgram per kg per day should be initiated once newborn screening is positive, pending the results of confirmatory testing. Higher doses may be required for infants with severe congenital hypothyroidism. The aim of the therapy is to maintain the serum thyroxine in the mid to upper half of pediatric reference range and serum thyrotropin in the mid to lower half of pediatric reference range. The target should be to normalize serum thyroxine approximately 2 to 4 weeks after the initiation of therapy. Once the proper dose is identified, surveillance testing with serum thyrotropin and thyroxine should be performed every 1 to 2 months during the first year of life, with decreasing frequency as the child ages. And what are the advice to be given to the parents? Take daily treatment to prevent the neurological damage. Crush tablet in small quantity of breast milk. Just check TSH and levothyroxine at 2 and 4 weeks of levothyroxine treatment. Every 1 to 2 months during first 6 months of life. Then every 3 to 4 months during 6 months and 3 years. Every 6 to 12 months until growth is completed. And at a more frequent intervals when the compliance is questioned. Any reduction of the levothyroxine dose should not be based on a single higher than normal free T4 concentration unless the TSH is suppressed or there are signs of over treatment like jitteriness or tachycardia. The first clinical and biochemical follow-up evaluation should take place 1 to 2 weeks after the start of levothyroxine. 1 week at the latest in case of a starting dosage of 50 microgram per day or even higher dose. So the next special situation is the pregnancy and postpartum. And let's see what are the physiological changes of thyroid to the thyroid of mother in pregnancy. The thyroid gland will increase in size, then increase in production of T4 and T3 by 50%. 50% increase in daily requirement of iodine, increase the thyroid binding globulin, and increase in HCG stimulates the production of thyroid globulin, thyroid hormone, with decrease the TSH. And what are the trimester specific TSH? Usually, in the first trimester, an upper value of 2.5 is usually recommended, and in second and third trimester, the upper value of 3 is recommended. So, in hypothyroidism in pregnancy, there may be either overt hypothyroidism, in which elevated TSH is more than 10, irrespective of free T4, and elevated TSH more than 2.5 with a low T4 is also considered as an overt hypothyroidism. And in subclinical hypothyroidism, in where TSH levels vary between 2.5 to 10 with normal FT4. So free T4 helps in differentiating between an overt hypothyroidism and subclinical hypothyroidism. So what are the goals of the treatment? A woman with primary hypothyroidism should be treated adequately with levothyroxine before planning pregnancy and try to achieve a TSH of less than 2.5 international units per minute. And alternatively, a woman who is euthyroid with once a dose of LT4 before gestation, increase the dose by 25 to 30% as soon as she misses a period, or increase the number of daily dosage to 9 doses per week. Subsequently confirm pregnancy and serum TSH if a requirement does not remain static throughout the pregnancy. And a pregnant patient detected hypothyroid during the gestation, normalize the maternal TSH values in the trimester specific range throughout with replacement therapy of levothyroxine. Serum TSH should be monitored every 4 weeks during the first half of pregnancy, and at least once between 28 to 32 weeks followed up to be carried out in the same laboratory. And after delivery, mother can go back to the preconception dose and check TSH 6 weeks postpartum. So now after the pregnancy, in postpartum, a thyroid dysfunction occurring in the first 12 months after pregnancy, marked by lymphocytic inflammation, is called as postpartum thyroiditis, and TPO antibody is positive. The initial phase has hyperthyroid symptoms, that is 2 to 6 months postpartum may pass undetected. And the second phase may be with hypothyroid symptoms in a 3 to 12 month period, and euthyroid function resumes in 80% of the woman in a year. So coming to the primary hypothyroidism in children, and when thyroid dysfunction is suspected, check for TSH and free T4, and check TPO antibodies if TSH levels above reference range. Repeat testing at the time of transition of adulthood. Levothyroxine is the drug of choice with dosage of in age-wise dose of 0 to 6 months 10 to 15 microgram per kg per day, and in 7 to 11 months 6 to 8 microgram per kg per day, and in 1 to 5 years 5 to 6 microgram per kg per day, 6 to 10 years 4 to 5 microgram per kg per day, and in 11 to 20 years 1 to 3 microgram per kg per day. So in primary hypothyroidism in children, follow-up and monitoring, that is for children about 2 years and for young people, do free T4 and TSH every 6 to 12 weeks until the TSH is stabilized. Then every 4 to 6 months until puberty, and then once in a year. And those children under 2 years, every 4 to 8 weeks until TSH is stabilized, then every 2 to 3 months during the first year of life, and then every 3 to 4 months during the second year of life. So coming to the myxedema coma, that is a medical emergency with high mortality. So it is defined as a severe hypothyroidism leading to decreased mental status, hypothermia, other symptoms related to the slowing of function in multiple organs. So what is the treatment? It is usually it has to be usually referred to a higher center for treatment, which needs emergency critical care. And levothyroxine, in where the levothyroxine can initially administered as a single IV bolus of 500 microgram, the loading dose, and usually continued with a dose of 50 to 100 microgram per day. If IV preparation is not available, the same dose can be given orally via nasogastric tube, and recovery is within 24 hours as usual. Another option is leothyronin 10 to 25 microgram every 8 hourly, IV or orally, or a combination of levothyroxine 200 microgram and leothyronin 25 microgram single IV dose, followed by daily treatment of LT4 50 to 100 microgram per day, and leothyronin 10 microgram every 8 hourly, maybe another choice. And also for myxedema coma, the supportive treatment include external warming if less than 30 degree, parenteral hydrocortisone 50 milligrams 6 hourly, broad spectrum antibiotics, ventilatory support, hypertonic saline or glucose, and try to avoid sedatives. And with this last slide, I am stopping this presentation and looking at the what are the possible complications of levothyroxine. That is, the possible complications of levothyroxine include pseudotumor cerebri in children, and also most certain cardiac symptoms like palpitations, arrhythmia, especially AF is seen with excessive dosage, and certain metabolic effects like weight loss, GI effects like vomiting and diarrhea, musculoskeletal effects like muscle cramps, weakness, etc., or neurological effects like anxiety, tremor, insomnia, restlessness, and also certain psychiatric effects like mania, menstrual irregularities, increased bone resorption, and osteoporosis is seen. So just covered this topic of hypothyroidism from a family medicine family physician's perspective. And with this, I'm concluding my presentation. Thank you.
Dr. Raghavendra can take it.
Thank you.
You're more experienced in doing primary care. We all work in hospitals, tertiary care hospitals, so we all pick up emergencies.
Dr. Kailash, thank you, ma'am. Dr. Kailash, I think you have presented a topic which is actually a primary care physician perspective. We call from cradle to grave. You covered right from birth till the old age, and also the thing. I think it's one of the nice topic. This is how I think a primary care physician should read any topic. This is all. But actually there are very few books which will give like this. You'll have to take 4 different books. You have to take one book from pediatrics, obstetrics, and different books to come with some. I can really see the effort what you have put in to make this slide. You have covered most of the thing, but one thing in the practice perspective, I'm telling, thyroid is one thing which will definitely build your practice. I think if a woman comes to your clinic, she doesn't come alone. She comes either with a husband, father, mother, or somebody. So if you are good at thyroid practice, definitely a woman who is treated well will tell 10 other women. I think madam will accept. So definitely if you are very good in thyroid practice, practice will definitely build. In the initial part of the practice, when everybody were looking at diabetology, I put my hand into thyroid. We did almost around lot of education sessions and other thing. And once we started looking at thyroid, definitely my practice. So I have a lot of good feeling towards hypothyroidism especially. And now the government has taken up in a very big way. Now every state PHC, they have a thyroid testing centers. And especially when a pregnant woman comes to the hospital, the thyroid testing is done. Especially they try to do it on spot. Before and all, we used to send the sample to Bombay or Delhi, and from there we used to get. Now most of the places we are getting that thyroid. That is one point which we would like to tell. And what point I want to put it is known as sentinel screening. If you get one patient of hypothyroid, you need to work around it. You have to ask whether a mother has been checked, or the children who especially girl child have the check. Either side, if your cousins have been checked. So definitely if you get one case of hypothyroid, you will have around 6 to 7 ladies in the family who are hypothyroid. You can definitely find out from that. And one more thing which point I want to put in is many people try to combine the doses. Like example, they take one source from Abbott company, one from the GlaxoSmithKline and things like that. So that should never be done. Always you should try to use one single brand, and you should not change the brands, because I've seen brand to brand variability when we are treating a case of hypothyroids. Then one more point regarding hypothyroidism management is breaking of the drug. Especially when you try to taper from 50 to 25, many of the ladies, they try to break it. So I tell them, this is how you do, you buy your gold or what? Like this, you don't buy, you break it like this. You need to weigh it. So this is in a microgram, so you can't break it. So we need to tell the patient that you should not break the drug. If you are changing the drug, throw the drug, or you keep it, next time we'll see. That is what thing. And in my practice, I generally tell the patients, I educate the patient. First thing is, many of them don't know what is thyroid. They think it is a curable disease, or they think it is something like a cancer. Many of the patients who come, they have a goiter and they think it is a cancer. That is why they come. So first thing is, we need to educate the patient, especially with the flow charts or in a pictorial gram, and tell them what is thyroid. Many of them don't even know where thyroid organ is. I ask them, where is your thyroid? They just look at me like that. They don't even know where is thyroid. So we need to tell them, this is what thyroid looks like, this is where it is. And one interesting thing about hypothyroid is, especially if a girl is not married, in places where I practice, getting them married is very difficult. Like it is type 1 diabetic. If you are a type 1 diabetic, you have to find a type 1 diabetic groom. Now in case of hypothyroid, it is very difficult. So most of the time we need to educate them about this customs and other things. So these are some very interesting things about hypothyroid. And one more important point is, when you're checking a thyroid, the sample, wherever the lab where you're testing, we try to stick to the same lab. People try to skip the labs because each lab, sometimes they have a different the reference range. So you need to always tell the patient, when you're coming back, get tested in the same lab. That is one thing we try to tell them. So these are the few perspectives which we try to put in hypothyroid. Otherwise, it was a wonderful session. Nice talking to you. Thank you, ma'am.
Yes, Kailash, it was
Thank
a
you, sir.
wonderful session. You have worked so much for that. Thank you so much. Thank you.
I thank AFPI also, Kerala, for doing such a wonderful session in the peak of COVID. Everybody is tensed. Even we don't know how the things are going to work. I think we need to, all of us, keep ourselves motivated, and we are all should be together, and we are all each other for help. And thank you, AFPI Kerala, for giving us this chance to chair this session. Thank you so much.
Thank you, sir.
Thank you, Dr. Kailas. Thank you, Dr. Raghavendra sir and Dr. Indu madam. So coming to the last session of the PG update. Introduction to the Spice Route India Movement and PG Open Forum. Speaker is Dr. Nadeem Abuti, the Kerala State Lead of the Spice Route India. He is currently working as Consultant Family Medicine Specialist at Josgiri Hospital, Talasheri and Heed and Heal Clinic, Talasheri. We welcome you, sir.
Hello. Nadim sir, you are not audible. Sir, can you rejoin the meeting? Sir, you can test your microphone once. Hello. Nadim sir, can you rejoin the meeting? No, sir, still you are not audible. Can you try without headphone once? No, sir, still you are not audible. Can you connect from another device, sir?
Is it audible now?
Yes, sir, now you are audible, sir.
Okay. Is it clear? That might be due to my headset. Sorry for the delay. Good evening, friends, teachers, seniors, my dear friends. And initially, I would like to thank the AFPICON Kerala 2022 organizers for giving Spice Route a little time to engage with the new residents. Okay, I know I'll not, initially I'm promising I'll not take more than 10 minutes for sure, because I know no one will be interested in this session, because since afternoon, everyone is in front of this monitor with this very vibrant classes, enlightening sessions, and most of them already know either how the Spice Route work, and some other don't know Spice Route, they'll not be interested, because actually 8 years back, I was also in the position where I don't know the importance of this Spice Route. And when we go for national conferences, me, Kailas and all know, when we go for national conferences, Dr. Idris will come up with these sessions with Spice Route, and that is the time we move for tea and lunch. And I'll not make this session like that. I'll just make it brief. I'll just introduce what is happening in Spice Route. Okay. Can I share the screen, my PowerPoint?
Yes, sir, you can. Yes, sir, you can check.
It's not getting open.
May I help you, sir?
Is it visible?
Not yet, sir. You can open your PowerPoint in backend, then come on Zoom screen, sir. Sir, have you opened that PowerPoint in backend? Okay, now it's coming. Now, from the taskbar, you can open the PowerPoint, sir.
Is it visible now?
No, sir, you have to open the PowerPoint. It's coming a Zoom screen only. From the taskbar, open the PowerPoint, sir.
Here only.
Sir, from the taskbar, you can open the PowerPoint. Go to the taskbar. Hello. Yes, sir. Go to the taskbar. Downside, sir.
It's visible. Yeah, this one.
Yes, open the PowerPoint. Yes, double click on the. Okay. Oh, okay. Now you can make it full screen, sir. Slideshow mode.
Okay.
Sir, just click on hide button.
Okay.
Yes, perfect.
I'll just rush through the Spice Route setup. The Spice Route is a young doctors movement, which is for South Asia. As you all know, for any organization, either FPI or something else, the backbone of the organization is young doctors, young youth of that organization. And for FPI, it is the young doctors for sure. And that incepted the beginning of the Spice Route. And Spice Route is that for the Young Doctors Organization for the South Asia, and for India too. This Spice Route is having a good chapter, and since last 2 years it is rolling on in a big fashion. And this is our big leaders for the Spice Route in India. That is our own Serin, Dr. Serin Kyriakos is the chair of the Spice Route. Dr. Jyotika from Bangalore and Dr. Kailas, who is here, is the FM 360 coordinator, and Dr. Jyotika is the secretary for the organization. And what is this Spice Route, and who is a young family doctor? According to the definition by Wonka, the young family doctor is who is the PG in family medicine, or who has completed 5 years in family medicine practice. Within 5 years of family medicine practice is considered as a young doctor. And there are a lot of young doctor movements in the World Family Doctor Organization under in each and every corner of the world and every continent. They are having in either in Asia or some other continent in different names, like our Spice Route, AFRIVON, Polaris, Vasco da Gama movement, and lot others are there. And our Spice Route movement actually started in 2010. That is first chaired by our present AFPI President, Dr. Raman Kumar. And we have a beautiful logo, which is designed by the great Dr. Remnik Parikh sir. And the first conference was held in 2011. This is the structure of the Spice Route. That is, we are having a regional chair and office bearers for South Asia, which is again coming to our country. We are having national chair, secretary, 360 FM coordinator, as already told. And we are having, each state is having a state council headed by a state lead. And almost every state is now having a state leads, and most of the states having state council members. The objectives of the Spice Route, as you all know, it is to improve the education and training of young family doctors, to increase the opportunities and skills for publishing, research, and presentations in national and international fora and also for exchanges. And it's also a platform for young family doctors to share their concerns, doubts, and aspirations, and helping them each other, and also to encourage them to become future leaders. And as you all know, since last 2 years, we are having much of the activities like CPD programs, conferences, pre-conferences, Spice Route Cafe, which is an informal one, workshops, background researches are going on, social media activities. Due to COVID situation, since last 2 years, we don't have much of an exchange programs, but micro exchange programs and some online virtual exchange programs happen during COVID times. And these are the state coordinators for Spice Route India who are heading the stage, and we will be having new names coming in the list soon, and we'll be coming up with much more activities from Spice Route in coming months. And we have a good editorial team who are coming up with good newsletters since last 2 years. We have a good tech team. We have a web designer, that's our own chair, Dr. Serin Kyriakos. And that last Spice Route was installed during our last state conference at Vadagara. And Dr. Serin has installed as the national chair, and Dr. Kailas from our own state as FM 360 coordinator. Then started our events since last 2 years. We are having most of the activities through online, because you all know in between we got some non-virtual meetings too. This is our South Asia chair, Dr. Sangha from Sri Lanka, visiting Bengaluru, Kochi and Thrissur. And we have a lot of webinars. We have a lot of cafes, informal sessions to engage the residents. And this is our Spice Route website. You can all visit and have a look at it. We have beautiful and wonderful leaders in the national and state levels. Lot of activities are coming up. And among the activities, one is we used to introduce our members from various states and various institutes to the world by putting up a program like Member of the Week, and we used to introduce the Spice Route members to the family medicine world. This is again Dr. Mamda is FM 360 coordinator from our state, who is senior resident at Calicut Medical College. And in Kerala, we have also a state secretary for Spice Route, Dr. Ali Zamil from Metra Hospital. There were a lot of lockdown events, lockdown meetings were there, followed by academic sessions. Since last 4 or 5 months, due to COVID situation, everyone were busy and we couldn't have much of the academic sessions. Now we are planning to restart the activities. Meanwhile, the Omicron is surging up. Once the Omicron settles a little bit, we will be coming up with more and more activities, and the Spice Route will be taking AFPI to new heights. I hope all the new residents or all the residents who are not part of the Spice Route till now, please engage with our activities. Please come forward, and we will feel the true spirit of being together. Okay, thank you, AFPICON Kerala for giving this opportunity. I think we'll be having a good conference this time too. Thank you all.
Thank you, Dr. Nadeem, for enlightening us about the Spice Route. Thus, we come to the conclusion of day 1 of our virtual AFPICON Kerala 2022. Tomorrow, 9th January, we have our main conference, and the registrations will start at 8:30 a.m. Poster presentation starts at 9 a.m. sharp. There is a wide range of interesting topic presentations, including panel discussion tomorrow. So make sure that you attend the same. Once again, thanks all chairs, speakers, and attendees for attending the session. Thank you and good night.
Thank you, everyone. So can I end the meeting with your permission?
Yes.
Thank you. So I'm ending this meeting. Thank you.